occurrence in corrosive strictures with alkali especially, balloon dilatation, SEMS placement, higher reinterventional rate and migration, and gastrojejunostomy, which is now done by EUS, was reported in 199 patients with different type of strictures, not entirely for the benign strictures, but in one study the success rate was about 92%. Refractory strictures by definition are those which you cannot successfully remediate to a diameter of 14 millimeter over 5 sessions in 2 weeks. That's the definition given by the British Society. An inability to maintain 14 millimeter diameter for 4 weeks. The simple small strictures are 2 centimeter and less. Complex strictures are 2 centimeter angulated and narrow. And rule is that use 3 traditional bourgeonnage in terms of increment of their diameter. And for balloon, 1 to 1.5 millimeter increment, and balloon have 3 sizes, mostly the TTS balloons. And duration should be 1 minute. The goal is to maintain 15 millimeter and symptomatic improvement. In 70 patients of refractory stricture reported by REPICI, 10% were of corrosive, and of these, stents were used in 34% metallic or biodegradable. Dilatation with steroid injection was 46%, mean follow-up was 43.9 months, and clinical resolution was 31%. Surgery was required in 8 patients, 11%, and PEG and PEJ, 8.6%. Serious complications of perforation, 4%, fistula, 6%, and there were 12 deaths. And 12 deaths, out of those were 2.9% were stricture related. Most of these were aspiration complications from other reasons as well. What is the incisional therapy for tight strictures? Needle knife sphincterotome can be used for short strictures, which can be, they're very useful for Shasky's ring and others, but for short strictures one can use the needle knife, and they were in a randomized study of 62 patients with a primary anastomosis stricture. These were not the corrosive strictures because the data is scanned for corrosive strictures. They did find that it was as good as the dilatation. The corrosive strictures are difficult to treat with the needle knife or with the TT knife because there is not much space to inject and create a submucosal space, and therefore they're very hard to deal with this kind of therapy, incisional therapy. This is incisional therapy, how you do it with the cap on, and then you incise the stricture, and the lower one is a very tight stricture and ultimately was dilated to a very significant degree. And ultimately surgery is an option which should be for those strictures which are recalcitrant and they are not amenable to dilatations or sustained dilatations, gastric pull-up, and colonic interposition. With this, Mr. Chairman, corrosive strictures often cause lifelong morbidity. All preventive measures and cautions should be taken to prevent this from happening. Corrosive agents should be kept out of reach of children and never placed in other containers. Danger labels should be well marked and well marked on those containers. Refractory strictures should be referred to centers handling them to prevent complications, and newer treatment modalities need larger studies for efficacy and safety. Thank you very much for your kind listening.
We'll take the questions at the end of the session. Thank you, sir, for a very elaborate lecture on managing corrosive strictures. Moving on to the next lecture of the day, As an endoscopist, whenever you encounter a subepithelial lesion, there are two questions. What is the lesion and what needs to be done? Now, Dr. Parith will talk about endoscopic management of subepithelial lesions. Dr. Parith has joined us from Bangkok, Thailand. He is Associate Professor of Medicine in Advanced Endoscopic Excellence Center. Do you have any questions from the last lecture? There's a mic over there.
Questions?
I have a question.
Yes, please. Yeah.
Yes, sir.
Do you have any experience with boogie gap dilators? Bougie gap dilators.
इसमें question?
Bougie gap.
Yeah.
Which is what? Bougie gap dilator. Does anybody know what they are? Bougie gap.
Data mainly from the German group where they've used again, but I think the experience in the West is very different from the experience in the East, and the type of the stricture that we see in this part of the world are totally different. So I don't believe those are of much benefit in patients with corrosive strictures.
Yeah, I think, for a corrosive stricture which are long, tortuous, you need a guide wire to, go through it. And then I feel like that the savory dilators are perhaps the most for adequate dilatation are the safer, because balloon dilators, you have to put the balloon in all different places, and it doesn't give you a good feel of how much you're dilating. It's more of an art than than medicine, because you need to learn how much force to to dilate, to use the dilator, and where to stop. It's very important to know where to stop, because you don't want to cause a damage and cause serious problems.
So I think that is a very important point which Professor Saab has just made. Is the safety is the key, and I don't think we can achieve that with those bougie dilators.
Yeah. Sir, I have a few questions.
We'll take rest of the questions at the end of the session. We're moving on to the last lecture of the session because we're having problem with the second one. So now Dr. Saleh is going to talk about managing anticoagulation and antiplatelets in endotherapy. Dr. Saleh is consultant gastroenterologist and hepatologist at Shifa Hospital, Islamabad. Sorry.
Thank you for nice introductions, and I'm really honored and indebted to the organizer and scientific committee, specifically Professor Ayasun Nabi Tayyib and our friend Israr. So we will be talking in the next 20 minutes or so managing anticoagulation and antiplatelets in endoscopy. No disclosures, however, my presentation is mainly based on the ESG, EBSG combined guidelines as well as by the ACG and the CAG guidelines 2022. So before we move on, so this is a dilemma that when these patients either presents with hemorrhage or they are requiring an endoscopy, whether to stop or continue. If you stop, there is a risk of thrombosis, and if you continue, then there is the risk of hemorrhage. So before we move on to that part, let's see that what are the low and high risk endoscopy procedures. So the low risk procedures are those who are like which are these diagnostic endoscopy with or without biopsies, including both upper and lower GI, and then of course without sphincterotomy, biliary stenting, EUS without sampling or other interventional therapy. And they also, the ESG also includes the esophageal and enteral and colonic stenting. However, the high-risk procedure, we all know that those are all those therapeutic interventional procedures we require cutting, dilatations, and polypectomies, ESTs, EMR, and sampling or doing other procedure, therapeutic procedures through the endoscopic ultrasound guidance. Now, let's define what a significant hemorrhage is if it occurs. So it's a drop of hemoglobin of up to 2 grams or more, and or requiring blood transfusions or requiring an unplanned hospital admission. And this may be apparent during the procedure or may occur later, even up to 2 weeks. So one also should have some patient considerations in these conditions, that whether your patient is at high risk for thromboembolism or low risk for thromboembolism. So patients with low risk of thromboembolisms are non-prosthetic heart valves, atrial fibrillation without high risk factors, that is the CHAD score of less than 4, or patient who had a venous thromboembolism more than 3 months ago. While the rest of the conditions, which includes prosthetic heart valves with or without atrial fibrillation, or atrial fibrillation with mitral stenosis, or atrial fibrillations without valvular heart disease but with high risk factors, which had more than 4, and atrial fibrillations with CVA or TIA in the last 3 months, or recent venous thromboembolism, or if the INR is, even if the embolism has occurred on the therapeutic or range of INR. So what happens if the patient presents to you with an acute upper GI hemorrhage? We all know that aspirin should be continued even if the patient presents to you with a GI hemorrhage, and the risk of thrombosis versus hemorrhage must be considered if you are thinking of stopping or holding on to the aspirin. And of course, if the patient has got a primary prophylaxis use of aspirin, one may think of stopping it permanently. However, if it is for secondary prophylaxis, please continue with it. If you are stopping it, or if you have stopped it, then restart it as the hemostasis is achieved. For dual antiplatelet therapy in acute GI hemorrhage, these should be continued if possible in patients who have coronary stents in situ, and of course you talk to your cardiologist as well. In major hemorrhage, continue aspirin, and you may stop P2Y12 receptor antagonists like clopidogrel, prasugrel, etc. And these therapies should be restarted if you stopped it within 5 days if indicated properly. For qualitative dysfunctions of platelets, do not use platelets concentrates, do not transfuse platelets. However, if the patients, the platelets are deficient quantitatively, on case-by-case basis, one may transfuse platelets. Now, oral anticoagulants in GI hemorrhage, acute GI hemorrhage, so withhold oral anticoagulants and correct coagulopathy as per severity of the hemorrhage and patient thrombotic risk in coordinations with either hematologist or a cardiologist. And the correction of coagulopathy should not delay the endoscopy. That if you've decided for endoscopy, it's safe to go for endoscopy, proceed with it. Do not document that whether the things are under control or not, or you have corrected the coagulopathy properly. There is a little bit of disagreement between the two guidelines from the ESG, BSG combined guidelines and the CAG and ACG guidelines. The ESGE says if in a patient with hemodynamic instability on vitamin K antagonist, administer 4 factors prothrombin complex or give FFPs. While as there is less amount of or less data is available to us, the ACG did not reach an agreement whether to use vitamin K or FFPs in these patients. And FFPs may be given in life-threatening condition or when the INR is supratherapeutic range, and it's a conditional recommendations. They also say that the prothrombin complex and FFPs are equal. However, they could not reach an agreement to recommend in favor or against the use of these. The oral anticoagulants, the directly acting one these days, the directly acting oral anticoagulants, the ESGE BSG says that give the monoclonal antibodies for the bigatrin or use andexanet or prothrombin complex for the prasugrel or clopidogrel, while the American College of Gastroenterology and CAG, they did not reach an agreement on the use of it. Now, when to restart these oral anticoagulants? Restart anticoagulation following acute GI hemorrhage in patients with an indications for the long-term anticoagulation. Patients with low thrombotic risk, restart anticoagulations after 7 days but before 30 days and do not delay beyond 30 days. While patients who are at high risk for thromboembolic phenomena, early resumption of anticoagulation is required, that is start within 3 days, and you may bridge with low molecular weight heparin or unfractionated heparin. Now we move on to the routine elective procedures, and we know that antiplatelets, how do we do about the antiplatelets in the low risk procedure, and we know what are the low risk procedures are, and these antiplatelets, we already talked about that aspirin can be continuous in all these patients, but what about the clopidogrel, prasugrel, or ticagrelor? Continue these therapies for low risk procedures. For high risk procedures, now they are divided into 2 categories. One is the low risk condition for thromboembolism, and the other one is high risk for thromboembolism. So for low risk thromboembolism, which means that these are cerebrovascular or cardiovascular diseases or peripheral vascular diseases without stents in situ, then stop clopidogrel 7 days before endoscopy and continue aspirin if already prescribed. Restart these medication after 1 to 2 days of the procedure for low risk of thromboembolic conditions. For high risk, there's all those patients who have got stents in situ. Then there are 2 categories. One, if they have got bare metal stents, then, and if they are beyond 1 month, you may stop it. But if they have got drug-eluting stents, then the 6 to 12 months are required before you stop these. However, with the 3rd generation drug-eluting stents, these therapies may be stopped even earlier. Of course, you continue with aspirin. Now then, the low-risk procedures, elective procedures, what about the warfarin? So continue with warfarin and check INR 1 week before the procedure and make sure that the INR is well within the therapeutic range. Then for directly acting oral anticoagulants, these just omit the morning dose, whether you are using the single daily dose or twice daily dose. So on the day of the procedure, do not give it. These are low risk procedures. Now oral anticoagulants in high risk procedures, and we know what are the high-risk procedures, all those where you perform some therapeutic procedures. So for warfarin, again, we divide them into two, the low-risk condition for thromboembolism or the high risk. For low risk, which means that the patients are having AF without other risk factors, or had venous thromboembolism more than 3 months, or have got non-prosthetic valves, then stop warfarin 5 days before the endoscopy and check INR before the procedure, and it should be less than 1.5 for all these high-risk procedures. And then restart warfarin in the evening, and then of course you recheck INR after 5 to 7 days. So high-risk procedure, but high-risk condition, and we know that all high-risk conditions for thromboembolism are all patients with prosthetic heart valves, or mitral valve diseases with AF, or prosthetic valve disease with AF, or AF without valvular disease but at high risk for thromboembolism, and then if somebody has AF with TIA or strokes, or had a VTE within the 3 months. So you stop warfarin 5 days before the procedure, start these patients after 2 days on low molecular weight heparin, omit the morning dose of on the day of the procedure of low molecular weight heparin, and then restart warfarin on the evening of the procedure, and of course you bridge or overlap with low molecular weight heparin till you achieve the therapeutic INR. What about DOACs? It's a bit simple that that you omit the morning dose of these procedures. If you stop them 3 to 5 days before the procedures, but if your patient has got a low creatinine clearance, of course the dabigatran is not allowed less than 30 ml of the eGFR. But if it's 30 to 50, then you stop 5 days before the procedures, and you need to work with your hematologist or the cardiologist, and restart these DOACs 2 to 3 days after the procedure. Some elective procedure quickly: do not stop aspirin or P2Y12 receptor antagonist in diagnostic endoscopy, and continue with DOACs, but only may omit the morning dose of these. EBO, which seems simpler but still has got a hemorrhage risk of 3.5% due to slippage of the bands or post-band ulcers. So low molecular weight heparin showed no increase in the post-procedural hemorrhage or reduction in survival compared to those who were not on low molecular weight heparin. Because these questions do occur, because we use them sometimes in these patients who have got portal vein thrombosis and all that. So you can continue these patients on these. And the retrospective data on DOACs have shown higher bleeding rates for patients on DOACs or warfarin. However, we know that the bleeding risk of these patients may be higher, but the expert recommend the continuation of their use. Endoscopic polypectomy, we know the rate of the bleeding, the post-polypectomy bleeding is somewhere up to 2% or so, and the risk factors for all these are polyp size, the use of pure cutting current, and you modify your techniques. Sometimes you use your endoscopic clips or submucosal injection, and which helps in maintaining or achieving the hemostasis. The use of clips is a little tricky. While it reduces the risk of hemorrhage, but it increases the risk of perforation due to thermal injuries while you are cutting close to it. Endoscopic polypectomy and aspirin monotherapy has been found to be safe during polypectomy, and the P2Y12 receptor antagonist may continue or switch to aspirin if the polyp is less than 1 centimeter. Further data is needed on dual antiplatelet therapy. We do not have good data to support that, and cold snaring is preferred to minimize post polypectomy bleed in the smaller polyps. And you also know if bleeding occurs, you can deal there and then. ERCP, we know the risk of hemorrhage is around 1 to 2% or 1.3%, and 1/3 of these patients can be very severe. And we also know the factors for these: the low experience, intraprocedural bleed, if the patient has got CKD or had dialysis, low platelet counts, and anticoagulation intake. Aspirin can be continued, and it's safe, or the endoscopic sphincterotomy can be safely performed. in these patients as the risk is low. Intra-procedure measure may be taken, or modifications are suggested that you may do only balloon dilatation for smaller stone retrievals. And there are no data to say whether one should continue or stop these medications, and if you are doing cholangioscopy or lithotripsy. DOACs, vitamin K antagonist, better substitute with the low molecular weight heparin or unfractionated heparin. Endoscopic stenting. Well, stenting seems at all sites be a low-risk procedure for hemorrhage within 7 days, but there is no data is available, and the risk of delayed bleeding is there. So caution may be taken, though we use stenting even at time to stop these bleeding. The PEG insertion, the overall risk of the PEG placement related hemorrhage is around 1.5%, and a meta-analysis showed continuing antiplatelets therapy such as clopidogrel, it may be saved. And a large retrospective data from the Europe shows that the PEG and warfarin has got a little higher risk of bleeding, it's around 2%, while under VAX is probably the same. So we conclude by with these take-home messages that aspirin is better continued in all endoscopic procedures. Low-risk procedure and patients with low risk of thromboembolism continue with the P2Y12 receptor antagonist, or alone or as a dual therapy. Low-risk procedures continue warfarin. Make sure INR is well within therapeutic range. Low-risk procedure continue DOACs, may omit the morning dose. High-risk procedure, but patients with low risk of thromboembolism. Discontinue P2Y12 inhibitor, sorry for the typo, receptor antagonist for 7 days. And high-risk procedures, but low risk for thromboembolism, and patients on dual antiplatelet therapy, discontinue continue with aspirin and discontinue with the other antiplatelets like prasugrel or clopidogrel. High-risk procedures with patients with in patients with low risk for thromboembolism, discontinue warfarin 5 days before the procedure and make sure that the INR is less than 1.5. High-risk procedures and in high-risk patients for thromboembolism, continue aspirin. Liaise with cardiologist before discontinuing P2Y12 receptor antagonist. High-risk procedures and in high-risk patient for thromboembolism, discontinue warfarin, substitute or bridge with low molecular weight heparin. High-risk procedures in patients on DOACs, the last dose of DOACs be taken 3 days before the procedure. Care should be taken in dabigatran specifically if the eGFR is low. Post-procedure antiplatelets and anticoagulation therapy be resumed in all these patients who have got high-risk procedure, but they are at high risk for thromboembolism in 2 to 3 days. Make sure that telling your patient that all these patients who are antiplatelets and anticoagulants are at increased risk of post-procedure hemorrhage, and this message should be the last one from my side. Thank you all for your kind listening.
Bleeding gastric varices is a nightmare for most of the endoscopists. We've already talked about managing endoscopic management of gastric varices. Now Dr. Nadeem Tehami will talk about treatment of gastric varices, EUS and beyond. Dr. Tehami is consultant in hepatology and pancreatobiliary medicine, University Hospital, Southampton, UK.
Thank you, Farwa. Thank you very much. Honestly, it's really good to be back. I'm really excited, and thank you for inviting us. Can I have my talk, please? Haji, I've got my talk. It should be, where is it? So let's see if you can find it. So my talk is not limited to just the endoscopic management. I'll try to give you an holistic view. I am a hepatologist, and I'm kind of one of my a different breed. I enjoy doing lots of endoscopies. Majority of hepatologists up and down, well, at least in the part of the world I work in, don't do a lot of endoscopy. I had my talk with you. So what I was going to talk about is the management of EUS or gastric varices from endoscopic perspective, and also what other modalities we have available in this day and age. We've had 2 fantastic days before today's session, and we had a session where Dr. Hassan beautifully demonstrated with Dr. Arain the EUS injection of coils and glue. So if you were there, then you must have seen the key principles, which is just a part of the talk that I was going to discuss with you. Can you? Brilliant, thank you. So apologies about the delay. So this tells us how much dependent we are on technology these days. So just happens if we are not allowed to use our phones for the next 24 hours. I guess majority of us are going to struggle. At least I live and breathe social media, so it's going to be incredibly difficult for me. That is brilliant, excellent. That's fine, it should work. That's brilliant, so that's who I am. So as I said, I'll try to focus on this beyond bit here, rather than just talking about it. I've got no disclosures, and so the objective for next sort of 15-20 minutes is just concentrate on what we can achieve by doing EUS, and what are some other avenues that we can explore going forward. And one of those is this concept of endohepatology. But we'll also kind of discuss something which you already know very well. It's not an easy task, because there are lots of domains that you are overstepping. So in the domains of interventional radiology, sometimes surgery, and sometimes people who have pure interest in hepatology. So let me begin by sharing this case which we had seen last year, who had presented with, he was quite an unwell man. He was 40, had alcohol-induced pancreatitis, and then developed a complication, as we would see with in form of a pancreatic fluid collection and splenic vein thrombosis. He had an endoscopy at the time because there was a question about anticoagulation, and there were no obvious varices. He presented 3 months later with a bleed, and on this occasion, when he had endoscopy, there was an actively bleeding gastric varices was seen. On the CTA, it just showed previously seen pancreatic fluid collection and splenic vein thrombosis. So obviously the question comes in mind, how are we going to manage this patient? Now there are different options which we will try to sort of look at individually. But I guess in this case, the appropriate option at the time that we chose was glue injection and followed by cyst gastrostomy. So you've all seen gastric varices, esophageal varices. We are in a part of the world where unfortunately we see a great burden of the liver disease. But we know it's not the gastric varices where we see majority of the problem is the esophageal varices. But when these patients bleed, they bleed with a high mortality. And you're also aware there are different classifications. The one we mostly rely is on serine. Professor Anwar Khan earlier alluded to sort of different sort of types, especially GOV1 and 2, and in terms of the management, how these should be approached. But what I wanted to show you is this image. So if there's an image that I want you to take away from this, is this image. What I shown you earlier is something you see a lot, but what we don't see is this. Do we really try to understand what is the actual burden of portal hypertension underneath? The reason I wanted to show this slide to you is because mostly when we are looking at the varices or gastric or esophageal varices, we are literally just looking at the tip of an iceberg. And if we see this, where are we going to really target our treatment? Can we justifiably choose one option over the other? I don't believe we can. And so what is the actual problem? So the actual problem is the underlying portal hypertension. Remember, it's very easy to offer any form of endoscopic treatment. What is not easy is to treat this underlying monster of portal hypertension. So we see a lot of patients with cirrhosis. We tend not to worry about them unless and until they have portal hypertension, because we know it is a group of patients who have portal hypertension who then end up developing problems. So not every cirrhotic develops problem. What we do need to understand that we are not alone. We don't work in silos. We work with colleagues from interventional radiology when our endoscopy treatment doesn't work. Surgeons are also there to help us and rescue us when we need them. We then also need our colleagues from hematology to guide our treatment, and sometimes we do need our colleagues from intensive care to support the management of these patients. So it's essentially a multi-modality treatment. The problem here is that it's when we are offering an endoscopic treatment, we are limited in number of ways, and few pitfalls are, as we earlier discussed, that when you go put your scope in and all you see is blood. So your vision is, or your field of view is significantly compromised. Then if we end up injecting those patients, then what you see is this kind of picture later on with those real glue embolization, which can be a disaster. If we have managed to see a varix, glued it, patients may have a bit of a glue embolization, didn't come to any clinical harm, but then there's a high risk of these patients coming back with a further bleed. So that's where the real problem is. So when we consider the EUS-guided approach, and the reason we say it's better, as we sort of alluded earlier this morning, is that you can look or try to at least find the perforating feeding puncture, because then you can puncture that vessels and then you can just target your treatment. So you don't have to use that much amount of glue, which you may end up using when you're just using endoscopic treatment. So that is where the advantage is. And the other way is that you can either go just with either using one of those glue, or you can use those coils, use them either packing coils, or you can use them as a scaffolding coil. So you put the coils in followed by a glue, and then that just acts, those coils acts like a scaffolding. Sometimes you can also use a combination of method. And this video, which obviously there are different ways where you can do the procedure. The way we prefer to do is that after identifying a perforating feeding vessel, what we then want to do is we just want to inject a contrast, and then we use it under fluoroscopy. And the reason we do that is because we then want to find a flow. Because, I mean, sometimes it can be scary when you see just a gush of the flow disappearing completely. That tells you that if I inject it, my glue is going to go everywhere. Just reaffirms your faith in using the coils, that by using the coils, you're much better achieving your goal of obliterating the vessel without really spreading the glue. So there is certainly an advantage of this technique where you inject the contrast, try to see where the flow is, somewhat similar to what our colleagues in IR do. And there the advantage is that you can then target your treatment. And then you can follow this with the further a Doppler window and seeing if you have been successfully able to obliterate it. Now the options are, you can, as I said, you can either use the glue alone or you can go with a combination. So if you're starting to look at the data, I think the data overwhelmingly supports that it's the combination of the treatment which works better. So the approach of just using coils and packing a varix or using glue certainly is not as effective as using a combination of coil with the cyanoacrylate glue. Now, there are certain things which obviously you learn from colleagues, having seen Dr. Hassan, Dr. Rain demonstrating this, and obviously the experience we have from other colleagues. So the way we would prefer to do it, we do it in endoscopy suite. We want our fluoroscopy, we want our anesthetist with us. As again, Dr. Hassan was earlier mentioning, when you see that chunky varix, you really want to make sure you think ahead of the time. You're not only thinking of the technical bit, because we have to engage this as well, rather than just focusing on our sort of technical skills. So that is important. You do want to just ensure that because of that, the bacterial overload, you want to prevent that patient becoming septic later on. And then you puncture the vessel, and as I said, in our practice, we tend to see if we can just inject the contrast and see it. Another important point is, again, I think it was beautifully demonstrated if you witnessed Dr. Hassan doing it, that he basically measured the actual feeding varix and then aimed for a coil which was at least 1.5 times the actual length of the feeding vessel. The length should be enough that you, when you see that perforating vessel going through the muscular layer, that you're able to create a thick mesh so that the bunch of the varix that you're seeing essentially disappears once you have deployed the varix. And then one of the other important thing is that you may not see, so one of the problems I had in the initial days of learning EUS is because we are used to seeing those colored images, and with the EUS is completely the other side. So you then have to really focus and just forget about the endoscopic image, and then focus on what you see on that black and white image, and then not try to move your scope very much, because if you do so, then you may end up puncturing the actual varix and causing more trauma and bleed than you would really want to do that. And the pitfalls that I mentioned about the endoscopic image remains, but as I said, the advantage is if you've got a patient who's actively bleeding and you cannot see much through your scope, at least you can still see where the problem is by using your EUS probe. It does require that you need to have expertise, you need to have EUS facilities and IR backup available. Yes, you still have to sort of worry about the possibility of the glue embolization and the importance of finding the perforating vessel, which is not easy. Now, coming back to what I was sort of alluding to earlier, that the underlying problem here is the portal hypertension. And we know this is a stage where we really have to worry about these patients, because this is where our patients are then going to develop problems. They end up developing decompensation, cancer, and then we end up running into problems thinking about how we're going to best manage them, transplant. So essentially it's a minefield. So you really have to try to focus on portal hypertension right from the beginning, because this is what actually determines the prognosis of your patient. The problem we have is, and in fact when I say we, is the entire world, is that we have relied for far too long on an indirect measurement, which is the HVPG. It is not a direct measurement. We're only measuring pressure from the hepatic veins, and then we are measuring pressure after inflating balloon and a reflective pressure from the sinusoids, which does not really tell you the true pressure in the portal vein if a patient has a pre-sinusoidal or pre-hepatic portal hypertension. The beast in the world of the hepatology is NAFL, and there's enough data out there which tells us that the NAFL-related cirrhosis, when you measure the HVPG, it does not truly reflect the actual underlying portal hypertension. So whatever we have, we still don't use it. I don't think many of us have it widely available to our practice, which is what we should be using to guide our treatment. Now, as a hepatologist, I mean, we like non-invasive approach, which is completely understandable. But that approach only works in a group of patients who are either have no evidence of clinically significant portal hypertension, or those who actually have a significant portal hypertension, where they've got a large spleen, they've got a low platelet count, or completely the opposite of the spectrum. What about those who are actually in the middle of it? So the case we had in the workshop was a young boy who had F4 fibrosis on the fibroscan, and we were worried about him, that he may have an advanced hepatic fibrosis. His spleen was borderline enlarged. It was 13 centimeters. Platelet count was normal. So where do we go for this? How are we really going to manage this patient? That is where the direct measurement of the portal pressure really makes the difference. Now, what we already know is that in terms of something which is commonly available to us, and that is using those non-selective beta blockers in our patients with a portal hypertension, trying to treat that, that the whole iceberg is by using those non-selective beta blockers. We want to use them in patients who have compensated cirrhosis with clinically significant portal hypertension to prevent decompensation. We can use it either as a primary or secondary prevention, and we should start them as soon as we know about them. Now, I mean, I wouldn't go into the details why carvedilol is preferred over propranolol, but it's important to use them and then actually try to monitor your patient. So this is another problem we have, is when you see with somebody with systemic hypertension, you start them on a treatment, and then you don't say just go away. You say, can you go to your local GP, make sure you have your blood pressure monitored? Whereas the portal hypertension, which is going to cause a lot of problem, we never go back and measure it. We just put them on non-selective beta blockers and say, bye-bye. But that is not where we should be heading. So coming back to, as I was mentioning, so with the portal pressure gradient, using HVPG, going through the neck veins, using fluoroscopy, using contrast, you're measuring pressure from the free hepatic veins, and then we are measuring pressure through the sinusoid by inflating the balloons. Where the EUS axis is, it's much easier. You can go into the hepatic veins, you can go into the portal vein, you can actually measure the pressure, and then just subtract it. So it isn't a major science at all. Now, I'm going to introduce you to a concept, and I think we are very fortunate that we are introducing a concept which has not been mentioned in the literature before. So we are all lucky who are in this roof that I'm sharing something which I believe is my brainchild, which I believe is a term which has never been used in the medical literature before, and I'm going to use it today here. So you see a patient with blood pressure of 160 systolic compared to somebody who's got a blood pressure of 220. Now the one who's got a blood pressure of 220 systolic, I guess you're going to be more worried about the one with 220 or the one who's got a blood pressure of 140 and 180. They both need treatment, but the one who's got a blood pressure of 220, he's the one you want to look for the end organ damage when you're looking at these patients. Likewise, when you're seeing somebody when we call they've got a clinically significant portal hypertension, is it 12? Is it 28? Which one are we concerned about? Do we really know? So why am I stressing about so much? It's because if this data, which is obviously based on some hard fact evidences, that higher the pressure, higher the chance of them then not responding to the medical endoscopic treatment, medical treatment, IR, you have to consider IR treatment, and this is a group of patients where they're going to develop problems including hepatomas. So you have to try to differentiate who has a normal portal hypertension or those who have malignant portal hypertension. So this is a term which is not being used in the medical literature. This is the term which is being used for the first time in Pakistan Society of Gastroenterology 39th meeting, and that is a term which I'm sure you will see in the medical literature coming forward. So all those young brains who are here, mark this moment that you will see this term going forward, malignant portal hypertension. So we have to try to see somebody who's got a blood pressure of 140 compared to somebody who's got a systemic blood pressure of 220. Likewise, portal hypertension of 12 compared to 22. So please bear this in mind. Now, why is that important? Because we want all to offer our patients what we call individualized care, that you really want to see which patient, do I really need to bring this patient back every 6 months, do ultrasound scans, do AFP, or do I need to just discharge this patient? Yes, they had a fibroscan of sort of 15, 16 pre-HCV treatment, but afterwards it has come down. But does this patient's portal hypertension disappear, or does he still have it? Do I need to scan him every 6 months? Do I need to scan him every 12 months? Or do I need to scan him 3 months? That's where your portal hypertension is going to guide you. Also, if you see a patient at 5 o'clock on Friday evening, somebody calls, I've got a patient who's got a very still bleed, can you come and scope him? If you know this patient's got a portal pressure of about 20, 25, you're going to say, no, look, I'm not coming, you need to get IR in. You need to do not want to waste time in this situation. So that is incredibly important. Now I can go in a lot of details and try to explain why portal pressure gradient is important than the HVPG, but as already alluded to, patient with pre-sinusoidal, pre-hepatic pressure, your HVPG does not work. You do need IR, you do need fluoroscopy, a lot of things you can easily avoid by just going down the route of EUSPG. Now, again, this slide, again, you all know in settings where this HVPG does not work, and we know that's where EUSPPG can help. Now, the problem is that, I'll come to it, so the way we are using currently is for those patients where we believe these patients have no clear signs to put them either into one bracket or the other bracket, that is clinical significant portal hypertension, yes or no. That is a group, if they need to have any major resection, that is a group we send them for measurement of the portal pressure gradient. The problem is that this is a technique where we have proven the safety, we've proven that it works, we know it's efficacious. What we have not proven is that there is enough data out there comparing it with the current gold standard. And I think this is where we lag behind. So people who are clever academic hepatologists who only do hepatology, do not do anything, they're the one who are really keen, and they're the one I'm still struggling to convince. But that's where the problem is, that hopefully this encounter study, which I'm sure colleagues from in their talks later on in the portal hypertension will mention more, is where we will get an answer from. So I've only got a couple of minutes left, and I think I'm not an interventional radiologist, so I probably will not waste any time on sort of intervention radiology techniques and intervention. But what we know is that you need to get them involved as soon as you can. They can find a way if there is a vessel, and then we are all alive if you've got a flow in our vessels. It's just this standard management of these patients. You don't want to pick up a phone and call someone when you've not adequately resuscitated them, assess them, and I think as Ray was earlier mentioning, imaging is crucial. You really want to see what sort of anatomy they have. And if you may recall the image first I showed you, it is a minefield. It's a leash of network which we really don't know what we're doing. So get a scan done, preferably with an arterial phase. We can try to localize this. Now this may not apply only to the very still bleed apply to other bleeds as well, but you can try to identify or localize the source. You can get a bit of a roadmap, how you're going to approach these patients, and it then just helps in managing your patient further by reducing the total time. They can do a lot of things. They can just block the vessels. They can use coils. They can use the same embolization as we were talking about. They can go down the routes of either doing a BRTO, they can do PRTO, percutaneous, or the standard tips. But this just kind of cartoon showing the development of the lienovenal shunts and how they can access it and how can then inflate the balloon and then inject the dye, which is sort of balloon occluded retrograde venous obliteration. So chairpersons, ladies and gentlemen, thank you for your time, and I'm just going to sort of conclude that EOS guided therapy, I know we work in an under-resourced settings, but they are becoming available. You have centers like LGH, you've got other centers where you can refer your patients to for an effective management. And I'm sure time will prove that this management is cost effective. We should think about these things not only as a secondary prevention, but also as a primary prevention, especially when they've got a significant burden of underlying disease. Thank you very much for listening.
Thank you, Dr. Tehami, for a very comprehensive lecture on a very difficult topic. Moving on to the next talk of the day, it's endoscopic management of subepithelial lesions by Dr. Parith Mehroon Kamol.
Thank you very much, Dr. Farwell, for the kind introduction. And first of all, I'd like to thank PSG, Professor Gayas, for the kind introduction as well. Well, my name is Parith Mehroon Kamol from Chulalongkorn University, Bangkok, Thailand. I have no disclosure. So my topic today is going to be about endoscopic management of subepithelial lesions. It's something that has been in quite a conundrum for us endoscopists, because these are the things that prevalence is not that rare. We incidentally found these lesions more often and the management guidelines that we have is quite arbitrary at times. These lesions, even though the malignant risk is low, but it's not zero. And endoscopic findings does not always correlate with symptoms and also the diagnostic and prognostic features. So the evolving recommendations that we have now is when to do biopsy. Does it always we need to do an EUS? Does it always need tissue diagnosis? And if we were to need to resect this, what is the best mode of resection? Surgery versus endoscopy. And if we were to do endoscopy, what would be the techniques that we use? And what about after resection, the surveillance protocol that we have to do? Or if not resection, do we need to survey these lesions? So these are the topics that I would like to explore into today within the next 17 minutes. How to diagnose this lesion, how to select the treatment strategy, the surveillance protocol, and what's waiting for us beyond the guidelines that we have now. So let's move on to diagnosing subepithelial lesions. It sometimes can be a challenge because, as we all know, what we see intraluminally is just the tip of the iceberg, and that can be a big lesion underneath in the intramural areas. And what's more of that, that can be something outside in the extraluminal lesions, which has impact on what we would like to do with these lesions. So in order for us to accurately determine the extent of these lesions, endoscopy alone might not be enough. Our adjunct modality includes CT scan and of course the EUS. Versus the two, the CT scan and EUS, the recent data show that the accuracy of EUS is higher than that of CT scan. However, CT scan is still not obsolete. There are still roles for that when lesions are clear-cut on diagnosis, such as lipoma or cystic profunda. Or if the lesion is big, more than 15 millimeters, CT scan still has a good role of evaluating these lesions. The recent ASG guidelines published last year show that the detection rate on CT scan is significantly lower than that of EUS. And EUS has been recommended to be the best tool to characterize subepithelial lesions features. However, it is alone by itself is not enough to distinguish the types of subepithelial lesions. And in lesions, especially when it's smaller than 15 millimeters, its accuracy is less than 50%. So I would like to introduce my approach on what I call a 6S approach from site, size, shape, source, sampling, and symptoms. So let's go over that one by one. Regarding the site, this is something that is a tool that's available for everyone. When we do endoscopy, we can roughly estimate or predict what type of mass can it be. For example, if it's a lesser curve, you might think of this can be extrinsic compression from the segment 2 or 3 of the liver. If it's at the cardia, it can be leiomyoma. If it's at fundus, it can be gastric varices. If it's gastric body, it can be GIST. If it's at the antrum, it can be pancreatic rest or glomus tumor. And keep in mind that lipoma GIST can happen anywhere inside the stomach. Most of the GIST lesions, even though it's in the stomach, but it can also be found in other areas of the GI tract as well. And the malignant risk of such lesion in different areas are different as well. So on the size of the lesion, that's also important for us to know. There are a few number cuts off that I would like you to keep in mind, 1, 2, and 3. If it's more than 1 centimeter and you think that this can be a gastric NEN, bear in mind that this at higher risk of metastasis and it should be removed. If it's less than 1 centimeter, it can be removed endoscopically by EMR. If anything beyond 2 centimeter, it warrants an FNB. It warrants a tissue acquisition. Especially if it's non-ampullary NEN, the risk of metastasis is significantly higher if it's bigger than 2 centimeter. If you suspect any type of subepithelial lesion, especially GIST, if it's bigger than 3 centimeter, it has predictive factors of high malignant risk transformation with more than 80% sensitivity. So these are the lesions that you can argue that needs to be removed. Moving on to the shape portion of the lesion, whether it's inward or outward, the border of the lesion and the characteristic morphology is important. For example, if you see these lesions that you can hardly see the border, they're so irregular, it's so blending in with the surrounding tissues, you have ulceration on tops, these are the lesions that you have to be careful for, that there might be an actual malignant transformation of the subepithelial lesion. As opposed to something like this, that you have a well-defined border, a very characteristic central umbilication, characteristic location at the antrum, so this can be safely diagnosed as pancreatic rest. For the source of the lesions, this is when the EUS comes to play. As we all know that the gastric wall has 5 layers from mucosa to serosa, submucosa, and muscularis propria. And each layer of the origin from the EUS can help us predict what type of lesions can this be. For example, it's coming from 2nd or 4th layer, this is most likely going to be spindle cell tumor such as leiomyoma or GIST, as opposed to something that's coming out from the 3rd layer, might be brunelloma, lipoma, fibroma, or neuroendocrine tumor. How about sampling? Just seeing alone might not be enough for your patient or for you as the treating doctors, right? So is tissue acquisition warranted? And what is the sampling modality of choice? This is something that has been updated in the recent guidelines as we have more data available. For example, when you have someone like this who have a large 2 centimeter submucosal lesions found in ascending colon, but you can clearly see the yellowish hue on the lesion, and when you do a pillow test, it's clearly positive here. This pillow test has more than 95% sensitivity that is most likely this is lipoma. You don't really need to do anything about this lesion. However, lipoma can be also symptomatic. For example, this gentleman who came in with hematochezia, colonoscopy found most likely lipoma-like lesion, pillow sign positive, yellowish hue, but there's an ulceration on top of the lesions. So I can argue that whatever this is, patient has symptoms already, it caused the bleeding, so this needs to come out. Luckily, the stalk of the lesion, the base of the lesion is not that wide, and because this is most likely going to be benign lesion, so you don't need to really dig deep into the wall, so we can just do a regular EMR, a little bit of circumferential ESD at the base, and we can remove 5 centimeter lesions within 5 minutes. So what does ESGE guidelines say? The guidelines stated that to obtain tissue diagnosis in all lesions, if that has feature of GIST, especially if they are bigger than 2 centimeter, or if they have high risk of stigmata, or if the patients require oncologic or surgical resection. As opposed to if you suspect gastric neuroendocrine neoplasm, even if it's less than 2 centimeter, but it's bigger than 1 centimeter, that needs to come out as well, because it has higher risk of malignant transformation and metastasis. So what is the best mode of sampling? The EUS still the master of this, because we are dealing with something that lies underneath the mucosal layer. So if the patient has larger than 2 centimeter, then you go for FNB. And if you have mucosal irregularities, you can also do the mucosal biopsy with targeted biopsy. If the patient has symptoms, like our last case there, you don't really need to do sampling, you just need to resect it, because whatever it is, that needs to come out. If you have a pathognomonic appearance of lesions like lipoma, varices, ectopic pancreas, EUS alone can safely diagnose the lesions without tissue, so you don't have to do a biopsy as well. When you try to do an FNB on lesions less than 1 centimeter that has low diagnostic yield, this is roughly only 50%, and that needs to be discussed with your patients beforehand, that even though you do an FNB, that might not be diagnostic. Sample might not be adequate, and there's also a theoretical risk of tumor seeding, even though this has never been verified in recent publications. So now we have new kids on the block. Now we know that FNB has some limitations, and that is costly and expensive at times. So we can do other modes of sampling that has higher diagnostic yield. And this is something we call mucosal incision assisted biopsy, MIAB. And this has been recognized in multiple guidelines currently. It combines the technique of unroofing. So basically we cut below the mucosa, open the mucosa up, exposing the tumor underneath, and do the direct biopsy. And this is less costly, less time consuming, and also has higher diagnostic yield. So that's why the guideline says that if the lesion is less than 2 centimeter, we go with MIAB. If it's bigger than 2 centimeter, we go with either one, MIAB or EUS FNB. This is how the MIAB is being done. So you do either a tunneling technique or mucosal unroofing, exposing the tumor underneath intramural area, and you do a direct biopsy of this. And this is what we normally do. Sometimes I do lift the lesions before, just to make sure that I don't cut open the capsule of the tumor, and it just expose only the outside of the tumor. And lastly, the symptoms. We touched briefly on this already, that if the patient has symptoms, whether it's bleeding, whether it's pain, whatever it is, this needs to come out. Sometimes we do a biopsy beforehand, just in case if the patients might need neoadjuvant chemotherapy, such as large cysts of bigger than 5 centimeter. So in the summary of diagnostic updates, the guidelines has more recognition on the techniques of the biopsy, especially on EUS and MIAB. So that needs to be incorporated when you encounter such incidental tumor. So I'm not going to switch gear to the selecting treatment strategies of what we do when we find these lesions. So the old guidelines suggest that if something less than 2 centimeter, just leave them alone, just do surveillance. But what if you found this 1.5 centimeter in a 20-year-old patient? Would you do an EUS surveillance every year for the rest of his life? That's not practical, right? Especially nowadays that we have more modalities and that can safely resect these lesions without undergoing surgery. So that's what I'm going to touch base on over the next couple of minutes here. When do we do surveillance endoscopy? When the patient has asymptomatic lesions, and those lesions are most likely benign, such as esophageal subepithelial tumor that is most likely leiomyoma. Something is very, very small, for example, less than 1 centimeter. The old guidelines would say that when you can do surveillance in up to 2 to 3 years. But in the past 5 years, we have more case reports that even the small tumor turns out to be cancer, and you cannot afford to have that one case that might come back and sue you because you said 5 years from now, let's just see each other, and the patient comes back with metastatic cancer. So the current guidelines suggest that no matter how small these are, you need to do a close surveillance in the first time, in the 3 to 6 months, just making sure it doesn't grow, just making sure that it doesn't grow beyond outside the wall. If it's stable in 3 to 6 months, then you can safely increase that interval to 2 to 3 years, 1 to 2 years, or 6 months, depending on the size of the lesion. But the first time, it has to be a close one. So symptoms, if symptoms warrants resection, just don't do surveillance, just needs to come out, just resect it. If you have a clear diagnosis of lipoma, varices, ectopic pancreas, also you don't do surveillance, you just reassure the patient that this is not something that you need to worry about and just leave them be. The current guidelines suggest that to avoid unnecessary follow-ups, for example, someone who's really young and the lesion is really small, you can have an option of resection to discuss with the patient. So what would be the best mode of resection? That depends on the depth, the size, the location, outward growth of the lesions, and of course the patient's preference. Some patients might say that, no way, I'm not gonna, it's not causing any problem, I'm just gonna leave them be. Some patients might say that, oh, I have no idea why I'm gonna keep this thing in my body, I just want this out as soon as possible. So you just have to discuss with your patient and see what is their preference. So these are the research techniques that our group just recently published on. The standard ESD, the modified ESD to unroof the mucosa first, and then enucleate the lesion. You can do a stir technique, especially if it's somewhere at the antrum esophagus. You can do an exposed EFTR, meaning just dig a hole and then just close the hole later on. Or you can do a neo-EFTR, meaning it's closed technique. You don't have a hole, but you can do a full thickness resection. So let me give you some examples of these techniques. So this is also another publications from our group comparing between each modalities of resection site. And that largely depends on how deep the lesion goes. If the lesion is superficial enough, it's from the second layer, third layer, I normally do a standard ESD. That's simple enough, easy enough, that takes less than an hour. But if you have something that's go deep beyond the fourth layer, that's something a little bit more risky. You might have to discuss with the patient, have a surgical backup, or you do aim for full thickness resection, otherwise you're going to leave something inside the patient's body. So I characterize all of my tumors into type A, B, C, depending on the origin of the lesions and if there's an inward or outward growth, because that also helped me decide which techniques I'm going to use. For example, something like this. This is a big enough tumor, 2 centimeter, but you can clearly see this coming out of the second layer of the gastric wall from muscularis mucosae. You have a nice line of submucosal space underneath the mucosa, underneath the lesion. So this can be safely resected by just regular ESD. So we inject the submucosal layer, expose the lesion, just burr a hole, and now you can remove the lesions with keeping the intact muscularis propria. As opposed to something inside the esophagus. If you have something inside the esophagus, even though this is most likely leiomyoma, but if it causes the patient symptoms, or if the patients would like it to come out, you can also do a stir technique, which is similar to POEM technique. So basically you open the mucosa, burr a tunnel inside the submucosal space. You're going through the esophageal wall, and as soon as you get in, you found the lesion, you found the mass arising from the muscularis propria. You can see this mass clearly, tucking in and having a little stalk from the muscularis mucosa. Muscularis propria. And it doesn't matter if you do a full thickness resection here because you are safely doing this inside the submucosal tunnel. You just dig a hole, cut the lesion out, and you close the mucosa afterward. So stir has been proven to have a high R0 resection rate, especially if tumor is less than 4 centimeter. If the tumor is bigger than 4 centimeter, you can still do a stir, but you have you run into a problem of removing the tumor out beyond the upper esophageal sphincter. So you might have to cut it out into pieces before removing beyond the upper esophageal sphincter. This is the ligation-assisted EFTR. So you exposed the lesion first by cutting the mucosa, and then you enucleate the tumor, and then you close the mucosa afterward. Compared between the exposed and non-exposed EFTR, you have the similar complete resection rate, but you have a much higher major adverse events rate if you do an exposed EFTR, meaning that you essentially create a hole. So how can we offset that? So let me give you some example. This is a gentleman who comes in with a screening colonoscopy and incidentally found a 1.5 centimeter lesion in the rectum. So the first thing that you keep in mind is that if the lesion is irregular or not. If you do a PR exam and the lesion is irregular, this can be a prostate cancer. But if it's smooth, it's movable, it's most likely outside of the prostate. So we do an EUS on this one, and you can see that the lesion nicely separate from the prostate is coming from muscularis propria layer. So this is most likely a rectal cyst. Rectal cyst has higher risk of malignancy. So even though this is less than 2 centimeters, this needs to come out as well. So luckily this is at the rectum. It is quite a forgiving area of the GI tract. So what we did is an exposed EFTR. So we just dig a hole, burr into the base of the lesion. So now we kind of cut the whole capsule of the lesions out, and we just close the hole after. So pathology confirmed the cyst. As opposed to this one, who have a 7 centimeter lesion in the stomach, this is quite big enough, but because we suspect of neuroendocrine tumor, the patients decline surgery. So we end up doing a non-exposed tumor enucleation. We peel the mucosa down and remove the lesions after. So now we get a grade 1 well-differentiated gastric NEN with negative margin. This is 5 years out, and patients still have like a normal surveillance protocol. So in my last minute, I'm going to talk about how to remove, compare the techniques of removing this large tumor as opposed to a small tumor. So now we have a small FTRD device that we can essentially remove a small tumor by non-exposed technique. This is how it's being done. We suction the tumor into the cap, and we use an over-the-scope clip to clip the lesions, to clip the base of the lesion first, and then remove the lesions. So this is how it's being performed, and less than 1.5 centimeter lesions can be safely resected within 15 to 20 minutes. This is a recent meta-analysis comparing the FTRD technique from the non-lifting lesions. It's found that it has a high R0 resection rate and a less than 10% of adverse event rates. Comparing between the endoscopic and surgical resection technique, our group found that it has a similar R0 resection rate and also the comparable adverse event rates. So in conclusion, so if you have a subepithelial tumor, anything more than 2 centimeter, anything less than 2 centimeter, you can either go periodic surveillance. If it does increase in size or is bigger than 2 centimeter, you need to get a tissue acquisition. Or if it grows, then you need to remove it. If you cannot get adequate tissue acquisition, you have the second attempt of doing a repeat FNB or doing a different technique. And once you figure out what kind of tumor this is, you have 3 options. 1, you send for surgery. 2, you do surveillance. Or 3, you do endoscopic techniques. Endoscopic resection comprises of ESD, stir EFTR, and exposed and non-exposed FTRD. So emerging data suggests to us that these lesions can be safely diagnosed and managed by endoscopic means, and that requires close surveillance and also expertise in terms of resection site. And I would like to thank you for your attention, and welcome any questions later on. Thank you.
Moving on to the last lecture of this session, it's Bleeding Ulcer Options in Endotherapy by Dr. Waqar Ahmed. Dr. Waqar Ahmed is a consultant gastroenterologist in North Manchester Hospital, United Kingdom.
Thank you very much for your kind introduction, and many thanks indeed to PSG, especially to Professor Gastroenterology Tayyib, Professor Israrul Haq, Tour, and their amazing dream team who have really gone out of the way to organize this conference so well. My topic is bleeding ulcer options in endotherapy. Not quite as high-tech as what Dr. Parit Makaroon just discussed, but it's something which we normally encounter in our day-to-day life. A lot of this has been discussed in our early breakfast meeting, so you may find a bit of repetition there. So it's a common problem. We all, as gastroenterologists, come across GI bleeds. Annual incidence is about 80 to 150 per 100,000 population. And the mortality varies quite a lot, from 2% up to 15%, depending on the setting of the presentation. Because if it's in a dedicated gastroenterology unit, the mortality is obviously much better. If it is not managed properly, then the mortality can be higher. The most common cause of upper GI bleed is due to peptic ulcer disease, and the majority of those is due to duodenal ulcers. It can be associated, as we all know, with NSAID use, which is relatively common these days, H. pylori infection, which can be quite common in certain population groups, and it can be stress-related mucosal disease in the setting of intensive care units, and very rarely Zollinger-Ellison syndrome. There are other causes of upper GI bleed as well, which we are familiar with, and we normally see them from time to time, including erosive esophagitis, duodenitis, which cause about 1/10 of those, varices, which can vary a lot depending on the population studied, Mallory-Weiss tears, and vascular malformation, which does contribute about 5 to 10% of the cases. For any upper GI bleed, the investigation of choice is an upper GI endoscopy. It's highly sensitive and specific for the lesion. You can identify the lesion, locate it, and if possible, you can carry out therapeutic maneuvers. The important thing is to stop the bleeding and prevent recurrence. Early endoscopy within 24 hours is recommended. For variceal bleed, we recommend within 12 hours. There has been a lot of debate on the timing of endoscopies, and we'll discuss that. The way to classify or describe bleeding ulcer is by Forrest classification, and that include on endoscopy, if you find a spurting or a bleeding vessel, it's called class 1A, which can be quite frightening to a lot of the endoscopists. If it's just an oozing blood vessel in an ulcer base, that's class 1B, and a non-bleeding visible vessel is class 2A, which this is a typical description of a spurting vessel. A visible vessel which is not bleeding, and then there is the scenario where there's an adherent class, which is class 2B, and a flat pigmented spot, which is class 2C. An ulcer with a clean base, which normally does not require any treatment, is termed as is class 3C. So you can see those. That's the adherent clot, which was very elegantly demonstrated in the breakfast meeting, where the clot was taken off with the help of a snare. The blood vessel was exposed and treated. This is the one with the pigmented base, and that's an ulcer with a clean base. Normally, to carry out an endoscopy, one has to be well prepared. Usually, one would expect in an acute bleed blood in the stomach. This can be a hazard because it would affect your visibility. It would be a hazard to the patient as well because there's a risk of aspiration of blood and gastric contents. So normally we tend to use a prokinetic agent like erythromycin infusion, 250 milligram before half an hour to an hour before the procedure. It helps in emptying your stomach. Some people tend to carry out a gastric lavage. We do not do that as a routine, and I really question the value of doing it. Allegedly, it's done to clear the blood, but I think it can present hazard in the form of aspiration risk. In spite of these attempts, if you carry out an endoscopy acutely, you might not be able to visualize the site of bleeding or carry out any therapeutic procedure because of the presence of blood and pure visibility. In that case, a second look endoscopy is warranted. Risk stratification of these patients is very important because you can't scope everyone that comes through the door. So the risk stratification is carried out on certain endoscopic, clinical, and laboratory criteria. And certain features like hemodynamic instability, low hemoglobin, active bleeding at the time of endoscopy or at the time of presentation, a large ulcer size, ulcer location, they are all indicators of poor prognosis. There is a standard ROCAL classification in which you, which is very simple. You check the blood pressure, comorbidity factors, and other evidence of bleeding, memory-wise stairs. A ROCAL score of the lower your ROCAL score is, the better is your prognosis. The higher it is, it carries more risk. So it is a measure of predicting the patient outcome. The other one which we commonly use is also Glasgow-Bradford score, which is a bit more extensive than the ROCAL score. And again, you look at various criteria of blood urea, hemoglobin, systolic pressure, and other markers like presence of melena, syncope, and other presenting features. Again, a low, all the good, it just gives you a predictive factor of what's going to come. Now, the whole, usually the debate is whether one should scope immediately or after hemodynamic stability, or what should we do? There is no clear answer to that. Ideally, one should stabilize the patient because immediate endoscopy is not always the answer. One should try and achieve hemodynamic stability, prepare bloods, prepare all the extra blood factors, and but sometimes this is all not possible, because if the patient is actively bleeding, then one has to take a decision and carry out an endoscopy. Now this is going to be a high-risk procedure, and to carry out an endoscopy in an unstable patient is the most challenging procedure that you'll have to perform, and I'm sure a lot of you have done that. Certainly requires an experienced endoscopist, should be fully trained in all modalities of treatment, and you should have good support from endoscopy nurses. They should all be skilled, and the more the merrier. So you need more than 2 endoscopy nurses for that. And also consider the use of therapeutic endoscope, because sometimes when you are carrying out treatment and you got your probe in, whatever probe you use for treatment, you might not have enough space around it for carrying out suction. So it is a special challenge, and you have to think about all the factors that are involved: protected airway, if required, the patient should be intubated if he's actively bleeding, especially that is the case in carrying out endoscopy in a bleeding varices patient. You should follow massive transfusion protocol and get support from your hematologist colleagues and backup of interventional radiologists and upper GI surgeons. Risk of endoscopy, as you all know, there's a risk of pulmonary aspiration, adverse reaction to medication that you use, most commonly sedative. There's the risk of causing a GI perforation, especially if you are carrying out heat treatment, and increasing the risk of bleeding during attempts at hemostasis. The main tools that you have for carrying out treatment are coagulation, which is thermal, and contact and non-contact, sclerotherapy, hemostatic clips, topical therapy, and mechanical therapy. Thermal treatment can be contact or non-contact. Contact ones are heater probe, gold probe, monopolar, bipolar electrocoagulation. Non-contact are used in very limited circumstances like organ plasma coagulation and laser treatment. Most commonly employed treatment in contact probe is the bipolar, multipolar, or the gold probe, which we currently use. And the main advantage of contact probes is that you can actually use tamponade to stop the bleeding or locate the site of bleeding. And then after applying tamponade, it's always good to use electric current to electrocoagulate the bleeding vessel. The only problem with that is there is a risk of causing perforation of the vessel out of the surrounding tissues. And if you cause a perforation of the vessel, it will burst in your face and make the bleeding worse. People talk about monopolar and bipolar probes. With monopolar devices, the current passes through the patient body, and you need a device to earth the accessory. With bipolar devices, the electric current is confined to the tissues between the electrodes and the instrument tip. You don't need a return pad for that. So that's the one that we commonly use. And endoscopist, it's I'm sure you've all used it. It's got a foot pedal which controls the electric current, and also there's a foot pedal for water irrigation. The current passes between the tip of the electrode. This is the typical picture of the gold probe. Sorry, I have to rush through because there's a bit of a limitation of time there, and I'm sure you've seen most of these things. So that's the gold probe that we use. The non-contact one is the argon plasma coagulation, which you currently use. Laser is hardly ever used for this purpose. APC uses the high-frequency monopolar alternating current. You create an atmosphere of argon, which is an inert gas, and electrons flow through that, causing electrocoagulation current. The advantage of APC is that it's the treatment of choice for vascular malformation, and it does not require contact, and you can control the depth of coagulation. Obviously, for argon plasma coagulation, you control the application of energy by controlling the type of current that you use. So it's usually for vascular malformation, we use pulse current. For tumor ablation, you would use forced, and usually precise is used rarely for taking residual polyps out. So generally, in the stomach, you would use 25 to 30 watts of type 2 pulse current. Injection therapy is used in addition to most of these other treatment modalities, and the one that we commonly use is adrenaline, diluted solution. It works to produce tamponade locally in the tissue, and to an extent may cause some vasoconstriction. I tend to use it in actively bleeding patients because if the visibility is poor, injection of adrenaline will slow down the bleeding and clear up your visibility. Sometimes, rarely, we use sclerosing agents, especially that used to be used more often in bleeding varices, but it's very limited in case of non-variceal bleeds. Because in sclerosing agent, there is a concern about causing tissue necrosis, perforation, or pancreatitis. Tissue adhesive is a new type of choice that we have now, and people use, we can use thrombin, fibrin, cyanoacrylic glues, and it creates a primary seal at the site of bleeding. So that is something which is an additional armamentarium. This is the injection needle, which I'm sure you are all familiar with. Mechanical therapy is, endoscopic mechanical therapy includes clips, which can be through the scope or over the scope, and band ligation devices. Endoscopic clips are deployed directly onto a bleeding site and can be very effective, especially if all else fails. It sloughs off within a few days after placement, and it secures your hemostasis. So hemoclips, there are various types that are available in the market. They are applied with the help of a special applicator. I'll just show you, and I'm sure you've seen a lot of them. And they're quite particularly useful in patients who have got coagulopathy, but there are limitations to the situation where you can use them. There are quite a few types of hemoclips on the market now, and there are various types where you can open and close them and then deploy them at will. In the past, you only had a choice of hemoclip where you could only use it once. Once you close them, that was it. But now you can change you can rotate them, you can open, close them, and select the best site to deploy them. So that's the advantage of the modern hemoclips, and some of them come with quite long jaws. The one that I tend to use is the Boston Scientific one, which is quite useful, very versatile and effective. There are different types. There is the option of over-the-scope clip, which is far more effective than most of the other treatment modalities. And if all else fails, it is quite useful to use this. They are available in various sizes depending on the type of scope that you use. And they come in different shapes as well, depending on the purpose for which you are using them, because they can be used both for controlling bleeding as well as sealing of perforations. This is the type that you see. Mechanical therapy endoscopic band ligation devices, they are traditionally used for varices, but they can be used for Delafoy lesions and sometimes used for gastric vascular ectasia. Topical therapy, that's something new, well, relatively new, because topical hemostatic sprays have been used in acute bleeds. The advantages of non-contact spray, catheter delivery, and when everything else fails, you can use them as rescue therapy. The one that I commonly use is the I used to use that quite a lot, the Hemospray by Cook, but there are others on the market. Hemospray is a mineral powder which concentrates clotting factors at the bleeding site to form a clot. And it's quite useful if there is a diffuse bleeding going on at the ulcer base, or if there's a bleeding from a tumor surface which you want to control. This is the picture of a Hemospray. Endoclot is another type of treatment, but I found it very disappointing and it's not very effective. The one which is really good is Purostat. It is new. It is a viscous transparent gel. It utilizes its self-assembling peptide technology. It's indicated for hemostasis of oozing bleeding in parenchyma of solid organs. Very useful for use during ESD and EMR, because you can actually see through it, and it's applied by a dedicated catheter assembly. And the advantage of this Purostat is it's a hydrogel matrix. Visibility of bleeding area remains intact, and it doesn't interfere with your operation. This is how it looks. It comes in a 1 ml syringe and very effective. There are a few recommendations from ESGE, which I'll quickly show through, but I won't go through them. Normally, generally speaking, adrenaline should not be used as a sole therapy in type 1, type 2 types of ulcer classification. It should be used in conjunction with all the other modalities of treatment. There's very little to choose between the different modes of treatment. You use whatever you are good at and whatever works best for you. Thank you very much for your kind attention.
the further complications are higher in the group when the portal pressure is significantly elevated, and therefore the term that I've coined is malignant portal hypertension. Clearly we need to work on that further to try to sort of define it more objectively and support it with the available evidence.
Okay. Any comments from the panel of experts?
In the interest of time, already we have a lot of experts sitting here.
Okay, a few housekeeping announcements. Tea is in a grand ballroom, and we'll be back in this hall at 11:15 a.m. And after that, this will be Hall B, and there's Hall A right next to it. And there will be symposium on portal hypertension in this hall. And there's also inauguration of poster exhibition in Palace Hall by Professor Arif Mahmood Siddiqui, ex-president, Pakistan Society of Gastroenterology and GI Endoscopy. Can we take a quick photograph in front of that poster?
Hello. I welcome you all to another session here. We're going to talk about another interesting and important topic, that is portal hypertension. Just to be clear, there are going to be 2 sessions simultaneously. This is Hall B, and we are going to have a symposium on portal hypertension. There is another simultaneous session going on in Hall A, that is the endoscopy session, that is just parallel to this room. So without further ado, let's call upon stage our panel of experts. I would like to call upon stage Professor Zahid Yassin Hashmi. He is the consultant gastroenterologist at Liver Clinic, DHQ, Faisalabad. I would like to call upon stage Professor Amanullah Abbasi. He is Professor of Gastroenterology at National Medical Center, Karachi and Dow University. I would also like to call upon Dr. Arif Mahmood Siddiqui, if he's in the hall. I think he'll be joining us real soon. So, portal hypertension. It is one of the major issues in Pakistan, and the most important complication of cirrhosis. So, first of all, I would like to call upon Dr. Anthony Teo. He is Professor, Deputy Director of Endoscopy, Prince Wales Hospital, Chairman, WEO Research and Education Subcommittee, Vice President, Asian EUS Group, Vice President, Hong Kong Society of Endosonography, Vice President, Hong Kong Hernia Society, Council Member, Hong Kong College of Surgeons.
Thank you very much for your kind introduction. As you know, some of you know, I'm a surgeon as well as an endoscopist. So I've been invited to this session on portal hypertension. So originally my talk is on non-invasive assessment of portal hypertension, but obviously I do not know anything about fibroscan and all that stuff, so I don't want to pretend I know that. So actually I would like to talk more about recent advances in endoscopic assessment of liver cirrhosis, particularly introducing the concept of endohepatology, because I know I'll be surrounded by a group of hepatologists here, and it is a good opportunity for me to introduce some new techniques. These are my disclosures. So before moving on, I'd just like to introduce a book on interventional US. For those here who are not so used to this area, this is a very nice book, and it has become one of the top sellers. So we have received more than 9,000 downloads. So if you are interested in interventional US, particularly in the space of hepatology, where we are using US to measure portal hypertension, there are a few cases in this book. So as we know, liver cirrhosis is a big problem in US, in Pakistan, in India, in this area around the world. And we know that the risk of portal hypertension can result in hepatic encephalopathy, varices and bleeding, hepatocellular carcinoma, and of course, death. We all know that there are several ways to grade liver cirrhosis, including biochemical methods like Child-Pugh score, MELT score, non-invasive imaging like FibroScan, as well as invasive methods like hepatic venous pressure gradient. And the concept of endohepatology has really risen over the last few years. Initially, we were just using endoscopy as a means of surveilling the varices. But recently, the role of endoscopy is expanding. And this includes the use of US to guide liver biopsy, to perform portal pressure gradient measurement with the use of US, or even sampling portal venous blood for circulating tumor cells. The idea of using US to assess varices is not a new one. Several studies have been published in the past to see if US is useful in predicting the risks of variceal bleeding. In this study, they looked at the size of the varices in terms of If the varices were bigger in size, then whether this could predict the risk of subsequent bleeding. Also, in terms of therapies, US is also particularly useful because in patients with variceal bleeding, very often the endoscopic picture is very obscured. So the use of US can really help to visualize vessels outside. In this study, we can see the size of the varices does correlate with the risk of need of bending, but of course this is an indirect means of assessing the severity of varices. More recently, the concept of US as a therapeutic maneuver for varices has been published. With the use of the US, we can introduce a needle in the varices and perform hemostatic procedures. So this is a coil which is commonly used in interventional radiology, and with the coil we can actually inject it, insert it into a blood vessel. So this is a bottle of blood which demonstrates the use of the coil, and as we deploy the coil into the bottle of blood, followed by injection of glue into the bottle of blood, that actually would result in some clotting of the blood. So this is the basis on how this approach could help in terms of hemostasis. And the use of this procedure in terms of US guided coiling and glue injection was published in this study. So in 30 patients, the GVs were obliterated after a single treatment session in up to 96% of the patient, and there were no distal glue embolization. In terms of liver biopsy, I think we all know that the traditional way is to perform a percutaneous biopsy. This is a cheap and very efficient way to perform liver biopsy. But recently we have also been looking at other means of performing liver biopsy, particularly by US guided methods. So if we just look at the approach itself, in this study, a systematic review including 9 studies, 435 patients, successful histological diagnosis was possible in 93.9%. Adverse events were only reported in 2.3%, and all of these patients complained of very mild discomfort because all these procedures were done sedated. When comparing EOS versus percutaneous versus transjugular liver biopsy, this study showed that the total specimen length was significantly higher in the US group, and also the complete portal trials was significantly higher. Of note, with US guided method, we can biopsy both lobes of the liver under direct vision. So this may be an added advantage of the US approach. And in this study, comparing 19 gauge needle versus the 22 gauge needle, the tissue adequacy was similarly greater with the 19 gauge needle. There were no differences in the total portal pressures between the 19 gauge as well as the 22 gauge needle. And the length of the longest piece of tissue was higher with the 19 gauge needle. And this picture shows you what the findings are. So really, the use of US guided liver biopsy may have some advantage over traditional means of performing percutaneous liver biopsy. In addition, US may be used to assess the portal pressure gradients. So we all know the gold standard for measuring portal pressure gradient is via the hepatic venous pressure. So just to remind you how we did this is quite an invasive procedure. The catheter will be introduced from the neck, and the radiologist will float the catheter all the way down the IVC, SVC, and then lodge the catheter at the hepatic vein. So with the blue balloon not inflated, this would be the free hepatic venous pressure. So basically the hepatic vein pressure, and this would be measured a few times. And then with the blue balloon inflated, this would be the wedge hepatic venous pressure. And this would be considered equivalent to the portal venous pressure. This is the sinusoidal pressure, provided that these two pressures are the same. So by calculating the difference between the wedge and the free hepatic venous pressure, we could calculate the hepatic venous pressure gradient. And this is another schematic showing you how we measure this. The free pressure would be lower, would be similar to the systemic venous pressure, and the wedged hepatic venous pressure would be similar to the portal venous pressure. So many studies have looked at the role of hepatic venous pressure. With a high pressure, it has been shown that this was associated with larger varices as well as the risk of bleeding. So smaller varices has a lower venous pressures. The hepatic venous pressure gradient also predicts mortality in conjunction with the MELD score as well as the Pew-Child score. And in the multivariate analysis, the hepatic venous pressure is 6 times is a very good predictor in terms of mortality. In terms of hepatic cellular carcinoma, the high hepatic venous pressure also leads to a 6 times increased risk of incidence of hepatic cellular carcinoma. And another study looking at the risk of liver decompensation, and again, the hepatic venous pressure gradient was a significant predictor for liver decompensation. So it points to us that the hepatic venous pressure gradient is very important in terms of guiding the outcomes in cirrhotic patients. But actually we are not doing so much of this because it is an invasive procedure and often it's quite cumbersome to arrange. So only recently we've been able to do this with endoscopy. So with US, we're actually measuring the true portal venous pressure gradient. So a US guided puncture can be performed with the hepatic vein, followed by the portal vein, and we can actually measure the true pressure difference between the portal vein pressure as well as the hepatic vein pressure. In this study, it is a pig study. They compared the US pressure measurement to the conventional hepatic venous pressure measurement. And they found a very good correlation, meaning the US approach should be quite a feasible and accurate one. And in this other study, they found that the US portal pressure gradient correlates very well with endoscopic appearances of portal hypertension, including the presence of varices as well as a portal hepatic gastropathy. So this sets the scene that US guided portal venous pressure gradient measurement may be quite useful. And how we perform this is usually performed in the left lateral position. The patient is deeply sedated. We use US to identify the portal vein and hepatic vein. Sometimes the hepatic vein is very small. And also we may need to identify the left or sometimes the right hepatic vein. The pressure gauge will be placed at the right atrial level and used to perform free readings for each vein on average. So just to remind you, the portal venous pressure gradient, a normal is between 0 to 5. Gradient more than 10 millimeter mercuries has increased risk of developing esophageal varices, and a gradient of more than 12 has increased risk of OV bleeding. So 2 studies have been completed. The portal study is an international feasibility study in which we have participated. Another correlation study of hepatic vein pressure gradient, which is the gold standard comparing to US portal pressure gradient. So we also performed the first portal pressure, US portal venous pressure gradient measurement yesterday in the endoscopy session. So I think this has a high potential. So with US, we are not used to assessing the liver, so we need to be clear that on US we are actually looking at the liver from behind, so the anatomy may be a little bit different. So this is a device. This is a 25 gauge needle, which we commonly use it for US guided biopsy. This is a pressure device. So all this is connected to the needle in a single connection, and the entire unit is primed with saline. So this is the unit, this is the pressure gauge, and we would turn on the pressure gauge, and initialize the pressure gauge. This pressure gauge can be reused, although the company would not suggest you to do so. And then the entire unit would be connected with tubings, and then we would prime the entire unit with saline so that there will be no air bubbles in the entire unit. So looking at this case, it's a patient with child species cirrhosis on antivirals. On surveillance ultrasound, there was a suspected hepatocellular carcinoma. On OGD, he was found to have 4 columns of grade 2 esophageal varices with red well sign, and 4 columns of banding was done. So this patient was referred to us for portal pressure gradient measurement. You might ask, we know that this patient already has a very high portal pressure going from the history. So what's the role? So on OGD, you can see this is the appearance of the 4 columns of grade 2 esophageal varices. And on CT scan, this was done for the hepatocellular carcinoma. We also take the chance to look at the position of the vein, because we need to plan for puncture of the veins. So sometimes in very cirrhotic patients, the anatomy has changed. So in this CT scan, there seems to be a good window for puncture of the hepatic vein as well as the portal vein. So this procedure was also done in another workshop.
So usually this is it.
So this is the liver. So first we would assess the puncture sites. So this is the portal vein. So why I say so? It is because we can see a very nice Gleason capsule. This is a whitish capsule surrounding the portal vein. And in patients with cirrhosis, the portal vein is often very dilated. So you can see a very dilated portal vein. And you can see a very rich paraesophageal varices. So going back to here, we would want to plan our puncture site. So usually when puncture, the first worry is of course bleeding. So we would actually puncture through some liver parenchyma and into the vein, so that when we withdraw the vein, the liver acts as a parenchyma, preventing the bleeding from the puncture site. Then we try to find the hepatic vein. This is the hepatic vein. We can trace the hepatic vein with a scope as it enters into the IVC. So the hepatic vein is usually much smaller in size. So this is around 2 millimeters. So from here, I would puncture the hepatic vein first. This is hepatic vein. So you can see the needle going in. There is some liver tissue. This is a pressure gauge. I will inject some saline to flush the pressure gauge. And you will see some water bubbles coming out from the needle. So after a while, the pressure will become equilibrium. And you can see the pressure in this hepatic vein is around 4 millimeters mercury. We wait for around 1 minute for it to become completely settled. And we would do 3 measurements. So on withdrawal, you can see the needle is done being under Doppler ultrasound, and we will observe for bleeding. So another measurement of the portal vein, again puncturing here into the portal vein, and again we would measure, do 3 measurements. So around here, the pressure equalized at around 19 millimeter mercuries. So this is quite high. So if you do a quick math, 19 minus 3, is already 60 millimercuries. So finally, after 3 measurements, this is the portal pressure gradient. So it's 17.66. It's quite high. So in this patient, we actually have room to further increase the beta blocker just by using the portal pressure gradient. And this may, for this patient, improve the outcomes. So the advantage of the endohepatology is that we could provide a one-stop shop for complete examination. We can do OGD for OV and GV surveillance. We can measure the portal pressure gradient. We can do a liver biopsy, and all this is performed under sedation. So this can much improve the patient comfort and also reduce the cost. So if you use ultrasound-guided liver biopsy, certainly this will be much cheaper. But if you combine all these procedures all together, the benefit to the patient may be significantly improved. So in conclusion, endoscopy has an increasing role in the assessment of liver cirrhosis. US-guided portal pressure venous gradient adds a powerful tool to quantify the severity of liver cirrhosis, and further studies are required to evaluate the clinical role of the procedure. So thank you for your attention.
Thank you so much, Dr. Anthony Teo. He did an excellent demonstration of PPH measurement US guided yesterday and during our workshops. So our next talk is going to be on novel therapies for refractory ascites and hepatorenal syndrome. The speaker is Professor-in-Chief, Section of Gastroenterology and Hepatology, Baylor College of Medicine, Houston, Texas. She is Dr. Fasiha Kamal.
Thank you so very much for the introduction and for inviting me to the PSG, to all the organizers. So I'll be talking about therapies for refractory ascites and hepatorenal syndrome. Let me make sure that I can move this. So just before I start, definition of refractory ascites. What is refractory ascites? Now, we heard about portal hypertension. Ascites is the most common complication in patients with portal hypertension. And refractory ascites is a complication of a complication. I think that's the way to think about it. It is ascites that cannot be mobilized or the early recurrence of which cannot be satisfactorily prevented by medical therapy. And there are 2 different ways to think about refractory ascites. One is diuretic resistant ascites and one is diuretic intractable ascites. So for resistant, as the name implies, is the ascites where it cannot be prevented and lack of response to sodium restriction and diuretic treatment. I'm sorry, I don't know, allergies or viral infection. Non-COVID though. The other ascites is diuretic intractable ascites. This is where there are complications from use of diuretics, and we all are very familiar with those complications. They could be electrolyte abnormalities, encephalopathy, and also sodium creatinine, AKI, multiple complications that can happen in patients with ascites on diuretics. Thank you so much. So a common problem, and as you think about treatment for refractory ascites, if you look at the guidelines, there are 3 general recommended treatments. I'll talk a little bit about these first, and then I'll talk about some of the novel treatments that are becoming available. So thinking about that, look at the blue boxes. The first recommended treatment, the first line is large volume paracentesis, done with albumin, and the second option is TIPS, transjugular intrahepatic portosystemic shunting. These are the 2 key alternatives, but the one point that I want to make is a third alternative, which is referral for liver transplantation, again, may not be available for most patients, but really important to think about this treatment option because the prognosis in patients with refractory ascites is very dismal. It's about 50% in 6 months duration, so the median survival at 6 months is 50%. Half the patients could die within a short amount of time. So really thinking of liver transplantation if that option is available. So I will not talk a lot about liver transplantation, but we'll focus on the other 2 treatment options, which is large volume paracentesis and TIPS in certain patients. So large volume paracentesis is really the first line recommended treatment. It is safe, it is effective, as long as it's used with albumin administration. Generally for albumin, it is 8 grams per liter of ascites removed. That is what's recommended. Most patients do not really need to be treated with diuretics once they are on large volume paracentesis. And another point that I want to make is there are controversial data about using of non-selective beta blockers like propranolol in patients with refractory ascites. I will not really go into these data per se, but the pragmatic approach is to avoid using high-dose beta blockers, such as like propranolol of 80 milligrams per day in patients with refractory ascites. A few words about TIPS. TIPS does work. It improves symptoms, ascites control, and there are actually some data that I'll share with you in a minute that in certain patients, TIPS can improve survival of patients, which is very important, especially in this very high-risk patient population. The main thing with TIPS is to use a small diameter covered stents because there is a reduced risk of dysfunction and hepatic encephalopathy with the covered stent. So that's very, very important. Another point that I think is important to remember is that after TIPS is placed, we still need to follow patients on salt restriction and also use of diuretics till the ascites is resolves, and it takes a few months for patients to get there, so it's important to continue to monitor those patients clinically. So TIPS is a good option. It is particularly important for certain subgroups because of these data. So in a very select patient population, TIPS can actually improve survival compared to using large volume paracentesis in select group of patients. So this is a prospective, it's a randomized study of 62 patients with cirrhosis with at least 2 large volume paracentesis within a short amount of time. And patients were randomly assigned to groups of TIPS and large volume paracentesis with albumin, and very, very remarkable data as you can look at that. Look at the curves and how they separate nicely with time. 93% of patients who were in the TIPS group, they survived without a liver transplantation at the end of 1-year follow-up. Pretty impressive. Compared to 50% in the LVP group. It makes sense. 50% survival, half of the patients will die in 6 to 12 months. So the control arm makes sense, but the remarkable improvement in patients with TIPS. So really, I think, very promising data. But the important point here is it's really for select patient population. It's not for everyone. In this study, the average age was about 60 for patients. Most of them had alcohol-related cirrhosis. And the mean MELD was around 9. So yes, decompensated, but really not very, very advanced liver disease. And as you can imagine, these patients did not have any contraindications to TIPS because they underwent TIPS. So it's an important point that I want to re-emphasize here. It works, but you have to be careful in who do you select for this procedure. So in general, just to reiterate this point, in younger patients who have relatively low MELD score, they could have a very good, excellent transplant-free survival with TIPS. But we have to be careful. If you look across different guidelines, they recommend against placing TIPS in patients with a MELD score of about 18 or higher, so again, more advanced liver disease. Patients who have hepatic encephalopathy, we have to be careful in not really thinking about TIPS for that patient population. And also those who have cardiac failure, pulmonary hypertension, HCC, sepsis, or portal vein thrombosis. So these are not such infrequent scenarios that we encounter for our patients. If you think about the patients that you've seen, and also in randomized controlled trials, about 50% of patients who are considered for TIPS are not eligible for TIPS. So it's important, but it's not really for everyone, cannot be recommended for all the patients. So which is important because it really leaves behind large volume paracentesis as the only practical treatment option, which is cumbersome. It means that the patients have to come to the hospital for paracentesis very frequently, and most of these patients are really at the end of their life. So in the last few months of their life, they have to come to the hospital for large volume paracentesis, really leaving a big unmet need in this patient population. So that's the novel treatments that are being evaluated. There are few that have some promising data, some safety data, but again, are not really recommended by the guidelines yet. So I want to emphasize that the next two treatments that I will be talking about, they're not recommended by the guidelines yet. The first one is using low flow pumps. The one that is available is called the Alpha pump. It is an implantable subcutaneous pump that pumps fluid from the acidic fluid from the peritoneal cavity into the bladder. There are few studies, case series mostly, that have looked at the Alpha pump, and a systematic review of these small studies, again, most of them are small, collectively just over 200 patients. Even with the presence of pump, 48% of patients still needed large volume paracentesis, so it didn't really fix the problem in everyone. But the most problematic issue was development of acute kidney injury, about 30%, so 1 in 3 patients, and also SPP, spontaneous bacterial peritonitis, in about also the same proportion of patients. So potentially useful, but there are issues with AKI, acute kidney injury, and infection. Having said that, this is still under investigation, this device. There's a large trial that's underway. The one that we have access to is a smaller study of about 30 DIPS ineligible patients, where using the pump did improve patients' quality of life. So one has to give credit for the investigators for looking at that. But importantly, most of these patients were maintained on antibiotics. So they did not really have risk for infections. Promising data, but small data, and really further study is needed before we can think about and recommend this for our patients. There are also emerging data on use of long-term abdominal drains. Now this technique is used for malignant ascites well for many, many decades. There are just recent data that are coming out for using this for patients with cirrhosis-related ascites also. Again, small studies, most show technical success. The risk of spontaneous bacterial peritonitis really ranges from 0 to 42% across these different studies. There's one small 12-week feasibility randomized control trial that also show promising data. Patients really liked getting these drains. They preferred to have these drains even after the study was ended. And the risk of complications, of serious complications, was quite low. Most of the significant complications were local cellulitis that happened in about 40% of patients, but serious complication incidence was reasonably low in this study. So again, small feasibility trial, promising data, larger studies are needed for this approach. So based on that, what does the guidance recommend about these strategies? These strategies, drains and alpha pump, might be alternatives to serial LVP in patients who have refractory ascites who are not candidates for transplant or not candidates for TIPS. But really more comparative effectiveness research is needed before these could be recommended for routine care. Now shifting gears towards AKI, some change in definition for AKI hepatorenal syndrome. This is when the serum creatinine increases for about 0.3 milligrams per deciliter within a short amount of time, within 48 hours, or the creatinine increases more than 50% from baseline. Now there has to be no response to 2 days of withdrawal of diuretics or with plasma expansion. And in the absence of shock or in the absence of any medications that can cause kidney injury, and also no structural kidney injury has to be present. So that's the definition for AKI and hepatorenal syndrome. Again, a very high-risk condition with a very dismal prognosis. Now, the first-line therapy for this, as recommended by the guidelines, is using albumin plus vasoactive drugs. And I'll talk about these vasoactive drugs in a few minutes, but before I do that, let me just bring up 2 points. One is, how do we define response to treatment? So this is based upon the final creatinine has to be within 0.3 milligrams from baseline. So really coming back to where it started from. There's also a definition of partial response where there's a regression, but the final creatinine is higher than that 0.3 cutoff. So remember that 0.3 cutoff. But the second point that I wanted to make, because of the real poor prognosis, liver transplantation. Thinking about liver transplantation for this patient group is also very important, just like it is for patients with refractory ascites. So going back to the treatment right now, what is that we have, that the guidance have recommended for a long period of time? Albumin. is really the cornerstone of treatment for AKI hepatorenal syndrome. And the dose that we use for this indication is 1 gram per kilogram for 2 days, and then 20 to 40 grams per day after the first 2 days. This is different. Albumin is used for other indications also. It's used for prevention of paracentesis-induced circulatory dysfunction. It is also used for prevention of SBP-related hepatorenal syndrome. So I've laid out the doses because those doses are different than the dose that are used for AKI here. In terms of the other treatments, we've been using for a long time combination of octreotide and midodrine with albumin. And if patients do not respond to it, the recommendation is to move to noradrenaline, which is problematic because you can only really administer it within the ICU settings. So in the interest of time, because I really want to review some really emerging new pivotal trials that have come out, I won't go over the doses here, but they're here for you to take a look at. And also there's several guidelines that really detail the dosages and how you step up therapy in patients who do not seem to respond. So we'll not spend a lot of time. But what I would want to talk about are some of these really pivotal trials. Albumin, I mentioned, it's really a cornerstone of therapy for patients with AKI and for decompensated cirrhosis broadly. This was a trial that came out now a few years ago that looked at preventive effects of albumin in terms of reducing mortality. So really showing survival benefit of using albumin in patients with decompensated cirrhosis, but manageable ascites, diuretic managed ascites. Patients were randomized to standard medical therapy, or they were randomized to weekly albumin for as long as 18 months. And as you can see by the graph, there was a separation. Using albumin was protective. It improved survival in this important trial now a few years ago. However, this is not borne out in this very recent trial that just came out a few months ago. This is the ATTIRE trial. In this, it's a large trial for hospitalized patients with decompensated cirrhosis who were hospitalized mostly for ascites or related complications. The 777, so a large trial patients, they were randomized to either using albumin infusion, I'll tell you in a minute how this was used, or standard of care. So patients had to have an albumin of less than 3 grams per liter to be enrolled in the study. And they gave them daily albumin infusions with the goal of raising the albumin level to above 3 grams per liter. And patients were followed over time for complications. The main endpoint was mortality, infection, or AKI, really significant clinical complications. And this was done in multiple hospitals across different countries. And what this trial found was no difference. There was no difference in outcomes between patients who were in the albumin arm or in the standard of care arm. But what it also found was higher risk of complications in patients who were in the albumin arm, more lung infections and also more pulmonary edema. So really, I think this is a very important study, a large awaited trial, that using albumin, despite all the promise, did not lead to any clinical improvement in patients who were hospitalized with cirrhosis, but actually was associated with more serious adverse events. So as we stand right now, albumin administration is not really recommended outside of usual routine recommendations. But all is not really doom and gloom. There are some exciting data from another trial that also just came out. This is the confirmed trial that looked at terlipressin plus albumin and really showed promising data. This was effective in patients with hepatorenal syndrome and AKI, again, used in combination with albumin. But in this large trial, again, used in terms of hospital setting using terlipressin, resulted in reversal of hepatorenal syndrome in about 1/3 of patients compared to just 17% in patients in the control arm. But again, take a note of that. There were higher numbers of patients who had respiratory failure, pulmonary complications in the treatment arm compared to the control arm, and also there was really no difference in mortality. Again, pointing out this is a very high risk condition. There was no survival benefit of using terlipressin. So just to summarize, as we stand right now, LVP and TIPS really are the options for patients with refractory ascites. There's some exciting data about abdominal drains and about these alpha pump, but we really will have to wait for more data to come out before they could be recommended for routine care. For AKI, the first line therapy is vasoactive drugs per albumin, and now we do have terlipressin available, at least for use now in the US, recently FDA approved, but has to be used with caution. It is associated with more serious adverse events, so really have to be careful in selecting the patients for that, but it is going to be used in routine clinical practice. Very mixed data on the efficacy of albumin in improving outcomes, and for now we'll just continue to use albumin for the recommended indications, just as AKI, using with large volume paracentesis and in patients with spontaneous bacterial peritonitis. Thank you very much.
Thank you so much, Dr. Fasiha Kamal. Our next speaker is Professor Altaf Alam. He is a consultant gastroenterologist and hepatologist and has served as professor of gastroenterology and hepatology in Sheikh Zayed Hospital. His topic would be portal vein thrombosis and cirrhosis, observation, anticoagulation, or TIPS.
Thank you, Dr. Ebtisam, for this nice introduction. I thank the organizers, particularly Professor Ghias and Professor Israr, for providing me this opportunity to talk on this important topic. For those who have to attend to some urgent work, my take-home message, you can take it now. You do everything. You observe, you anticoagulate, and you do TIPS, and sometimes more than that. So the take-home message is, the management is on a case-to-case basis, where you may require all the modalities, including observation. So, greetings for all the delegates to my hometown of Lahore. I have no disclosures to make regarding this presentation, and what I'm going to do is just present a case of portal vein thrombosis in cirrhosis and discuss the approach on how to manage such patients. So here is my patient, a 58-year-old male, history of HCV cirrhosis, treated with DAs 4 years ago, comes to OPD for 6 monthly follow-up, mainly for HCC surveillance. He is asymptomatic on examination. He has palmar erythema, spider nevus, splenomegaly, but no ascites or edema. Hemoglobin 13.1, platelet 132, white cell 3.2, bilirubin 1.2, ALT, AST normal, ALP 132, albumin within reasonable range, INR normal, creatinine 0.8, sodium 140, and alpha feto 4.2. Ultrasound, unlike the previous ones, shows features of cirrhosis, but this time it raises the suspicion or confirms that there is portal vein thrombosis. There is no ascites. His CPT score is A5 and MELD is 8. So what next? Any postgraduate student here who wants to contribute? Where do we go from here? You have this information. Where do we go from here? Anyone? Yes? Okay, so message number 1, don't rely on ultrasound imaging alone. You need a cross-sectional imaging, not only to confirm your diagnosis, but also to see the extent of thrombosis and also to rule out HCC. So, message number 1 about this case, you have to do a multiphasic CT scan. Number 2, you have to do congenital and acquired thrombophilia screen. You may argue that some of these tests are not reliable in the setting of cirrhosis, but not all. So you still, it is mandatory in terms of management to do congenital and acquired thrombophilia screen to optimize the management of such patients. And of course, endoscopy, because before you start any treatment, you like to look after the bleeding or future bleeding sites in the upper GI. So certainly these three things are what we would like to do in this particular patient. My patient's CT shows in the portovenous phase shows portal vein thrombosis, and take my word for it, there was no splenic vein or superior mesenteric vein thrombosis. I like this classification, although more than quarter of a century old, but you know, partial portal vein is grade 1, complete portal vein or more than 50% is grade 2, portal vein thrombosis extending to superior mesenteric but not blocking it completely is grade 3, and grade 4 portal vein and SMV complete thrombosis. So I like this classification. I would probably be referring to it in my further slides, although Bovino 7 has recommended a few additions to it, time course, recent or chronic with a 6-month window, occlusive, minimally occlusive, and cavernous transformation, which we see in chronically thrombosed portal vein with collaterals, and you can't even see the portal vein in such cases on imaging. And then response to treatment has to be described as well in terms of either stable, regressive, or progressive, and these terms are self-explanatory. So you need not only make a diagnosis, you need to either observe or treat and then follow up, and all these things have to be noted in your records. There are a lot of causes of portal vein thrombosis. As I'm restricting my talk to cirrhosis, I'm not going to talk about all other causes, just to say that thrombophilia does contribute to a large percentage of patients with cirrhosis, both acquired and inherited thrombophilia. So whether it is inherited like factor V Leiden mutation, prothrombin gene mutation, protein CS and antithrombin 3 deficiency, hyperhomocystinemia, and many others. Acquired thrombophilia, particularly myeloproliferative neoplasms, MPN as we call them, and you can detect them by various mutations, particularly JAK2 and JAK2V617F mutations. And they are not uncommon. You know, in the next slide, I'm going to tell you that this is as per EASL guidelines. Inherited and acquired thrombophilia account for more than 50% of cases of portal vein thrombosis, so not uncommon. And if you include myeloproliferative neoplasm, this is 2/3 of cases do have either one or the other, or maybe multiple causes. So it is mandatory that you do the whole screen, because one patient can have multiple causes. What is the incidence and prevalence? It is one of the most common thrombotic event in cirrhosis. Incidence at 1 year is 7.4 to 11% based on data that you are looking at. Prevalence of 2.1 to 23.3 has been documented in transplant waiting list setting without HCC. And in cirrhosis river, the relative risk is very high, 7.3 of non-neoplastic portal vein thrombosis. So it is not really uncommon. I understand there is a talk on coagulation in cirrhosis, which I just saw in the program, so I'm not going to discuss all these factors, but you must remember that clotting by conventional methods is not very reliable in the setting of cirrhosis. Moreover, the hemostatic system is rebalanced, and this rebalance is not as stable as in normal liver. So it can either tip one way or the other. So the pro-hemostatic and anti-hemostatic factors have a very, difficult and slippery balance in cirrhosis. I would just say another last slide about coagulopathy in cirrhosis, that in this rebalanced hemostatic system, the bleeding is normally not due to coagulopathy, but because of these factors like sepsis, portal hypertension, endothelial dysfunction, and renal impairment. And although there are many reduced procoagulant factors, reduced platelet function, decreased fibrinogen, they are less contributory and less commonly the cause of actual bleeding. In terms of favoring thrombosis like portal vein thrombosis, hospitalization is a major risk factor. And when the patients of cirrhosis are admitted to us with SBP or hepatic encephalopathy, do we provide them thromboprophylaxis in this country? No. Why don't? Because we are unaware of this factor, that in cirrhosis, thrombosis, particularly of portal vein, is not uncommon. And again, hospitalization is a major risk factor, although there are many other contributory factors like reduced anticoagulant factors, increased von Willebrand factor, increased factor VIII, and decreased cleavage of von Willebrand factor by Adam TS13. So you have to remember that hospitalization is again a risk factor, and we should be thinking of providing thromboprophylaxis to our patients. So coming back to my patient, these were the three options that we discussed. Let's look at the results. We find portal vein thrombosis alone, no extension to splenic vein, no extension to superior mesenteric vein. Congenital and acquired thrombophilia screen is negative. EGD showed small esophageal varices with no stigmata of bleeding. So what next? Should we observe? Should we anticoagulate? Should we do tips straight away, or what? Well, before we think about these options, there are many factors. And as I said, you have to, upfront, this is what I said, that you have to make a decision on a case-to-case basis based on equity of thrombosis, transplant candidacy, presence of an inherited coagulopathy, bleeding risk factors. You know, a patient who is actively bleeding profusely, you can't anticoagulate him, and comorbidities and the expected survival. So these are some of the factors that you have to keep in mind. What do I do? In a patient like this, CPT-A, low molecular weight heparin, followed by warfarin or DOACs in grade 2 to 4 portal vein thrombosis. In grade 1, that is less than 50% of main portal vein, I observe and follow up. Anticoagulate if it shows progression on follow-up, and I always consult a hematologist. I would also like to add here, before you anticoagulate, you always do an endoscopy, and if the varices are high grade, you bend them, and then you think of other options. Child class B and C, in liver transplant candidates, the same principle. Because, you know, the only difference here is that DOACs have to be used with caution in child class B and certainly not in child class C. So that is the only difference. The other difference is on warfarin. It is very, very difficult to handle warfarin in our setup, where we cannot ensure reliable follow-up of patients, and repeated checks of INR. So I tend and avoid that as well, if possible. But if a patient has shown a track record of reliable follow-up and agrees to follow up regularly, I may consider that. So my mainstay of treatment is low molecular weight heparin in such category of patient in therapeutic doses. 1 milligram per kilogram body weight twice daily, or 1.5 milligram per kilogram body weight once daily. So whatever is convenient to my patient. Grade 1, I observe and follow up, but if my patient is a transplant candidate, I always anticoagulate even in grade 1 portal vein thrombosis. So again, always consult a hematologist and always do an endoscopy before making any decision. What is the suggested duration of anticoagulation? It is, generally speaking, 6 months. It should be continued for at least a few months after recanalization of the portal vein, which means that you have to follow up your patients regularly. But in patients with SMB thrombosis or past history suggestive of intestinal ischemia, permanent thrombophilic state, lifelong anticoagulation is suggested. Future liver transplant candidates anticoagulate till transplant. What to do after transplant? There are no guidelines on this, but I believe a patient with thrombophilic state should be anticoagulate, and Spanish Society of Transplantation has now recommended anticoagulation in such patients post-transplant as well. The question arises, we always had this myth that cirrhotics are naturally anticoagulated. Why anticoagulate a cirrhotic patient with portal vein thrombosis? The answer is, even when there is no portal vein thrombosis, there is one randomized trial published about 9 years ago in Gastroenterology. Sorry, it is not coming up here. Via et al. Did this trial in small number of patients, around 90 or so, a randomized trial. Cirrhosis with no portal vein thrombosis, prophylactic 40 milligram of low molecular weight heparin for 2 years, and they found that there is decreased bacterial translocation, decreased portal vein thrombosis, actually no portal vein thrombosis, and decreased decompensation and improved survival. So why are we afraid of anticoagulating cirrhotic patients admitted with portal vein thrombosis and those who are admitted without portal vein thrombosis for other life-threatening conditions? I would recommend using Padua score to assess suitability for prophylactic anticoagulations in your cirrhotic patients based on the underlying comorbids and their physical status. And in portal vein thrombosis, it is certainly helpful. Decreased bacterial translocation, decreased decompensation, and improved survival. As I mentioned, heparin and warfarin and low molecular weight heparin can be used in all categories, child class A, B, C, whereas DOACs only in A, B with caution, C, big no with capital N. I'll skip some of the slides. What do the guidelines say? ASLD says case-to-case basis, which is not wrong. EASL is more clear, anticoagulate for 6 months. But as I mentioned, if SVT, thrombosis, and intestinal ischemia, consider lifelong anticoagulation. What about thrombolysis, thrombectomy, and TIPS? Thrombolysis, either systemic or local, can be used as an adjunct to anticoagulation in patients who are progressing despite anticoagulation, but it carries high morbidity and mortality. And surgical thrombectomy is very high morbidity and usually not practiced anymore. Of course, emergency surgery for gangrene of the intestine has to be done. TIPS, inadequate response to or contraindications to anticoagulation, you have to go for TIPS. Chronic portal vein thrombosis and cavernoma with portal hypertension related complications refractory to medical and endoscopic treatment, TIPS should be considered. And I'm glad Dr. Ammar is following me. You may question that in cavernoma, portal vein is not visible. How are you going to go TIPS? But Dr. Amar, I would request you to add one brief comment on this, that through transjugular and transsplenic route, there is still very high recanalization on TIPS of portal vein and success of TIPS in current days, and I'm sure you are going to talk about it. I'm not going to talk about non-cirrhotic patients today, but my conclusions are high index of suspicion for portal vein thrombosis in cirrhosis on follow-up. Gear up your radiologist to look for it and use Doppler at least in all those patients who are coming for HCC surveillance. Always confirm it with cross-sectional imaging. Thrombophilia screen and hematology consult is mandatory. Anticoagulation is the mainstay of treatment. Before you do that, endoscopy should be performed. TIPS still has a major role, but thrombolysis and surgical thrombectomy have very little role in current times. Thank you very much for your patient listening.
Thank you, Professor Altaf Alam. Our next speaker is Dr. Amar Sarwar. He is Associate Professor of Radiology, Harvard Medical School, Co-Director, Liver Tumor Multidisciplinary Program, Beth Israel Deaconess Medical Center. Ladies and gentlemen, Dr. Amar Sarwar.
Good afternoon, everybody. Thank you to the organizers, the moderators, Professor Ishaq and Professor Ghyas for inviting me. I'll be speaking about the endovascular treatment for variceal hemorrhage. I have no disclosures. So I'm going to try to talk mostly about the guidelines for variceal bleeding from hepatology societies, and then I'll briefly talk about TIPS, BRTO, and splenic artery embolizations. So we'll start with the EASL guidelines for the management of acute variceal hemorrhage. And as you see over here, when a patient comes with acute GI bleeding, the first therapy of choice is endoscopy. But with endoscopic band ligation, the most recent guidelines, which I think are due for an update soon, indicate that so 85% of patients will get control with endoscopic therapy. About 15% of patients will be refractory to endoscopic therapy. For the patients who get control of with endoscopic therapy, there is a consideration for early TIPS in high-risk patients. And obviously, patients who are refractory to endoscopic therapy should be undergoing TIPS with rescue or salvage strategies. In terms of management of persistent bleeding, in those 10 to 15% of patients who have either persistent bleeding after endoscopic therapy or early bleeding, there's level 1 evidence with level 1 evidence and a level 1 recommendation from EASL that TIPS should be used as a rescue therapy of choice in these cases, in addition to some other medical management that is performed typically by endoscopists. The AASLD guidelines from 2017 say that the patients who have a TIPS placed successfully during the acute episode do not require beta blockers or further endoscopic screening or variceal ligation. TIPS is the recommended rescue therapy in patients who experience recurrent hemorrhage despite combination therapy with both beta blockers and endoscopic therapy. The first TIPS trial started in 1989, and I'm highlighting this for our population in Pakistan. We have a high incidence and prevalence of cirrhosis in our population, and I think that it's high time that TIPS starts to get used more frequently in Pakistan as well. Since that time, there have been numerous studies which basically talk about either an elective TIPS for variceal bleeding, for example, in patients who have a MELD score of less than 17 with more than one episode of variceal bleeding despite endoscopic control, or patients who have ectopic varices even with endoscopic control, or patients who have persistent untreated varices. There are several studies that have come out in the recent years from 2015 to 2020. One of the studies highlighted here showed that endoscopic band ligation plus TIPS was much better than endoscopic band ligation alone. At 1 year, there was no rebleeding in 97% of patients with EBL plus TIPS compared to 50% rebleeding rate with patients who had EBL alone. The 1-year survival was higher, and there was longer hospital and ICU stays in patients who only underwent endoscopic band ligation. Moving on, I think a point that I would like to highlight as we start to think about patients coming for TIPS is that TIPS alone is really not the answer, but it's really TIPS plus variceal embolization. This randomized trial from 2005 clearly shows in the left-hand side that the group 2, which was the TIPS plus embolization, this means that after or before you place the stent that will decompress the portal system, you should also embolize, or the interventionalist should also embolize the varices with either coils or a combination of coils and sclerotherapy. That group did much better in terms of both freedom from variceal rebleeding up to 120 months. That's 10 years after the procedure, as well as doing better in terms of survival. That study was from 2005. Technique has since refined, and this newer study, which is with a smaller amount of follow-up, which was a retrospective study published in 2019, continues to show that TIPS plus embolization is much better than TIPS alone. One of the areas that I'm going to spend some time on that I think is really important is secondary prophylaxis after variceal bleeding for TIPS. This is a paper, a seminal paper, I would say, that came out in 2010 in the New England Journal of Medicine, and as an interventional radiologist, we get very few papers published in the New England Journal of Medicine. And so this publication from Europe, which showed the early use of TIPS in patients with cirrhosis, looked at early use of TIPS in patients with cirrhosis and variceal bleeding. In terms of patient selection, and this is one of the challenges of doing medical device trials, but 359 patients were screened and 63 patients underwent randomization. The point that I want to highlight is that this trial excluded patients who were Child-Pugh A, excluded patients who were Child-Pugh B but did not have active bleeding at endoscopy, and excluded patients who were Child-Pugh C with a score greater than 13. In terms of patient characteristics, both groups were equivalent, but as you see here, a majority of males, majority of alcohol cirrhotics, but Class B and Class C disease. All of these patients had active bleeding at the time of endoscopy. Small percentage were in shock and had blood units transferred. Almost all of them underwent successful band ligation, with a few undergoing injection sclerotherapy, and all of them were on some form of vasoactive drug therapy at the time of randomization. The early TRIPS group showed improvement in freedom from bleeding up to 2 years after the study, as well as better survival compared to the patients who underwent both drugs and endoscopic band ligation. So what this trial shows is that after you have achieved endoscopic control of varices, even in Child-Pugh B and Child-Pugh C patients with less than 13 score, for the Child-Pugh score, there's a benefit in terms of survival and a benefit in terms of rebleeding if you undergo early TIPS within 72 hours of that initial bleeding episode. The other efficacy measures that were studied in this trial was, as I mentioned, rebleeding, and there was no rebleeding both in the early time period from 5 days to 6 weeks after the procedure and up to 1 year in the TIPS group. In addition, in terms of mortality, mortality was higher, especially in the Child-Pugh C class patients in the EBL alone group versus the EBL plus TIPS group. And then in terms of the time in the hospital, the median hospitalization was much lower in patients who underwent TIPS compared to patients who underwent only endoscopic band ligation. In terms of safety, one of the common conditions that we worry about as interventionalists is the induction of hepatic encephalopathy in decompensated patients. But this study showed that actually hepatic encephalopathy was higher in the pharmacotherapy plus EBL group compared to the early TIPS group, along with the other adverse events. Now, one of the concerns that often come up in places which are not doing TIPS very commonly is the TIPS failure rate. And certainly there's a very large learning curve for performing TIPS safely. Poor outcomes after TIPS typically happen when you have high rates of unsuccessful TIPS at your institution. If you undergo bleeding, either variceal bleeding or bleeding from a capsular puncture or a hepatic pseudoaneurysm because of puncture of the hepatic artery during TIPS. Liver failure is an important consideration. We use typically a MEL score of greater than 18 for a relative contraindication for elective TIPS and greater than 24 for emergent TIPS, because those patients are typically acutely decompensated, but their liver function can be recovered. And then right heart failure is something that we think about when we're placing a TIPS. And so we do right atrial pressure measurements, and when it allows, we like to have an echocardiogram to make sure that the right heart will not be overloaded if we shunt all the portal blood flow directly into the heart. Another area to think about is stent dysfunction. And this is important in the Pakistani context and a kind of third world country context because of the costs involved. But stent dysfunction is extremely high. If you see here, within 1 year after TIPS, if you're using a wall stent, which is an uncovered stent, the stent dysfunction rate is very high, and these patients will need repeat interventions. And therefore, a Viator TIPS, which is a PTFE covered TIPS, is really the standard of care for TIPS placement at this time across the world. There are studies that have looked at causes for rebleeding. So how do you prevent basically rebleeding after a TIPS? And in this study of 300 patients, they evaluated 25 patients who had variceal hemorrhage after TIPS placement. So what can the interventionalist do to reduce the risk of rebleeding after TIPS? So the root cause for rebleeding after TIPS placement is lack of or insufficient embolization. So I think variceal embolization at the time of TIPS is really critical. The presence of coagulopathy is a risk factor for rebleeding. TIPS stenosis or occlusion. So TIPS dysfunction is really something that we have to avoid, even if it means higher cost at the time of the index procedure. And then finally, inadequate portal systemic gradient reduction. We try to aim for bringing a portal systemic gradient less than 12 millimeters in order to have control from rebleeding at the longer term. Another study that I published in Hepatology a few years ago, where we looked at about 10,000 patients undergoing TIPS across the United States in more than 500 hospitals, showed that experience matters. And while this may seem intuitive, what we found that hospitals performing more than 20 TIPS per year had a better mortality, a better adjusted mortality adjusted for all other risk factors compared to hospitals performing less than 20 TIPS per year. So experience, I believe, in TIPS placement really matters. And even in Pakistan, similar to how we have centers of excellence for liver transplant, I think we should have centers of excellence for hepatology and TIPS placement and IR therapies, which is really critical. Moving on, I'd like to share some new innovations in TIPS, and these slides are dedicated to Professor Altaf. This is going to be about portal vein thrombosis. So first of all, looking at variceal bleeding in portal vein thrombosis, this study in Gut from 2017 randomized patients with portal vein thrombosis in more than covering greater than 50% of the portal vein and had a prior variceal bleed. They were randomized to either a TIPS and portal vein recanalization versus endoscopic band ligation with beta blocker. Overall survival was similar, number of hepatic encephalopathy episodes were similar, but there was decreased rebleeding with TIPS PVR and increased portal vein patency up to 36 months after TIPS placement. And so this randomized study shows that even with patients with portal vein thrombosis who have variceal bleeding, who are very challenging to anticoagulate, performing TIPS, this is probably the ideal patient population to attempt TIPS in. Here are a few slides on TIPS PVR technique. Again, I read Dr. Altaf's mind and I brought up transplantic TIPS. So this is a patient with main portal vein tumor thrombus and variceal bleeding. Here you can see from a transplantic approach, and this case, by the way, was done in Pakistan. You can see from a transplantic approach there's complete occlusion of the main portal vein. There are large esophageal varices. We're able to wedge our catheter into the nipple of the portal vein. And what we found, and Riyad Salem at Northwestern has done these studies where they've actually transplanted a lot of these patients. And when the transplant surgeon goes in and looks at the recanalized vein, it's as if it's a normal vein. So what we know now is that even though you don't see a vein going towards the main portal, there is a fibrosed cord that's going up, and it has endothelium within it. And so if you're able to pass your wire through it, put a TIPS in. Here you see kind of our catheter coming through. We put a snare into the thrombosed portal vein. We stick it with a cannula, get through and through access, a body floss access going from the transjugular vein out the left side through the transplantic access, place a TIP stent, and then here you can see that immediately the portal vein has opened up to a 10 millimeter vessel. The left portal vein has also opened up, and we also did some variceal embolization at the time, and this patient now has a normal portal vein. At our transplant center in Boston, we're doing this very frequently for patients who are transplant candidates who otherwise would require jump grafting or other techniques to get to a transplant. And we've also been offering this or training people to do this in Lahore as well, which I'll talk about at the end. So in the last few minutes, I'm going to talk about endoscopic vascular management of gastric variceal bleeding. As all of you know, GOV1 varices are typically treated with either a TIPS or with endoscopic band ligation, but GOV2 and IGV1 varices are the ones that we're talking about when we talk about gastric varices. According to the ASSLD, there should be no primary prophylaxis. Neither TIPS nor BRTOs are recommended to prevent first hemorrhage in patients who have fundal varices that have not bled. However, for management of acute gastric variceal bleeding that is not amenable to endoscopic therapy, those patients should undergo consideration of endovascular treatment. I'm going to skip this slide, talk briefly about the GRS anatomy, which is actually quite complex. There are multiple different afferent veins. We have to look at the gastric varices. The true gastric varices are those with submucosal components, such as you see here, but there's also extra mucosal components of the gastric varices, which are typically known as the false varices. So these are the afferent varices from the splenic vein, and then you have the efferent varices emptying through the left adrenal vein into the left renal vein. Skipping this slide, a typical BRTO, we would come from either a transjugular or a transfemoral route. We would place a balloon in the left adrenal vein, and then doing a balloon-occluded run, we'll be able to fill the gastric varices. And from here, we can inject any sclerosant and leave the balloon up, or we could place a plug or coils to embolize these varices. The BRTO technique is actually easier to perform than a TIPS technique. There have been 10 prospective studies, multiple retrospective studies, which have showed a high technical success rate of up to 97%, a high clinical success rate of up to 100%, low rebleeding rate if you treat gastric varices with a BRT approach, compared to a TIPS approach where we find 11 to 30% rebleeding rate from using a TIPS. And then the 1 year mortality is much lower with a BRT approach for gastric varices compared to TIPS. Finally, in the last couple of minutes, I'll talk about splenic artery embolization, where the hypothesis is that the splenic blood flow reduction may reduce portal hypertension. This hypothesis right now is relatively under-tested. This is the only significant study that I could find where they retrospectively reviewed 256 patients who underwent a TIPS procedure between January 2013 and November 2018 out in China. They enrolled patients, about 48 patients, with a TIPS group and a TIPS plus partial splenic embolization group. And what they showed was that the cumulative rate of remaining free of variceal rebleeding was much higher in the TIPS plus partial splenic embolization group compared to the non-TIPS group. I have to admit I only included these slides because it was part of the topic that was given to me by the organizers, but I have not typically used this technique in any of my patients, nor have I found the need to do this in patients who undergo TIPS. So in conclusion, early TIPS for patients with recurrent and refractory variceal bleeding improves mortality in patients with cirrhosis. For gastric variceal bleeding not amenable or responding to endoscopic therapy, BRTO is a safe and effective procedure, and partial splenic embolization has shown promising early results and may be useful in selected patients. In the end, before I finish, I'd like to highlight that in Pakistan, thanks to the mentorship that we have from Professor Ghiaz, over the last 5 years, we've built a nice interventional radiology group who has crossed that 20 TIPS threshold that I talked about in the experience for TIPS. And we have a good team, a large team of now interventional radiologists and assorted staff who have been performing TIPS, PVR TIPS, and TIPS prior to transplant in patients. And I think that there's a lot of room for growth for this particular procedure in Pakistan. Thank you.
Thank you, Dr. Amar. Our next presenter would be Dr. Badr Fayaz Zubairi. He is consultant physician and gastroenterologist, Dean of Medicine and Allied in Dow University of Health and Sciences. He's going to talk about recurrent portosystemic encephalopathy, the missing links.
Assalamu alaikum. I'll be talking about recurrent portosystemic encephalopathy and what are the missing links and why these patients are having repeated episodes and how we can address them. Yes. I'll start with the quote from the Sheila Sherlock, in which, as a long quote, you see that she has described a lot of problems with patients with portosystemic encephalopathy. Some of the groups of patients will be presenting with variceal hemorrhage, some will be presenting with encephalopathy, and another group of patients will be presenting with intellectual dysfunctions, in which we have minimal portal systemic encephalopathy, in which they have a different low IQs, they cannot perform highly skilled work. So there's a lot of variety of this patient presentation that can be present in this patient. Typically, when we talk about hepatic encephalopathy, there are majorly three types: type A, type B, and C. Now, type A is usually for the patient with acute hepatic and fulminant failure, is a totally different group. And type B is with the patients, yes, the type B is with the patients in which the liver is normal, but they do have developed some portosystemic shunts, either by the intervention or themselves on their own. The major talk of our patient types will be the type C, in which the patients are with cirrhosis and they have a portosystemic bypass. First, we have to look into what are the factors that precipitates this type of encephalopathy. And then we need to address them one by one, so the patient will not have recurrent episodes of such a disorder. As you might all be knowing that there's an infection, GI bleed, overuse of diuretics, electrolyte disorders, constipation, concurrently using of psychoactive drugs, dehydration, or dietary indiscretion. We need to look into the mechanism of hepatic encephalopathy in these patients also, and that is the most important thing that we consider is ammonia formation. Now, ammonia formation is a thing that we have to establish that there is ammonia regulation, but it does not correlate with the grade of encephalopathy. So it does form the precipitation of this, but it is not related to the grade of encephalopathy. If you look at the grading of encephalopathy, these ammonia levels have a very poor correlation with those. So we have, among the mechanisms, up regulation of astrocytes in the peripheral blood and dysregulation of benzodiazepine receptors, and neurosteroid production is impaired, and then modulation of GABA and hepatic encephalopathy precipitating these things. Graphically, if you look at this, you see there is you see a lot of bacterial load coming from the gut. Now, this is one of the reasons that we have to reduce this. This is one of the factors which will cause repeated episodes of hepatic encephalopathy. And to reduce this, we have to check that the person does not bleed, does not have a very high protein intake, and then if there are the tips are produced or the shunts are produced, then these may bypass the liver and they will not be cleared and will go into, or if the varicose, which is not present in the normal person, in the portal systemic, these varices have opened up, and shunting of these products goes into the systemic circulation via this. Now, this ammonia has to be detoxified from the gut, which will show in the next slide, and then they go into the GABA and receptors and toxins into this. So every action we have to check that we can stop this from the gut. We have to see that the tips placement, if have occurred, has to be reduced, the size of the tips has to be reduced, and if there are the shunting, then we need to address these shunts, either with band ligation or with BAR2 and other systems that are available currently. Now, Adrian has said a very beautiful line, and I like to quote it here, that blood ammonia level cause a much confusion in those requesting the measurement as in the patient in whom they are being measured. This immaculately depicts that although ammonia is one of the major cause of hepatic encephalopathy, but we should not overuse this, or we should not overstress its levels with the grading of encephalopathy, because various studies have shown that they do not correlate with the grading of hepatic encephalopathy. Now, when we focus upon the treatment can be luminal or extraluminal. When we talk about luminal, then the therapy of non-absorbable disaccharide like lactazose, lactidol, rifaximin, probiotics, they reduce the nitrogenous load and in the gut and impair function, and portostomach sensitivity should be reduced when we talk about this gland. Now you see a very important role of lactulose, where we differentiate it from any, or lactidol from any other laxative. It's very important that not every laxative is going to work like that of lactidol or lactulose, that the pH of the gut has to be made acidic. That's very important. So when the pH of the gut is made into acidic form, this ammonia production from the urease production and the blood, if present in the gut, is reduced, and this converts NH3 conversion to NH4 conversion is acid dependent. If it is acidic in gut, this will form towards the ammonia formation and it will be excreted in the gut, in the stools. But if it is not acidic, it will turn into ammonia, which will cross this gut barrier and will go into the blood and will cause all the problems of ammonia. And moreover, these lactulose and lactidol do have a laxative effect, which this will be excreted out. So by this mechanism, you can understand that maintaining the acidic environment of the colon is very important and is one of the factors which can precipitate for repeated actions of portosystemic encephalopathy. Now, when we talk about extraluminal treatment options, the medications that reduce ammonia by providing alternative pathways of metabolism like glycerol, phenol butyrate, or branch chain amino acids can be used, that have shown to decrease this load presenting towards the gut. Interventions that decrease portosystemic shunting by embolization of large portosystemic shunts like balloon occluded retrograde transvenous orbital, like just talked before, presenter BRTO, of large spontaneous splenorenal shunts will cause this decreased presentation of the shunting and will be betterment of the encephalopathy in this patient. So we need to see if the patient are having multiple shunts at splenorenal agent or gastrorenal agents, we need to stop that and occlude them, so there will be a betterment in these patients of repeated encephalopathies. Now, the role of zinc. There are two major organs that are involved in metabolism of ammonia. One is the liver, in which ammonia is converted into urea, and the second is the skeletal muscle, where ammonia is metabolized into glutamic acid via glutamate synthesis. Now, zinc is a critical factor in these enzymatic reactions, and in some animal models it has shown that zinc deficiency decreases this activity of ornithine, while the zinc supplementation markedly increases hepatic ornithine transcarbamylase activity. So there are various trials have been done, and one of the meta-analysis that I'm quoting here is that the 4 trials of total 233 patients were included, and oral zinc supplementation was associated with significant improvement and performance on number connection tests, and was reported in 3 of these trials. Other significant outcomes like mortality, related morbidity, quality of life were not reported in these trials, so I cannot comment on those. Now in this plot, forest plot, for the number connection test, it has shown, you see, all of these are having better for the zinc replacement therapy, and then we see the mean average of this forest plot for the number connection test, that is the quality of life, the zinc supplementation has been. So a zinc supplementation can improve the quality of life and reduce the episodes of repeated episodes of hepatosystemic encephalopathy. Now, also for the forest plot has been given that for hepatic encephalopathy, that was for number connection test, and now the hepatic encephalopathy also is not so strong as that for number connection test, but still the median is on the left side of the graph, and it shows with the better of the zinc, and we see that these trials have shown that a zinc supplementation will have a betterment in the patients with repeated and reduce the episodes of repeated hepatopathy. Now coming to the diet, there have been much misconceptions about the diet, and people will either stop it or will say there is no protein diet. So unless most instances the normal diet is continued, unless the patient has a severe encephalopathy in which only 30 to 40 grams in divided doses in 3 meals can be allowed. So restriction comes in severe encephalopathy, and it has been shown that the vegetable proteins are better tolerated in terms of cerebral function rather than the animal protein in these patients. And some rare causes in which the genetic deficiency of enzyme of N-acetylglutamate synthetase will lead to repeated episodes of encephalopathy in these patients. So we can check if this enzyme is deficient in select patients. Now we come to shunt embolization. That is a very important step that can be taken to reduce the repeated episodes which needs the splenorenal shunt, gastrorenal shunt, intrahepatic portal vein and hepatic vein shunts, and shunt embolizing using stainless steel coils can be done either via percutaneous transhepatic portal vein approach or transrenal approach. So both these approaches can be undertaken to reduce the shunt size and improve the outcome. Now in this you can see there is a confluence with ectatic left renal vein. You can see this here renal vein and there, and the shunts can be placed over here. And similarly, there is a sphenogastric vein indirect in these images. You can see that here, and from here to here this screen. So a shunt, when placed properly, will occlude and will reduce the amount of the hepatic encephalopathy. Now, we just heard about Berto, and the balloon occluded retrograde transvenous obliteration has been recently been introduced and is a new intervention modality to prevent fatal bleeding from solitary gastric varices. But solitary gastric varices sometimes also precipitates hepatic encephalopathy, it has been shown, and so large portosystemic shunt including gastric varices can also cause these hepatic encephalopathy in some cirrhotic patients, and it's better to embolize them, and thus you hit the 2 sparrows with 1 arrow and you have a better response. So the technical success rate of Barto is around 91%, intention to treat obliteration in 86% as reported, obliteration rate of gastric varices is around 94%, and Bartos is successful in controlling the active gastric variceal bleeding in 95% of cases and significantly reducing or resolving encephalopathy in nearly 100% of patients. Some of the adverse effects of Barto we should be aware of, that it diverts blood into the portal circulation and increase the portal hypertension, thus aggravating the esophageal varices and their potential for bleeding. So as done by the previous speaker, that at the same time coil embolization should be undertaken in these patients. Gastric variceal rebleed rate of successful Barto procedure and the intentional to treat variceal bleed and global and all type of varices are shown as good, very good trend. But Barto also have an advantage that it diverts blood into the portal circulation and potentially improves the hepatic function to some extent, although this function is not a permanent one and can last up to 2 to 3 years after these procedures. So coming to the conclusion, diet, ammonia, pH of the colon, zinc, GI bleed, shunt closure, and should be used to prevent these repeated episodes and also common sense, which is really not so common in these patients. Thank you so much for your time.
Thank you, sir. That was very enlightening. Now I would like to call upon stage Dr. Zahid Azam. He is Professor of Medicine and GI at Dow International.
Bismillah ar-Rahman ar-Rahim. I'm thankful for the organizer, as well as it's very difficult for me to be the end of the talk where we have namaz as well coming up. I'm thankful to Professor Taraf Alam, who has also helped me in covering majority of the topic. There was some overlap. So coagulation in cirrhosis, basically there is a play of thrombosis as well as bleeding, and in portal hypertension the bleeding may be because of the pressure effect or the high HEPG, and this could be the mucosal or punctate hemorrhages where the bleeding is premature clot dissolution. This is a term that we call accelerated intravascular coagulation and fibrinolysis. So here we have a patient with cirrhosis who have coagulation problem, and what are the reasons? Patient with liver disease may acquire complex alteration in their hemostasis. One is AICF. Then we have increased von Willebrand factor, increased procoagulant factors like factor 5, factor 7, and factor 8, factor 10, and then decreased anticoagulant like protein C, increased endothelial drive factor, which is a procoagulant factor, factor 8, and then thrombocytopenia and alteration in the platelet function and low level of fibrinolytic proteins. Majority of this is because of the poor synthetic function of these proteins that lead to the haywire distribution of these proteins. This is the rebalanced hemostasis already touched upon by Professor Altaf Alam as well. This is the normal situation where we have a very balanced situation of bleeding and thrombosis. And here though we have balance, but this is very unstable balance in the sense that it can tip off anywhere because of the patient is prone to any situation leading to thrombosis. So in this hemostatic balance, basically thrombocytopenia, platelet dysfunction, and enhanced production of nitric oxide and prostacyclin are the changes promoting bleeding, whereas elevated levels and other things are counteracting this. And same is the case with secondary hemostasis and fibrinolysis, where these factors are playing around. Coming to INR, we are talking about INR and placing very high emphasis on INR in terms of correction of INR for the procedures. So this is the most problematic area, especially as it measures procoagulant factor and does not measure deficient of anticoagulant factor which are derived from the liver. So most of the time we are using FFPs to correct this INR. Majority of the time this is seen prolonged in liver disease and cirrhosis. But it changes the factor too, but does not exacerbate, and it does exacerbate portal hypertension, especially when we are dealing with varicose hemorrhage and we transfuse FFP that refills the pressure in the vein and can lead to further bleeding. The platelet counts that are low in cirrhosis because of platelet sequestration in the spleen, as well as because of dysfunction of the platelet. The target is basically platelet level in the 50 to 60,000 range, promotes thrombin generation, and this lead to be the target for prophylaxis, because we need prophylaxis because this becomes a procoagulant. However, elevated von Willebrand factor and increased coagulation activation platelet in cirrhosis does not have been taken into consideration, and that's why thrombocytopenia and cirrhosis is a multifactorial involving shortened platelet survival, dysfunction, as well as sequestration. Important thing is fibrogen. most of the time in our practice, we do not take in consideration of fibrinogen level, potentially more meaningful, this more meaningful than INR, to couple with the platelet level as a measure of rebleeding and the bleeding risk. When replenishing is desired for procedure, cryoprecipitate can be used, and because it is cryoprecipitate is in small volume, that gives you the fibrinogen, and it is more useful in terms of doing procedure after correction of the coagulation state. So 98% of the fibrinogen is synthesized in the liver, and its half-life is approximately 4 days, and is a healthy individual which is shortened in cirrhosis. As compared to FFP, the half-life of factor 7 in the FFP is only 7 hours, 5 to 7 hours. So there is a short-lived. Here we have relatively longer half-life, and also the volume is very low, so it doesn't expand the vasculature, especially when you are dealing with any hemorrhagic situation. Then peri-procedural management of hemostasis. So majority of the time when we are talking about hemostasis, these are general measures which is optimize anemia, because if you have anemia, this can increase vulnerability bound factor. We need to treat infection or optimize renal function and avoid acidosis. Good hydration is also recommended. So prophylactic administration of platelet or fibrinogen concentrate, cryoprecipitate, may be performed with highly abnormal platelet count, like less than 20,000. So majority of the time we do not need low risk procedure with the FFP coverage or cryoprecipitate coverage. This is only needed when you have fibrinogen level less than 1 and less than 20. We are going to talk about the levels in the third slide. So the important thing is coagulation assessment of for the procedure. The normal practice, especially my apologies to radiologist, I'm also facing in my center, and maybe you may be also facing with other centers, that our radiologist asks for the platelet and correction of the prothrombin time. So it is recommended the majority of the diagnostic and therapeutic procedures like abdominal paracentesis or thoracentesis doesn't require FFP or cryoprecipitate. Even upper GI endoscopy for screening or therapeutic endoscopy for band ligation, you do not need to get the cryoprecipitate or FFP or platelets. And even for the diagnostic colonoscopy, for colonoscopy where you are expecting polypectomy in a cirrhotic patient, yes, do consider correction, but otherwise routinely they are not required. This does, and the important thing is this does not apply for those patients who are already on anticoagulants or have renal function, because in renal function the platelet quantity and quality both are compromised, and for pharmacological to give them with the coverage. So how to prevent thrombosis? Basically, it was thought that cirrhosis is a procoagulant, is an autoanticoagulant state. This was a myth, and in 2006 this myth was challenged clearly, where we know came across that venous thromboembolism is increased in cirrhotic patients. So the role of anticoagulants in prevention of venous thromboembolism in patients with cirrhosis remains limited. And by means of venous thromboembolism, I'm talking about portal vein thrombosis, I'm talking about mesenteric thrombosis, and sometimes even deep vein thrombosis. In 2014, a study showed that patients with cirrhosis treated prophylactically to prevent venous thromboembolism had low rates of gastrointestinal bleeding as compared to those who were not given prophylaxis. And even in current guidelines supports use of thromboprophylaxis in patients with cirrhosis. So the myth of FFP and cryoprecipitate, fresh frozen plasma approximately, this is 250 ml per unit, and it is dosed as 10 ml per kg. It's not recommended to correct any coagulation factor deficiency if It in fact exacerbates portal hypertension because of the increasing flow and volume. So cryoprecipitate, which has a low volume, it's 10 to 20 ml per unit, and the increase in plasma fibrinogen level from 1 unit of cryoprecipitate per 10 kg body weight will be approximately 50 milligram per deciliter. An average of 5 to 10 units of cryoprecipitate increases your level of 50 to 200, and we should have. Coming to the platelet transfusion in cirrhotic patients, pooled platelet of 5 to 6 single unit donors drive is less as compared to a single unit, which is beneficial because of the use of and it decreases the immunogenicity. Total volume infused is approximately 250 ml per platelet rich plasma, and the half-life is also decreased. So the best thing is use of medicine, L-Tempopag. We are already aware of this. The only problem with L-Tempopag is that sometime when it's not checked regularly, it may cause and increases the level to normal. It may be associated with portal vein thrombosis. The new agents, Eventropopag and Lustropag, they have better efficacy. And here we have to give for 5 days in elective procedure. I'm not talking about emergent procedure, but in elective procedure you can give for 5 days this product, and the effect remains for a longer time, and you can do the procedure after 10 days. And this remains for 10 to 12 days, the effect. And for the second agent, you can give for 1 week, 7 days, and then you can do the procedure after 8th day, and the effect remains longer till 2 weeks. Antifibrinolytic agents are rarely used as prophylaxis, more commonly used as rescue measure if bleeding occurs after procedures. So tranexamic acid, we are all aware, this may be given in a dose of 1 gram IV every 6 hourly, but recent data published from Halted showed that tranexamic acid did not reduce death, but was associated with a somewhat increased risk of thromboembolic event in cirrhotic patients when this was treated with IV tranexamic acid. So, as we know now that chronic liver disease is a procoagulant state, venous thromboembolism does not decrease in CLD, and in fact, the odds ratio of getting venous thromboembolism is 1.5 times higher in cirrhotics, and has a poor outcome in cirrhosis. So, just quickly, the portal vein may be treated with IV heparin infusion followed by low molecular weight heparin in acute setup, where you have the acute 2 trial documented dose superiority over warfarin, but the problem is dose can be given in child A and early child B, but not in child C. So my last slide, I'm going to conclude here. Platelet more than 50,000 is the requirement in patient. So this is if the patient, and we do not need to recheck. Majority of the time our interventions ask for recheck of the platelet in normal setting. In anticoagulant therapy, acute settings such as new portal vein or extension of the prior thrombosis, systemic anticoagulant should be initiated. For active bleeding and portal hypertension related bleeding, antiportal hypertensive intervention, you need to minimize the volume, so cryoprecipitate can be used in this setting instead of FFP. A value of 120 milligram per deciliter of fibrinogen is the cutoff that need to be maintained, and controlled induction and optimized. So just to conclude, the coagulation cascade is rebalance of the patient is cirrhotic. A standard measure of coagulation such as INR is poorly correlated, and transfusion carries significant risk, so we should be considering on low volume. Assessment of patient pre-procedural bleeding risk one should have to ensure treatment is necessary to prevent bleeding, as several procedures like paracentesis and thoracocentric diagnostic endoscopy do not require to check or replenish your platelet and FFP cover, and platelet number and fibrinogen level are adequate markers and can be used in acute bleeding setting. Thank you very much for your patient listening.
Thank you very much, Dr. Zahid. With that, we conclude our presentations for this session. Before going to the Juma break and lunch, may I have a brief comment from the panel of experts, please?
I think we are getting short of time. I'm very thankful to all the speakers. They were very eloquent and interesting topics were discussed and was very educational. I have a small conceptual question from our colleague from Baylor, Texas. There is a group of anti-diabetes drugs like empagliflozin and dapagliflozin which cause osmotic diuresis, and the spin-off effect is that they have been found very useful in congestive cardiac failure. So do they have any place as diuretics or fluid load decreasing medicines in cirrhotics with ascites?
Kindly hand over the mic, please.
Thanks. I think the short answer is no. The pathophysiology of fluid retention and ascites and cirrhosis is very particular and mediated by a different mechanism. So that's why the cornerstone for treatment is really based upon furosemide and agents that work on the aldosterone pathway, so spironolactone and related medications. So not that I am aware of, not that we use them.
Thank you. I think back to you.
With that, we conclude this session. Our next session is going to be on women in gastroenterology. While we go on a Juma break, people who want to stay here and take this session, lunch would be served in this hall as well for those people. So with that, we sign off from the session. Thank you so much. For pictures and shield, please come to all the presenters and panel of experts, please come to the picture booth.
I request all the women to come in the first seats. The first half of the hall is all empty. Hello. मैम मेरा अभी सेशन मॉडरेट कर इधर ही kindly settle down. We'll be starting shortly. The front rows are empty. Kindly settle down. I am Dr. Farwa Javed. Welcome to the symposium on women in gastroenterology. This topic is very close to my heart, as when I joined gastroenterology in year 2013, that was the most frequent question that was asked was, why did you join gastroenterology? I see more and more women in gastroenterology today, and that makes me very happy. And all the women involved in this symposium are a continuous source of inspiration for all the young emerging female gastroenterologists in the country. Let me introduce the panel of experts and guest of honor for today. The guest of honor for the session are Dr. Asma Shaukat. She'll be joining us shortly. She's currently serving as Professor of Medicine and Population Health, Director of GI Outcome Research, NYU Grossman School of Medicine. And Dr. Fasiya Kawal, who's Chief Gastroenterologist and Hepatologist, Bayer College of Medicine, Houston. Our panel of experts for today are Dr. Lubna Kamani. She's Professor of Gastroenterology at Liaquat National Hospital, Karachi. Ma'am, would you like to come to the stage, please? Thank you. Dr. Nazish Bhatt, Consultant Gastroenterologist and Hepatologist at Jinnah Postgraduate Medical Center and National Medical Center, Karachi. And Professor Bushra Khar, she's Professor of Medicine working at Holy Family Hospital, Rawalpindi. So we'll be starting with the first lecture of the day by Dr. Fasiya Kawal, and she will be talking about opportunities and advanced training in hepatology for female Pakistani hepatologists in USA.
Assalamu alaikum. Acha ji, before I start, let me just get an idea of who's really in the audience. Who is now working, other than the panelist here, who's finished their training and working as gastroenterologists? Just a couple? And the rest are still in training? Can you raise your hand if you're still in training? Okay, that's great, that's wonderful. All right, so I think they're having difficulty finding my talk. So as they are looking, I'm sorry? Yeah, no, I can get us started. So just don't hold me to that 15. Thought was to have a broader dialogue with you all. So instead of that specific narrow topic, I am actually going to talk to you about challenges and opportunities that we have as women in gastroenterology. So that's, my overarching goal for today, to really share some of my journey with you, some of the challenges that you might think are specific to you, but in reality, they apply to lots of us. Not just actually women, I would say even men in our field. So that is why I thought that it is important to have a broader dialogue and a broader topic. Still having some challenges finding this. So while they're getting us started, maybe I can have another show of hands. How many of you thought about gastroenterology as a field that's dominated by men? 1, 2, 3, 4. Excellent, yeah. When you finished your medical school, your college, what was the split in men and women in your graduating class? 50-50? 70-30. 70 what? So just imagine 70% women in the class that's graduating, and then in a field, what's the split in the field? It's reverse. I would be surprised if even 70-30 in the reverse order. And then what's the distribution as you go up in the ranks? Full professors and head of the departments. Think of that for the split, the gender split. I think we have a handful of people sitting here that probably not a whole lot more than that. So see, there are things that we need to talk about. There are things that hopefully need to be fixed. All right, I see we are back online. Very good. Can I also have this here so I can move? All right, so here, I think, yeah, it's, while they give me control, this is what I was talking about. And these are data from the US. So we actually are much, okay, but can I see it here? I don't want to keep looking back. Yahan nazar aayega? अच्छा मुझे पीछे मुड़ना पड़ेगा इसके लिए देखा challenges starting from this challenge I hate to look back but I'll do the best that I can अच्छा this is what we started with this is a split equal pink are women and blue men this is US medical schools 50-50 equally split equally distributed really nicely balanced right same thing for training in internal medicine training it's pretty fairly balanced between men and women. But really as it is here, it's the same story there as well, that the field, the GI field is predominantly a men predominant field. However, it's changing. It's changing there and I'm seeing that it's changing here also. So in 2000, only 16% of the GI fellows, which is the postdocs, they were women. And now if you look at more recent data, it's about the third. The 1/3 are now women, and these numbers are improving. So we're making gains in the number of women that are now getting trained as specialists, as gastroenterologists. But the problem is that this gain in these numbers is actually counterbalanced by attrition. Attrition meaning loss of people, loss of women. And it happens quite early on. In the first 6 to 10 years after finishing training, women, they are significantly more likely not to work full time, or even if they're working full time, they're thinking of cutting back. So within the first 6 to 10 years after finishing training, it was really very nicely depicted in this recent study. It was a survey study. They're following people over time, people who finished their residency, and now they are in practice. And they follow them, year 1 after training, year 2, year 3, so they kept surveying these people for the first 6 years. And what they found that within the first 6 years of training, 3/4, meaning 3 in 4 women physicians were either working less than full time or they were thinking of cutting back. It's a big number, meaning just 1 in 4 women, they're working full time. So really, I think this divergence, these numbers, this attrition, it has consequences. And I'll talk about the consequences in a minute, but before I do that, let me just talk about some of the challenges. Why is that the case? And that is what I was mentioning earlier on, that you might think that those are your challenges, but the reality is that they cross-cut most women. They're challenges that we all have experienced. I'll go over the challenges and I'll give you some of the tips that I have used, other people might have used, and the goal is really to make sure that we can all have this dialogue. And by the way, I'm not an expert in this. Your experiences are as valuable, maybe more valuable than my experience. I really want to hear from you, all right? So I am going to just talk about 3 main challenges, and I'll give you some strategies after that. It doesn't mean that these are the only challenges. Just I picked 3 in the interest of time. Okay, the very first challenge is that we as women, we actually take more time in taking care of our patients. Would you agree with that? And this is evidence-based. I'm not making it up. There's studies that show that women, we take more time and more care in caring for our patients, and actually, it improves their outcomes. So there's this very interesting study that patients who were treated by women internists or medical doctors, their outcomes were better. They had lower mortality, lower readmission compared to those patients who were being taken care of by men. So we do take it very seriously, and our diligence is very high. And while we're spending more time in taking care of our patients at work, we also shoulder more responsibilities out of work. Right? We are always trying to balance our families, for those of us who have kids, and our career all the time. And this is also evidence-based. We spend more time in taking care of our kids than our male colleagues. And women in medicine, they tend to feel this guilt over not spending enough time with their families, while also feeling the guilt and the need to further develop their careers. So I want another raise of hands. Who in the audience has felt this guilt? All the time. For all of my career, I've lived in this constant guilt that I'm not doing enough for the kids or I'm not doing enough for work. But I'm trying to tell myself now, after all these years, that, this is what it is, and I'll talk about that in a minute too. I have to say some people are wiser than I am. And they don't have that, but I'm not one of those people. I'm like that person on the Pink, the female K awardee. The thing that I prize the most, and I know that I share with other women in academic medicine, is really being able to have both the family and a successful career. It's crazy busy with the two, but without the two, it just wouldn't be as satisfying and as fulfilling. I want it all. I'm sure there are many people here who have similar stories. And also, the male mentor, the blue box at the bottom, is right on. Perhaps guilt that comes with not being there is felt by women more than men. I do believe there's a lot of angst and worry that comes with not being there for your kids. And while we're trying to also struggle with these, okay, now I'm going to switch here. So as it is, it was difficult. COVID made it worse. So again, this is data from a very important journal, JAMA Network Open. It's the same group of people who are doing surveys for residents and interns and following them over time. When they did the survey, they found that female physicians were far more likely during COVID to take more responsibility for childcare, to work from home, and also responsible for the household chores compared to the male physicians. And this wasn't without any consequence. There were effects of this. When looking at these graphs, the first set of dots, the very first set of dots, these are the depression screening scores for men and women before COVID. They were the same, and again, they're all physicians. But with COVID, look how it split, how it diverged. Female physicians, they were more likely to report higher depression scores, higher burnout, and lower professional satisfaction during COVID. So these things are real, and they have an effect. And not just that we're trying to constantly balance and deal with these internal struggles between family and life, the cultures at our workplace, they don't help either. So there are these stereotypes, there are these implicit biases that are there in the workplace. I have to say some workplaces are really taking it seriously, at least in the US, but there is so much work to be done in other places. And I think part of that is this mental image that we have of perfect, ideal worker. To be really rising up on the leadership ranks, you have to be available 24/7. That's in our heads. That's the mental image. And really, it's just not compatible with our careers and our lives, which really makes it less attractive for very, very many women as they rise up the leadership rank. And I have to say also for men. This mental image is making it very difficult for even some men as well. And most of these might not be completely under our control, but I think it's important to lay it out because these really are challenges that we face. So this is all challenges, but I have to say it's not all bad. It's not all doom and gloom. There are many people sitting right here. I'm standing right here. You are all here. We all have our stories, and I have to say these are success stories. The fact that we're here together means that we can do it. So before I talk about that, I also want to point out that I'm not undermining or underestimating the importance of these issues. The constant struggle with time management, time constraints, this constant balance between family and work, and also these sort of inflexible work routines, they have consequences. There's a higher burnout rate, lower productivity, and lower advancement for women. And the problem is that does go up, increase as we go up on the ladders. So yes, the graduating class is equally split between men and women. But as you go to the middle and to the more senior career roles, these curves, they start to diverge and it becomes bigger and bigger. So just looking at some US data, and I don't have access to the data from Pakistan, but the US data, the pink bar is women, junior assistant professor and see what happens to that pink bar as you move. It gets smaller and smaller and smaller. And among all the GI fellowship programs in the country, in the US, there are 163, only 18% are program directors are women. Although about 50% trainees are women, only 18% of program directors are women, and only 7% of division chiefs are women, and I'm one of them. So there is this divide that happens, and it happens as people go up on the rank. So, as I said, looks bad, but it's not that bad. We could do it. We are here. We made it. We can also move forward. So I'm going to, in the next few minutes, share some of the strategies that I've used, that also I have to remind myself, because I'm not really very good at some of these, but I think are useful for you guys to think about as you think of your careers. There are lots. I won't be able to go through all of them in the interest of time, but I'm going to focus on these first 4 because I think they're harder to develop and to cultivate, but they're important. So the very first one is that you have to know and you have to accept your limitations. And I think this applies not just to women who are sitting in the front, but also to the men in medicine now. We all deal with work-life conflicts, but we want it all. So we will have to accept that we will always be multitasking. And we'll have to accept that there will never be a perfect time to do all that you want. So you just have to do it. Also, it's important to know that each day is not going to be balanced. But you can strike a balance over weeks and months. So having that mindset is important. So knowing and accepting is the very first part. Once you've done that, then you have to understand your strengths and your value that you bring to your workplace and to the practice that you're in. You've gotten here because of those strengths. And now you have to know what they are and you have to cultivate them. In general, and all of us have different strengths, so I won't be able to say what they are, but in general, all of us we are perfect. We're master multitaskers. We can do many things well at the same time. And we're also highly collaborative. We're also very strategic, and we stick with it. So those are our strengths, and we really need to understand them and need to cultivate them. And also sometimes for men, it's difficult to really know how women think. So use that. Use that to your advantage. Another thing that we are really terrible at, including myself, we don't ask. When was the last time anyone here really asked for a higher salary or, asked for a special role in your unit? Raise your hand. We don't ask. As my role as a division chief, I was struck by how different men and women are in terms of asking. Men, they ask twice as much as women and then negotiate 4 times as much as women. And that's true. We just don't ask. Our social expectations, they typically include that we just have to wait and wait to be promoted. And we think of the controls as an external thing, and we just, our bosses would ask us if I just work harder or, stick with it, and I struggle with it myself too. But really, I think all of you and myself also, we really need to start to learn to ask. Yes, it will need some thinking, it will need some planning, data, to make sure our ask is supported, and lots of guts. But I think we need to start doing it. And build your network. So that's why I thought this is such a wonderful idea and a venue, a platform to get us all together, because really what will help us the most is to build up a network of sponsors. There are many examples outside of here. I was part of the AGA Women in GI regional workshops. We led one. There's several around with ASGE, ACG, and I think this is, again, will be one of those wonderful opportunities where we will create that network. And there are also actually data that show that women who have more women in their internal circle, they tend to progress faster. It doesn't really matter for men who is in the inner circle, but for women it does. So we really need to work together and elevate ourselves together to really go to the next step. Also some other things, thinking about strategically finding your niche, using the advantage of your environment and volunteering. They again apply to both men and women. I think we just need to be aware of them and make sure we use those strategies. Again, I won't be able to go into detail for these, but they are here and I can answer any questions that you have afterwards. So this was the actual topic that I was given. So I'm going to take a minute to go over that, but I thought other things were more important. So for hepatology training, a more advanced training in the US, you have to go through residency and to GI training before you could do transplant hepatology fellowship. There are multiple pathways for transplant hepatology fellowship. One is, the most traditional one is after GI fellowship, so it increases the number of training years that you have, but it has really great advantages. That's the one that I did, because it gives you more time for GI training. It also gives you dedicated time for hepatology and transplant hepatology training. You can also really get exposed to research and thinking about scholarly work. So it's an advantage. There are many programs, I think close to 60 programs in the US right now with these pathways. There are also other ways to do transplant hepatology. You could do it after just internal medicine residency, though I think GI training, it does really add a lot of value to that pathway. So I can also take any questions that you have about this after we get done, but that's something, a resource for you to be aware of. Some of the resources also, I think, again, going back to those networks, there are specific networks for women in hepatology also. So EASL has one, and then AASLD is also starting one. It's the Women Initiative Committee. And we just had a conversation about really partnering with AASLD to really elevate this forum even more. One other thing that I would mention, people don't think about it, there are opportunities for research. So it might be easier for those who are interested in research careers, because there could be remote mentoring. We've tried it a few times with our group and it has been very successful. And there could be other innovative programs that could really make it possible for women to come to the US for more research exposure. We just have to figure out how to really make it happen, but that also is possible. So again, just to wrap up, I reviewed with you some very pragmatic approaches to the barriers that we face so that we can thrive and succeed. One point that I didn't really talk very much about, I don't want to underemphasize this, that there are cultural constructs within our institutions that we might not have much influence on at this point. I can't change it, you cannot change it alone. But having this forum, it's a way to start the dialogue. And I think with time, we can make a difference there as well. But really things that you can really do is to start thinking strategically. It's really a marathon, it's not a sprint, so plan long term. Know your strengths, you all have strengths to be able to get here. Find your niche, and find your mentors, and your sponsors, and your village. That will go a long way. And as I mentioned, yes, your village needs to have women, but I have benefited a lot from men as my mentors and as my sponsors. So really find those people who believe in you, and they will elevate you. Make sure you know how to work with them. And you just cannot give up. You have to be persistent, you have to be resilient, and really in the end, it's a wonderful journey. So try to enjoy the journey, take a minute, look around, enjoy, and then move on. Thank you so much. I will end here.
Thank you, ma'am. We thought that life and work-life balance was difficult for women in gastroenterology in Pakistan, but after listening to Ma'am Vasia, we think it's the same everywhere. So as a conclusion, women need to ask for more, negotiate more, and accept our limitations, and at the same time, we should enjoy the journey. Okay? Moving on to the next lecture of the day. It's by Dr. Amna Subhan, and she will talk about challenges in training and practice for female gastroenterologists in Pakistan. Dr. Amna is Associate Professor of Gastroenterology and Program Director of Gastroenterology. She is also currently serving as Joint Secretary of Pakistan Society of Gastroenterology and GI Endoscopy.
All right, so thank you very much, Farwa. And first of all, I would like to thank Professor Gastroenterology and Professor Israr and the whole organizing committee for giving us this opportunity to speak on this forum. So my dear girls, I need your attention. How are you guys doing today? Say it loudly. Good. Say it loud. How's the day? Great. Here comes you are. Okay? So whatever the situation is, the first message, whatever the way is, try to just... So I'll be talking about few things you may or may not be aware. Probably you all are aware of whatever I'm going to talk about it. But I think it's sometimes the repetition is actually help you to register, and sometimes it actually gives you an insight about that, where my road is going, how can I find out my new ways, and whatever the challenges I've been thinking others are facing, what could be the potential solution in the future. So no conflict of interest. Interventional fields of medicine, whether these are like surgeries, just like surgeries and all, they're less chosen by the women. No one denies about it. So someone is actually mentioning about it that this is something which is not easy. The entire journey and then hiccups which come in between. It's actually in every subspecialty, but especially in the interventional subspecialty where there lots of hiccups will come and the people will look for that how actually these issues could be fixed up. I see is actually a little bit in a different way. I see it is actually the field of the gastroenterology just like as a park, and you are actually living in this park and you are actually having your journey. And someone who believes on merit and the possibilities and exploring the possibilities, I know that there are lots of issues one can see and face and experience at a training stage, and when you are actually building your career as an early career, mid-career, and as a senior faculty. So issues will always be there. Remember that. Challenges will always be there. This is you and me who will actually develop an insight that how I need to handle these challenges. So I'll be briefly talking about that what are the training opportunities and challenges in Pakistan, and what the women in GIs actually face challenges, and what are the opportunities for them when they are in practice. When they're in clinical practice, what are the issues in presentation in the national societies. So there are two types of the pathways. In young, most of you seems to like trainees. Can you just raise hand how many of you are trainees so that I can have some idea about it? Great. And the rest of the people are faculties? Can you please raise your hands? All right. So most of you are actually trainees. So we all know that there are two types of the programs that are available in Pakistan, FCPS in gastroenterology, one of the most adopted one, especially by the women, and then the MD in gastroenterology. So if FCPS GI till before 2020, it was actually a first fellowship where you do is actually do an MBBS, first year house job, FCPS 1, 2 years of internal medicine, and then 3 years of a gastroenterology, which simply means that at least 6 years in training, you minus the time period you actually take for clearance of the exam, but in training you are in 6 years plus 5 years of MBBS, which means that at least 11 years of exposure in undergraduate and postgraduate is actually fulfills your eligibility criteria. And then you can add on 1 year passing different examination, and after 12 years of this entire efforts, you become a gastroenterologist. On the other hand, with the new model of CPSP, which is GI as a second fellowship, the duration is now pretty long, which simply means that you do an MBBS, then you do a house job, FCPS 1, 4 years of internal medicine, and then after clearance of internal medicine, FCPS, you will be eligible for 3 years training in GI as a second fellowship. And after that, CPSP is actually working on to develop advanced fellowships as a third fellowship, which simply means that 8 plus 5 years minimum to become a gastroenterologist, plus minus 1 or 2 years in clearing an exam, and you can make it, you will be needing at least 13 to 14 years to become a gastroenterologist after starting your journey. So in MD gastroenterology, the mechanism is a little different, but the journey and the pathways are like actually of same duration. So how much are the training opportunities in Pakistan? At least 42 centers for FCPS, and you can see over there that mostly in Punjab, most of the centers are located, followed by in Sindh, KPK, Balochistan, only one center. I try to get the data about what is the situation about the training opportunities in MD gastroenterology. I could not find out a very authentic source, but this is what I could actually find out, that most of the centers are actually in Punjab, in Pindi in Islamabad, and one is actually Sindh. I'm not sure about this university is offering MD in gastroenterology or not, and I'm not sure about Balochistan. But relatively less centers. Seems like FCPS in gastroenterology stands out till now as actually the most opted program in gastroenterology. On the other hand, if you just looked at approximately 48% of the population of Pakistan is actually of females, and female doctor to female Pakistani population ratio is again very, the difference is like quite a bigger one. And you can imagine that what is the ratio for the gastroenterologists available in Pakistan. So how many trainees then? How many people is actually opted for the training in gastroenterology in Pakistan? So this is a very recent update about how many trainees has been registered with RTMC of CPSP right now. So and you can see that right now 43% are women. But if you could go back 10 years back, you could see that there was a very few women in the gastroenterology. So there is an incremental trend over the period of time, and now this ratio is about 43%. On the other hand, this is something alarming. Can you imagine only 5 female supervisors? Only 5 female supervisors are existing in Pakistan in the field of gastroenterology. And this is 2023. And other than that, out of these 5, 3 are coming from one program. So what the rest of the programs are doing, and what is happening with the graduates of other program, and if they are practicing, then why are they not opting academia? I think I'm leaving this question for the discussion, and the experts are actually sitting over here, and this is something which is actually really alarming. So this is really good that over the period of last 10 years, there is an incremental trend among women, females who are actually opting for the gastroenterology. So I tried to find out that if I am ignorant, has somebody else has actually tried to explore what's the situation of training and opportunities for the women in GI. I could not find out much except one of the editorial which is written by Dr. Lubna, and she's over here, she can also comment on. So I then quickly decided about let's collect the perception of the trainees and the consultant. It's a very quick brief survey, anonymous one, which we quickly develop, and we try to find out what's the perspective of the trainees as well as the consultant about their experiences and the different things in the gastroenterology. So far 81 respondents we have, and all of these are like females, and you can see that 58% are trainees, and most of them are actually in their 30s. Majority of them among trainees are like almost half, I would say, not the majority if they are married, but 45% were single, and 64 or 65% were actually married among the consultant. So the number of kids, majority didn't have any kids, and most of them have only one child. So what's about the gender dynamics in their department? And again, you can see over there that the number of the female faculty is like average 8, ranged like this, and the female faculty average is like 2. The gender of the current head, 93%, almost 94% they are men. Good. So the gender dynamics among the trainees, so the male trainees, 6, female 3, which is like now, this is looking very good that at least 50% in different centers like the females are actually the trainees. So we wanted to know what their perspective. So we put the question in a neutral way to avoid investigator bias so that we are not influencing anyone as an investigator. We're putting the neutral questions for them and let's see that how they are actually, they look at the situation. So the female trainees receive equal training opportunities as compared to male trainees. So most of them, this is a strongly disagree, disagree, neutral, agree, and strongly agree. So this is the scale we use. And here you can see that most of the people is actually falling over there. So they disagree and strongly disagree, but 23% actually remain neutral. So how about that the female trainees have same difficulty in balancing the work and home responsibilities? No, most of them is actually don't agree with that. All right, so the female trainees receive the same recognition. And again, you can see that the bar is actually going on this side. However, almost 17% and 9.1% people feel actually they have been recognized. It simply means that yes, there are goodness existing in our society, but definitely there are some needs for improvement. Females receive equal research opportunities and 23% they agree, 12.5, 12.8% is actually they strongly disagree and strongly disagree, they remain neutral. 34% is actually felt that they receive actually a good research opportunities. Ergonometrics, was it a challenge? I don't understand why people opted for being neutral for ergonomics. I don't have any plausible explanation for this at the moment, but this is actually what was the response we have. The same difficulty in completing the skill training for the intervention, this was really very important question for them, for endoscopic procedures and all. And here you can see the response. Relatively more efforts, relatively longer time, they require to achieve the same competencies. This is something which is alarming. Same gender-based discrimination by the faculty. So, but the good thing is this, that there is no very high and very low bar. So it simply means that different people is actually have different type of experiences, but all sorts of experiences have been faced by the female. Lack of female mentors. So seems like few centers probably they have females, that's why these proportions are actually coming like relatively higher, but female mentors were available. Now the question comes in, when the female mentors are available, then why these females are not growing in academia and in leadership position? This is something which is a bigger question for us. Now look at is actually their satisfaction. So most of them remain neutral, and they disagree that that they are not really very satisfied with the situation at their workplace. How satisfied are you with the potential to achieve and the professional goal? And I was really happy to see this slide at least, because most of them, they felt they're reaching to some point. They're actually achieving their some goals, even in whatever the situation is in their institution. So overall professional training, how satisfied are they? So most of them is actually, they are, 38% felt that they are satisfied, they agree, strongly agree. However, 1/3 felt that they are not really very satisfied with the situation. How satisfied are you with overall research experience? 34% remain neutral. I'm surprised why, but a good number of people, they actually disagree and their research experience was not good. How satisfied are you with the ratio of the male to female trainees at your program? And here, the people are not really very happy. You can see over here. So the next part is really interesting. So this is about the GI consultant. So in the trainee's perspective, you can see that so mixed type of responses somewhere. But here you can see that in 2009, there are very few, and gradually the number of consultants are increasing and increasing. It's a good change. So the year of training completion between 2009 to 2022, most of them is actually have an experience around 4 years, ranging from less than 1 year even till 12 years. Female consultants feel gender discrimination. The most common response was a strongly disagree. Female consultants face the same difficulty in maintaining the work-life balance, strongly disagree. Face same recognition of their contribution towards the field compared to the GI consultant, disagree. And again, receive the same promotion opportunities and the leadership opportunities, strongly disagree. Face same difficulty in obtaining their grants and the fundings, remain neutral. This is again very surprising. Female consultants face same workplace harassment, strongly disagree. And female consultants are paid less, strongly disagree. Female consultants are more likely to have career interruptions as compared to males. They strongly disagree, but I thought that I'm not sure if they read this question appropriately or not, but this is what the response we get. So the female consultant face no gender discrimination, strongly disagree. Now here is the very interesting part. We question about that how many people are actually doing advanced endoscopies as an independent consultant. Now can you make a guess how many people are actually doing independent ERCPs in EUS? Make a guess for ERCP. Any nice guess? 10%. And EUS? So EUS independent, 0. ERCP less than 5%. So the satisfaction is actually was like very variable from difference. In the interest of time, I'm skipping very quickly, but many of them were actually falling between satisfied and satisfied and not really satisfied. So we look at the top that the representation of women in the different national societies. We can see that there is a little change with the passage of time. The women accommodated as moderator, chairperson, and the speakers is changing, but probably the pool is small of a consultant. In here you can see that larger number is actually was found in PSSLD as a speaker, but definitely the representation is increasing. In PSH, more or less similar trend, but less accommodated in the national societies. I think what my talk I try to emphasize is to give you some idea about that what is happening at the moment in Pakistan, but I'm still really optimistic. Someone who is a possibilitarian, someone who believes on taking challenges and on merit. So every single woman who is existing in GI, practicing GI, learning GI, you are capable and you have a potential, believe on yourself. Dynamics are changing. It's a good change. Growth is inevitable. You just need to be focused, persistent, keep yourself motivated, try to get your mentors, learn and excel daily, but this is very important. You need to be strategic if you want to excel. Still a long way to go. So thank you very much, organizers, for organizing this very nice symposium. But on the other hand, I'm quite impressed with the timing of this session. Exactly the Jummah prayers. So this gives you a situational, and you can do your analysis and you can conclude by yourself, but I'm leaving it as food for thought. Thank you.
Thank you, Dr. Amna, for a very comprehensive lecture. This concludes the lectures for this session. Now I would like to request the panel of experts for their comments.
Bismillahirrahmanirrahim. Thank you very much for the organizers who have taken interest in this topic, that the women in GI endoscopy. I've learned the views of the Fasiha. She has very extensively elaborated the situation in USA. The same situation almost has been elaborated by Amna Subhan in Pakistan, that how the women are being neglected. I am the senior most practicing gastroenterologist in Pakistan. I was initially trained for internal medicine. In 1985, I became assistant professor in medicine, and in late 80s and early 90s, I started taking interest in gastroenterology. That was the time when there was no formal training available in gastroenterology. There was no fellowship program in gastroenterology, which started almost in the mid-90s. So when I started taking interest and tried to learn endoscopy, there were no centers. So I was working in a unit where the senior person, he arranged a person, because there was a scope available in the unit, so he arranged a person who teach the endoscopy. I was also interested, but what happened one day when I went to the endoscopy room, the sister asked me that, "Madam, please, sir has asked me that you are not allowed to enter this room." So this was a big challenge for me, that I was not allowed to learn endoscopy. So this was the first challenge. So I accepted this challenge, and from that day I thought that I will learn endoscopy and I will be a teacher in endoscopy, and inshallah I will develop a system of training in Pakistan. And I took this mission. And my ally, I must appreciate the efforts that my husband was very cooperative. So we took this mission that we will make GI training in Pakistan as a first rank and training. So what I did, I started going to MH. There was a gentleman, General Ashad. I must appreciate his effort, that he's then taught me how to do endoscopy. And then I started, and I must tell you that it is a determination and your own willpower that will make you successful in this world of, basically in this world of men. And I started doing endoscopy, and I used to do endoscopies early in the morning, because I was as a professor, associate professor of medicine and unit in charge, I had to do the medicine work. So to take the time off, I start doing it in 8 o'clock in the morning till 9 o'clock. I do endoscopies and then the rest of the work. And this continued for a long time. And this effort, and then we started learning endoscopies and other procedures from abroad. And from east to west, we have been standing the whole day behind the people who are doing the procedures, because you know in abroad you can't do a procedure. You just can observe. So we keep on standing. And I remember the Massachusetts General Hospital, the days when we start at 8 o'clock and go at 8 p.m. in the evening, and there was no place to sit down. And then the staff nurse, Anna, then she put a stool there that you keep on standing, and at half time me's sit on that stool, and half time my husband, he sit on the stool, and we keep on doing, seeing the procedures, because there were many rooms. So we don't want to miss any procedure. So one room's finished, then we go to the other room. People who are doing the procedure, obviously they can take rest, they can take the lunch, they can take the tea, but we, for our greediness, that we don't want to miss any procedure, so we keep on moving the room to room. So the whole day passes, and sometimes we don't have even a glass of water. So this is the effort we have put in, and then we learned not only the simple endoscopies, colonoscopies, and the advanced procedures. And now for the, I must thank to the God that we have the biggest unit of endoscopy in Pakistan. I must say, and I can confess that this is the biggest unit. There are 5 rooms of endoscopy. There are 2 rooms of advanced procedures. There is radio frequency ablation available. There is EUS available. There is manometry available. Not only the upper GI manometry, but anorectal manometry is also available. There is laser therapy available. All these things, they are available, and we are having a very robust training program. And we have trained almost 20 FCPS in gastroenterology, and at the moment, out of 10 who have passed, 7 are the female gastroenterologists. And out of those 7 female, 5 are with us, and they all are doing independent ERCPs. They are all trained in independent ERCPs, and the next step will be they will be trained in EUS. So we are doing our best, but this is the story of hardship. This is a story of determination. This is a story of willpower. This is a story of sacrifices. You have to sacrifice. And I must say that how do you balance, because it's very important for all the females, that how do you balance your family? I must say that you have to do sacrifices. If you do sacrifice for your children, they respect your profession. If you don't sacrifice, then they start hating your profession, because the profession has taken their time. So you have to sacrifice for them, and I don't want to tell you, but how I work with my children, that I took them to school in the early morning, I bring them back from the school. It's just become a self-praising, but I never became late from the hospital. I never left hospital earlier, and I worked all day. So you have to be strong also. If you want to compete with a male person, usually what happens when we are doing a procedure, all the male, they sit down, but I never sit down, and I keep standing. So you keep your health and your stamina, that then you can only compete with your male colleagues, and you can get some place in this gastroenterology or any medical field like this. And I must appreciate all those women who are basically in medicine, because they are doing very hard. Medicine is a tough specialty. As such, medicine is a tough specialty where you have to sacrifice, and its sacrifice is not only that you want to get some name, but the sacrifice is for humanity also. So that's very, I just have to give this message that the situation is not so gloom. Inshallah, in future you will be seeing that female gastroenterologists will be available, because the training started were quite late, and then the centers, there were very few centers which were producing gastroenterologists. Now there are a lot of centers available, and a lot of females, they are starting gastroenterology. So inshallah, in future there will be a lot of gastroenterologists will be available as mentors, as examiners, as supervisors, and as practicing gastroenterologists. Thank you very much.
Ma'am Lubna.
Assalamu alaikum, everybody. The success of this symposium is that after my struggle of 15 years, we are having an independent woman in GI symposium in PSG, and this is the first time that the entire symposium is dedicated to women in GI. So now people are started recognizing women in GI, not only globally, but also in Pakistan at last. I'm seeing since the start of this symposium, the front seats are not taken by the females. This is your symposium. All front seats should be taken by the female colleagues. Why not? Why there is hesitancy of leading from the front? You have to lead from the front. And that is what Amna Subhan pointed out, that there is a gender gap, not only in Pakistan in leadership roles, but in US also. Because when women are asked to become leaders, there's always a question of 3 C's: capability, credibility, and capacity, basically. Quite constantly they are asked these 3 questions. And one thing that it's the Juma prayers, and the lunch was supposed to serve in the hall, and it is not served. So most of the people left because obviously they are hungry, since morning they are listening. So this is again that it's called a glass cliff phenomena, basically, to give position to a woman when the company or the hospital or the enterprise is about to move down, and then the blame goes to the shoulders of the women leaders that they were not capable. That's why the company had a lost or sealed out. Women in leadership has time in and time out, again and again, proved themselves, and COVID was a big example. Countries who were led by female prime ministers did better in COVID as compared to male, basically. So in Pakistan, there's a very, unfortunately, there's a concept of Dr. Bride. We see 85% of the females in the medical school, but when we talk about the workforce, it's just 1/3, and when we talk about the leadership, it's less than 1%, basically, because those are then trophy wives. They are not allowed to work outside, basically. Being a professor in my field, I'm the first professor in gastroenterology, it was not easy. The first question that I was asked in my interview, you have a 2-year-old kid, how are you going to do gastroenterology fellowship? So a woman with a kid cannot enter a gastroenterology fellowship. Why this question is not asked from men? Both men and women have equal responsibilities taking care of the home and kids. So why always, time and again, woman is asked this question? So we need to change, basically. There is a great man theory, basically, that the leadership suits to men. It's time to change. It's time to challenge the status quo. And I guess this is the beginning. Thank you very much.
Dr. Asma has joined us. I would like to call her on the stage for her remarks.
Thank you so much, and so proud to be here, and congratulations for having the first Women in GI session, and I'm honored to be a part of it. Thanks to the trailblazers, Dr. Lubna, Dr. Nuzhat, Dr. Jalpa, we're all inspired. So I'm sorry I couldn't be here a bit earlier. I definitely felt a little sick, but I'm much better now. So I did want to very briefly not reiterate everything that's been said, because we do know there's a vacuum for women in leadership. But what can we do to bridge that gap? So I want to give you some practical tips and some ideas of how we can break this cycle and succeed. So here are the top three career lessons. Finding your passion. What truly gets you out of bed every morning, and what motivates you? Is it clinical work? Is it teaching? Is it education? And then finding the right setting where you can actually be successful at those skills. And then finding a team which can help you succeed your goals. Oh, you're driving this? Okay. I'm going to talk about this theme about teamwork, because that's truly how I think we're going to succeed. And it's not just women helping women, but we also need our male colleagues and male allies. So finding your passion, how do you go about that? I think it's a fine balance of these 3 circles. It's a Venn diagram, and ideally the sweet spot is right in the middle. Something you enjoy, something you're good at, and then, you know, let's face it, something practical that pays well also. So what gets you excited? Is it a new endoscopy technique? Is it a patient encounter that went well? Is it a research question that you're very fired up about? Or is it truly teaching and engaging with trainees? And then finding a niche, extremely important. Think about obtaining advanced clinical training, teaching skills, or research skills. And then think about focusing your research into one area. It doesn't have to be a single organ. It can be an organ, it can be a disease spectrum, or it can be a broad area like epidemiology or cost effectiveness. But then figure out what skills you need and try to seek those skills, if not locally, regionally, nationally, or internationally. Your trajectory should make sense. So when you say, this is what I truly love doing, then it should follow, this is what I have been doing, and then where I want to go. And those are, fairly straightforward principles that will set you up for success. There's wonderful opportunities through multiple societies. I was asked to address, in particular, the US-based societies, but there's a whole variety of other ones also in Europe, UK, and Asia. So for instance, get in the habit of looking up some of these websites. It's completely free. And you can browse and see what opportunities are available. You'd be surprised how much emphasis there is to help women from countries like ours in succeeding. So for instance, this is American Society of Gastrointestinal Endoscopy. I'm a member of this. And they have a program where they pair a mentee to a very qualified team of mentors. This is a fabulous opportunity to apply to. And if you need help with letters or sponsorship, I'd be very happy to do it for you. But start looking these applications, be strategic, apply. Go after what you want and be proactive. The American College of Gastroenterology, I'm now on their board of trustees, and they also have a mentoring program. And this mentoring program, again, connects younger faculty to more experienced faculty. It can be in the areas of clinical work, research, or education. And that's another great way to make connections and network. I won't go over this because I think Fasiha addressed this, but there's even opportunities in American Association of Society of Liver Diseases, and you can see that they have multiple global outreach and engagement committees. So be proactive, click on these links, put in your CV, and apply for these positions. And that's a great way to get started. Everybody's looking for international trainees, particularly women. And then finally, I belong to the World Gastroenterology Organization. This is a great setting, and it's an organization of 53 other GI organizations from all over the world. And we have now a committee called the Young GI Committee. I'm the chair of that Young GI Committee, and we're always looking for motivated members. So please apply. This is a low-hanging fruit, and the application process is not tedious, but definitely will get you the exposure, the connections that you need to make that step. So I'm the committee chair, and this is my co-chair, Kavil. And you can see some of our members, including Talal Khurshid from Pakistan. And then finally, build your brand. Once you know what you want to be known for, collaborate. You can't survive in isolation. You can get more done faster if you collaborate and do teamwork. Make sure you network at events like this and others. Volunteer to give talks at your hospital, at local and regional conferences. Have a team of mentors and discuss with them what else you should be doing or could be doing. Find a peer group, whether it's writing manuscripts, writing grants, or learning new endoscopy skills. But a few words of caution: define role in collaborations, have timeline expectations, and practice moderation. You don't want to unload too much too fast, and so essentially you have to do it in small steps. Again, building your brand, knowing your area, having your interests broadly known, taking opportunities to write or speak on a topic. Serve as a resource. There's nothing stopping you from preparing patient education material, writing for your newspaper, or GI society involvement. And then finally, harness social media. And there's multiple social media avenues. For the sake of time, I'm just going to focus in on Twitter very soon. But social media is part of our life. And you can search for anybody on the web and see what comes up. There's no reason why you can't make a clip of a video and post it on YouTube. You can see there's a preparing for a colonoscopy, and it has over 6 million views. So is there any reason why you couldn't, highlight something that would be useful for your community? And that's a way to get known. Social media presence is, again, very important. I'll basically address Twitter, since it's one of the common medias we use. So again, this is another way to interact, network, find out what colleagues are doing, and also highlight things that you find enjoyable or are passionate about. And I've highlighted an article about how to get involved, how to get started. So if you don't know anything about Twitter, this paper is a great resource. What you don't want to do on Twitter is share patient information or start giving medical advice, no negative comments, and no political posts. And here's some winning examples. This is a very successful woman in GI and a colleague of ours. And you can see her expertise is education. She started a Monday night IBD case conference on Twitter, and she has a huge following. So that's one way to build your brand. Another example is, this is one of my mentees, Dr. Bilal, and he has a huge following because his big passion is, again, education and clinical pearls. So what I like to do, I enjoy clinical work, research, education. I enjoy the joy of discovery and the excitement of research. I really enjoy working with my colleagues, and I truly value the ability to mentor and collaborate. So based on those, I've engaged in activities which have led me to this point and continue my journey. So here's a future leaders group, education, clinical work, research groups, and our endoscopy unit together. So these are some of the things that I enjoy, and hence these are the things that truly define me and keep me motivated. Women in GI supporting each other. You recognize some people from the audience in this picture. We all got together in Dubai in December, and you can see how many of us there are from across the world. So there's no reason why you can't reach out to any one of us or all of the women in this picture and collaborate across the board. So take home points, find a niche area, get involved, get social, network, be a team player, embrace and enjoy who you are. Don't try to do too much, don't be all about self-promotion, and don't be negative about peers or institutions. And remember, the career we're in is a marathon, it's not a sprint. So pace yourself, be patient, and go after your goals. Thank you so much.
Thank you, Dr. Asma, for joining us. Lunch will be served in the grand ballroom, and before that, we'll take a quick picture in front of the photo booth. Thank you, everyone, for your participation in the symposium.
Next I request General Dr. Tasawwur Hussain Saab. He is Professor of Medicine at Foundation University Medical College, Islamabad. And I request Dr. Asif Abbas Naqvi Sahib to come to the stage. In Pakistan, abdominal tuberculosis is one of the leading infections in gastroenterology. I invite Professor Javed Iqbal Farooqi Sahib for a state-of-the-art lecture on abdominal tuberculosis and ongoing saga. Professor Javed Iqbal Farooqi Sahib is Professor of Medicine, Hepatology and Gastroenterology in Life Care Hospital and Research Institute, Hayatabad, Peshawar. He is ex-president of Pakistan Society of Hepatology from 2017 to 2018. I request Professor Javed Iqbal Farooqi Sahib for his lecture.
Thank you for the kind invitation and kind introduction. Okay, thank you. So the time has reduced. Okay. Okay, Bismillah ar-Rahman ar-Rahim. Okay, thank you very much. Thank you, Professor Ghayas and Professor Israr, for inviting me to this excellent academic program. When Dr. Israr rang me up to that Ghayas, when he wants me to talk on the abdominal tuberculosis and ongoing saga, correct me if I'm wrong, probably this is the only talk or only discussion on abdominal tuberculosis. It gives the impression that probably we are done with it, but when we look to the topic, the phrase they have made, ongoing saga, it means picture abhi baki hai mera dost. So I'll start with the quotation of this Charles Dickens, the English writer. What he described the tuberculosis as a dread disease in which struggle between soul and body is gradual, quiet, and solemn. The day by day, and grain by grain, the mortal part wastes and withers away. And I think this is true even today. The Hippocrates said about the abdominal tuberculosis as the diarrhea attacking a person affected with phthisis is a mortal symptom. Just to mention that in that era, in the era of the Hippocrates, the tuberculosis was called phthisis. The other quotation I'll share with you, the Joseph Walsh. It is impossible to diagnose abdominal tuberculosis with any degree of certainty, since the disease mimics many other abdominal conditions and histological confirmation may be equivocal. This was said more than 100 years ago, and still today it holds true. We all know about 1/4 of the world's population have latent TB infection. The latest figures from the WHO, still the tuberculosis is in the top causes of the death in the lower middle income countries. Point is, when 1/4 of the world's population has latent tuberculosis infection, people infected, these people, these 25% of the people of the world, they've got 5 to 15% lifetime risk are falling ill with TB. So this is alarming. Data in 2016 and 17, more than 10 million people, they developed tuberculosis, and around 1.5 to 1.7 million, they died because of this. This is the latest figures from WHO. TB remains the top causes of death in 2019. They assessed the TB infection with different parameters, and with all parameters, the Pakistan remains in the top 10 countries, whether this is the total incidence, whether this is the MDR and the RR-TB cases, or if this is the cross-sectional detection rate, Pakistan remains in the top 10 countries. So, saga means a long story of heroic achievement, rather series of achievements. So what, in my talk, I'll mostly discuss what we are knowing, what's the status of abdominal tuberculosis today, but I would like to look into the past, how this story started, how different achievements are what helped us in the understanding of this disease, and then we will look into the future, what are the possibilities. We all know human history, world history has got two components, the prehistory and the history. And believe me, the tuberculosis infection, it was there even in the prehistory era. It is known to mankind since prehistory times, as I said. It is believed that the genus Mycobacterium was present in the environment about 150 million years ago. An early variant of Mycobacterium tuberculosis was originated in East Africa about 3 million years ago and infected early hominids. Even it was present before this creature. So this is really the senior to us in this world. And growing pool of evidence suggests that the current strains, what we see today, they originated from a common ancestor around 20 to 15,000 years ago. So coming to the known history, what we know, and the first period is that of the ancient period, that is from the 3,000 to 500 years BC, and that is the Egyptian civilization. Egyptian mummies, dating back to 3,400 BC, they reveal skeletal deformities typical of tuberculosis, such as this one in the British Museum, London's British Museum, having characteristic signs of Pott's disease. The nexus were done, the mummy was having the Pott's disease. But interestingly, in all the inscripts, what we see, what are available to us from this Egyptian civilization, there is no mention about tuberculosis infection assay. Though we see that it was there, but they didn't recognize. The written documents what we see today, they are from the India and from the China. Like these documents from the India 3,003 years ago, when they mentioned the tuberculosis, and in China 2,300 years ago, they mentioned the tuberculosis. This was in the ancient era. What about the classical era that is from the 500 BC to the 500 AD? That is the Greek and Roman civilizations. They did contribute to our understanding of the tuberculosis. In the Greek, the tuberculosis was called phthisis or consumption. This was the old name. While in Rome, it was called tabes. What we see, the documents is there, the most knowledge comes from the Greeks. Hippocrates, he described as a fatal disease, especially of young adults. He described the symptoms of the phthisis, which are very similar to the common characteristics of the tubercular lung disease. The disease understanding was started from the lung disease. But till that time, the Hippocrates and others believed that the TB was hereditary in nature. They say it runs in the family. and probably this is the father gives to the children, the parents give to the children, and then they give to the onwards their children. It was Socrates who suggested that TB was an infectious disease, not a hereditary disease, and then Aristotle, he suggested that TB was contagious. It is infectious, and one person infects others. Then, again from the Greek physicians, that Galen, he described the symptoms of the tuberculosis as fever, sweating, coughing, and blood-stained sputum. On the Roman side, they did mention, but we don't get that much information about the tuberculosis. The most knowledge what we have from the classical era is from the Greek people. Coming to the middle area, that extends over 10 centuries, from 500 AD to 1500 AD, and this is called in the Europe as the Dark Age of them. And here, no significant advances were made regarding understanding of the tuberculosis. The Ibn Sina and Ar-Razi from Muslim side in that timings, both of them continued to believe that TB was contagious as well as difficult to treat. This was the whole understanding. It persisted over next 10 centuries. In the Middle Ages, yes, a new clinical form of tuberculosis was described as scrofola. We know it is the disease of cervical lymph nodes. In England and France, the disease was known as King's Evil, and there was a popular belief that the disease can be treated with royal touch, that the king will touch the neck of the patient and that will heal. The practice of the royal touch established by English and French kings continued for several years. Queen Anne was the last British monarch to employ these methods for healing. This was the French surgeon who suggested surgical intervention for this scrofula. So this was the first intervention to be offered despite the royal touch. Then again, in the 16th century, this was the Italian physician who in detail described that this is the contagious nature of the tuberculosis infections. So only a few, not that huge contributions to the understanding of tuberculosis was there from that period. We do see some development to our addition to our understanding in the Renaissance period, that is the 3 centuries, 1500 to 1700, and this is the area when there was the rebirth for the cultural, artistic, political, and economical understandings. This was the Sylvius. He, for the first time, described the pathological and anatomical description of tuberculosis in his book, Open Medica. And in 1699, Italian health law was made and issued by the Republic of Lucca, and officially they declared the nature of TB as an infectious one. This was our understanding that this is the infection public problem, and what they said that admission of tuberculosis patients in public hospital was forbidden. And specific places for treatment were established. This was in that Renaissance area. What we see, our understanding is in the modern and in the current area. The modern era is the 1700 to 1800, the 2 centuries. It was the Benjamin Martin who conjectured that yes, this is the infectious disease. Then the mortality was very high in that era, and mostly they were affecting the young people, and that's the reason it was called the robber of the youth. Extreme anemic pallor of the people affected by TB led to the new term for this, the white plague in that era. The name of tubercle was coined to the neccaseous necrosis by this Scottish pathologist in 1793. And this is the first evidence that yes, the tuberculosis can have extrapulmonary infection as well, and that was the Pott's disease, and he gave the first evidence that tuberculosis can affect or can go to the other organs as well in addition to the lungs. This was the understanding till the modern, that is the 17th, 18th centuries. What about now? What we are today, this is the results of so many good achievements. This man, Theophile the Laennec, he invented the stethoscope. He did a great job in that. He identified pathological signs of tuberculosis, including consolidation, pleurisy, and pulmonary cavitation. This is he who suggested, who identified that tuberculosis can infect the gastrointestinal tract, bones, joints, nervous system, genital urinary tract system. So the abdominal tuberculosis concept was given by him. We know the Johann Schonlein, it coined the terms tuberculosis to this disease. Then the Hermann Behmer, he gave the first the idea of the sanatorium, and he made the first sanatorium for these patients. The Robert Koch, this was the physician and microbiologist who successfully identified, isolated, and cultured tuberculous bacillus, that this disease is because of the tuberculous bacillus. This was he who gave the etiology of this infection. And of course, he was given the Nobel Prize for it. Then these two gentlemen, they give the tuberculin test. And nowadays we know this is the interferon gamma release assay, but the concept was given by those two gentlemen. Then these two gentlemen, they gave the first vaccine in 1921, the BCG vaccine. And thanks to the development of these two gentlemen and the lady who developed the streptomycin in 1943 as the first anti-TB drug. We all know in the next decade it was the isoniazid and pyrazinamide which were discovered, and in the another decade, in the 60s, the ethambutol and rifampicin. So now what we have today, this was, yes, the story, and everybody contributed to it. So what we know today is that extrapulmonary tuberculosis occurs in about 20% of the tuberculosis patients. Abdominal tuberculosis constitutes about 10% of the extrapulmonary tuberculosis. Gastrointestinal involvement is found in 66 to 75% of abdominal cases, and the terminal ileum and ileocecal region being the most common sites of involvement, and approximately 20% of cases of abdominal tuberculosis, they do have the concomitant pulmonary tuberculosis. This is what we know today about this disease. How we define? Don't confuse abdominal tuberculosis with only GI tuberculosis. This is the infection in the GIT, peritoneum, or intra-abdominal solid organs. This is not confined only to the GIT. We all know the main routes is by the ingestion of the infected food or infected sputum, hematogenous spread from the distant tubercular foci, contagious spread from the infected adjacent foci, and through lymphatic channels. These are the different routes how the abdominal tuberculosis happens. We all know that diagnosis of abdominal tuberculosis is a dilemma, a big, big dilemma. What was said 100 years ago, still it holds true today. We cannot be sure in each and every patient in these cases. So we get the benefit, we use the hematological tests, acidic fluid, radiological studies, biopsy histopathology, and molecular immunological techniques. Hematological, we all know that these are the very non-specific raised ESR, anemia, and hypoalbuminemia. In acidic fluid, typically tuberculous ascites, it has got protein more than 2.5, SAG is less than 1.1, TLC more than 500, predominantly these are the lymphocytes, ADA more than 40, and if PCR may be positive, it is subjected and the yield is there. Radiological studies, different modalities we are using. I won't go into the detail. The ultrasound, plain X-ray abdomen, barium studies, CT, and MRI. And the biopsy and histopathology, yes, they have got the very diagnostic role. And the biopsy can maybe through endoscopic GI, mucosal biopsy, image-guided percutaneous, EUS, or surgical. And this is the caseation necrosis, which is the pathognomonic of the TB biopsy sites. Gene expert has got its role, and the sputum may be acidic fluid, lymph node, thickened omentum, or mesentery. And this is the multiplex PCR. The target is the MPB64 or ICE 61140. We know that the abdominal tuberculosis may be of 4 types: tubercular lymphadenopathy, peritoneal tuberculosis, gastrointestinal tuberculosis, or visceral tuberculosis. Tuberculous lymphadenopathy is the most common manifestation of abdominal tuberculosis. We know that. The most commonly involved lymph nodes are the mesenteric nodes, the omental nodes, those at the porta hepatis, along with the celiac axis and in the peripancreatic location. And ultrasound is a good modality to start with, and it tells you that yes, lymph nodes are enlarged. Coming to the peritoneal TB, traditionally the peritoneal TB has been classified into 3 types: the wet ascitic type, that is the ascites, it may be generalized or loculated; fixed fibrotic type; and the dry plastic type. But remember, this classification is usually not adequate, and a combination of features are usually present in these patients. And we can take the help of the barium meal follow-through and the CT scanning in these patients. Coming to the gastrointestinal TB, any part of the GIT can be affected. The most common site is ileocecal location, followed by the jejunum and colon. The esophagus, stomach, and duodenum are rarely involved, but they do involve, like esophagus in up to 1%, gastric TB 2%, duodenal TB 2%, colorectal 10%, but the huge is the ileocecal and jejunal tuberculosis in these patients. In esophageal TB, barium swallow can help you out, CT scanning can help you out. In the gastric, endoscopy will help you out, like in this patient, it was pyloric obstruction because of the tuberculous infection. And of course, in the duodenal, the barium studies, the CT scanning, these will help us that where is the lesion and what is the extent of the lesion. Jejunal and ileal tuberculosis, as I said, this is the most common one, and 64% involvement here. Terminal ileum is more commonly involved in these patients, and the most common complication is lower bowel obstruction secondary to hyperplastic mural thickening, structure formation. But remember, tuberculosis accounts for 5 to 9% of all small intestinal perforations, but it is, and in Pakistan, is not uncommon. Morphologically, the lesions in the intestinal tuberculosis are either ulcerative or ulcerohypertrophic varieties, but the distinction between these two may not be sharp. And endoscopically, you can, this is the ileocecal part, endoscopic picture, and you see the ulcerations, the deformation, the hypertrophic form of this patient. And here again, the ulceration and structuring. Again here, these shallow ulcers. In this, again, the ileocecal area, these narrowing and the ulcers on that. Again, the narrowing and the ulcers in that. The barium the simple X-ray can tell you the subacute obstruction, the fluid levels, you can get the benefit of that. Different barium signs have been advised, suggested. I won't go into the detail in the interest of time, but the CT scanning and barium can help you out, and even the computed tomography images and the barium enteroclysis. All these help us in the identification of the ileocecal tuberculosis. Colorectal tuberculosis is again not uncommon. Around 10% of patients, they can have colorectal tuberculosis as well. Coming to the visceral, as I said, abdominal tuberculosis does not mean only GIT tuberculosis. These patients, they present with non-specific symptoms. Cross-sectional area, they can be they can tell you, and the involvement may be the solid organs. Genital unit system, again it's abdominal tuberculosis. The liver, the spleen, the pancreas, all these comes into the visceral tuberculosis under the heading of the abdominal tuberculosis. CT scanning will help us in these patients as well. Coming to the treatment, the medical treatment, we know abdominal tuberculosis is essentially a medical disease and generally responsive to medical treatment alone. Early diagnosis can prevent unnecessary surgical intervention. Surgery is indicated, and these patients go to our surgical colleagues when there is non-resolving intestinal obstruction, perforation, abscess, or fistula formation. We know the very good ATT regimes, the rifampicin as soon as it is ethambutol pyrazinamide, the consolidation 2 months, then the follow-up, and it's a good cure rate, more than 90%, but believe me, DILI is the main indication to stop ATT in these patients. This is what we see in our clinical practice. Outcomes of ATT, it may be complete response, patient may respond completely, or it may be recurrence. Once the patient responds and again the disease recurs, or it may be partial response, or no response even. Not as it may be the MDR or resistant tuberculosis in these patients. Endoscopically, yes, dilatation is possible, like in this patient, the gastric outlet obstruction they presented the patient with, and it was dilated with that. Surgically, there are 3 types of surgery. The first type of surgery is the surgery which is done to bypass the involved segments ballot in case of the enterostomy and transverse colostomy. But these surgeries, they are complicated by blind loop syndrome, fistula formation, and recurrent disease in the remaining segments, and hence usually not performed routinely. Second type of surgery, those involving the radical resection like a right hemicolectomy, and these surgeries are also hindered by the malnourished status. So again, not in practice too much. Third type of surgery is usually conservative, like structuroplasty, in which structure which causes more than 50% luminal compromise, they are relieved. Surgery is performed by and large in 15% of the cases of abdominal tuberculosis. Half of these are for the obstruction, abscess formation, or perforation, and half of these as a diagnostic procedure. What do we know? If I summarize that till now, and in this current, what we know that abdominal tuberculosis can be of various forms like peritoneal tuberculosis, tuberculous lymphadenopathy, GI TB, and visceral tuberculosis. Gastrointestinal tuberculosis usually involves ileocecal region, but it can affect any part of the GI tract. The symptoms of the abdominal tuberculosis can be non-specific. Various imaging features and radiological signs are used in making the diagnosis. High degree of clinical suspicion is required to make the diagnosis of TB in those areas like in Pakistan where it's, and even where you shouldn't say that it's only confined to the ileocecal. Any part, as I said, can be affected. Various molecular and immunological techniques are increasingly used, and GIT TB is generally managed with medical therapy. So, what's beyond? I shared with you the whole saga from the prehistory to the history. So, what's the future? We need to progress in the development of new TB diagnostics, drugs, and vaccines. Since the introduction of the BCG vaccine in 1921, very few novel vaccine candidates have advanced into clinical efficacy trials. We need to develop new vaccines indeed. Tuberculosis drug therapy, what's the progression? What's the future intervention? It's good that the last developed drug was in 1960s. So after the 4 or 5 decades, now the new drugs have been approved by the FDA, that is the bedaquiline and the delamanide. Multi-drug resistant tuberculosis and extensively drug-resistant tuberculosis challenge the public health with limited drug options. There are a good number of drugs in the pipeline. Repurposing FDA-approved drugs being used in other diseases can help us in getting these drugs at earlier pace, and effective strategies including nanotechnology, gene editing tools, and the host-directed bacterial killings are important. It's good that there are so many drugs in the pipeline. Conventional approaches are required, the new approaches are required, and we hope that in the coming So, the chairman, that's and colleague, the topic that was done is an ongoing saga. We saw that this story dates back to the prehistory era. Every period of the human history has contributed to its understanding, our understanding of this picture.
Mention detailed history of tuberculosis. In his state of art lectures, he covers all important areas of disease, including investigations, diagnosis, and prevention.
Which we have tended to forget over the last few decades. All the disease is still there, and we may have problems in the future also. The diagnosis of abdominal tuberculosis previously mainly on laparotomies, but now with improved facilities for endoscopic procedures, gene expert, and better facilities for CT guided biopsies and laparoscopic biopsies, the diagnosis is being made more frequently, and the patients who are diagnosed, they have a chance to have full recovery. So I think we should not forget this diagnosis when we are seeing patients with abdominal conditions, and because this is one of the treatable conditions, and if you can't treat it, then it can have serious consequences. So I would like to thank Professor Faruqi, who has covered the subject very well and has reminded us of some of the aspects.
Okay, with this we conclude the session. I will request Professor Faruqi sir and the panel of experts to gather before the photo booth for a picture.
Next expert is Dr. Altaf Bakir Saab. He is a consultant gastroenterologist and hepatologist at Medicare Hospital, Multan. Please come to the stage. Now I am calling the first speaker of the session, Dr. Faisal Basim Ismail. He is Associate Professor working at Section of Infectious Disease Department of Medicine, Aga Khan University Hospital. And his topic of discussion is role of healthcare simulation in medical education. जी.
खुद कर रहे हैं खुद ही कर रहे हैं चेंज करो आप कर रहे हैं या मैं कर रहा हूँ Bismillahirrahmanirrahim. Assalamu alaikum. Panel of experts, ladies and gentlemen, friends and colleagues. A very big thanks to the scientific committee for giving me an opportunity to speak about a subject that I think has been assuming ever more importance over the past 10 years. I think it's extremely important to talk about training the new crop of not only gastroenterologists but medical professionals. Just for the record, I'm a gastroenterologist. I'm not an infectious diseases consultant. No relevant disclosures as part of this talk. What I'll try to do for the next 5 minutes, for the next 20 minutes, is to talk about why we need to use more simulation, discuss the sound. 1 minute, I'm sorry, they've not put in the updated. Right, to continue. Right, so I'll be talking about the need to use simulation in medical education, why we should more be using it, discuss the misconceptions in simulation-based education, outline why it's important to use, and discuss the simulators that are available, particularly with the focus on GI training. And a few of the misconceptions I would want to address during the next 15 minutes is the fact that people still thinking, does it even work? Kare, na kare, kaam bhi karta hai, simulation kani. So that's one thing that I would want to address. The second thing that I would want to talk about is how people tend to think that all simulators are very expensive, and I would argue the case. Although if our rupee continues the downfall that it's been having, then perhaps I will not be able to say that they're not all expensive, but currently it's not correct to say that all simulators and simulation is expensive. The third is that a lot of people tend to think that just by using a simulator, you're using simulation, and that's not correct. Simulation is a way of delivering medical education, not just by the fact that you use a machine to use it. And I'll be talking a bit about why that's so important. So why do we need to use simulation? And we use simulation because it's valuable when on-the-job training is expensive or risky. And it finds its roots in military and aviation. We know that for the past 40 years, pilots have been training on simulators to develop their skills. And it's only when they are good enough and have learnt on the simulator do they actually get to try it on in a real setting of flying a plane. And yet we think that it's very important that pilots train that way because of the fact that our life depends upon it. But the people who take care of us and our patients, that is doctors and physicians, we've never really felt the need for them to be trained on a simulator before they start practicing or doing their work on real patients. A lot of the misconceptions that I also hear about a lot in simulation is that they will never take the place of a real patient. And that's absolutely correct. Simulation is not meant to take the place of a real patient. It will never happen. Simulation is meant to provide a risk-free and safe environment for trainees and trainers to practice so that the mistakes that you make, you don't make on a real patient. Like pilots and like aeronautical engineers, it's not meant that once they pass on the simulator, you give them a 747 to fly. Doesn't happen there, it doesn't happen in medicine. That's what I want to talk about. So most serious medical errors are committed by competent caring people doing other competent caring people would do. But unfortunately, that's where medical errors happen. And medical errors leading to morbidity and mortality is well known all throughout the world in both Western and Eastern medicine. And you think about it, the work that we do is extremely hazardous. It's hazardous not only because of the type of work we do, but the system that we work in, the medical devices that we use, the procedures that we do, which are getting more and more invasive and complex day by day. So the medicine field, particularly interventional medicine, is a loaded field with multiple areas where we can, for patient safety, is it compromised. And current medical education has difficulty in providing sufficient opportunities for practice. There is exposure to infrequent yet critical scenarios. Think about codes. Think about the patient who's hemorrhaging on the surgery table. How many times can you give your trainees the opportunity to actually practice that? We understand as educators that not all students and trainees learn at the same level, so you know that programs need to be tailored according to the individual needs of the trainee. Yet you're not able to do that with current medical education, where you have a group of 20 students coming to you and you deliver your content or the way to do a procedure, regardless of how much each has imbibed. There is patient variability and there's just feedback. Simulation, I think, has the answer because it would give you sufficient opportunities for practice, exposure to infrequent yet critical scenarios, and allow you to go back again and again and again. So you put in a CVC, there's a hematoma, no problem. Nobody is worried, nobody is concerned because no patient damage has been done. Gives you an opportunity to go back and practice again to develop mastery learning. Aristotle knew it when he said thousands of years ago that excellence is an art won by training and habituation. We are what we repetitively do. Excellence then is not an act, but a habit. And that's what simulation provides you, the opportunity to practice again and again to develop your skills, instead of making your mistakes and endangering your patient. And the need is because of increased focus on patient safety, the need for a new training model, not only based on apprenticeship. The apprenticeship model is what a lot of us have learned through, the see one, do one, teach one model. And we know that there are problems with that. When you do that, not everybody learns at the same pace, not everybody gets an opportunity to do all procedures. Some trainers are actually very bad, they don't know how to train. And a lot of that is essentially patient focused, right? If I'm teaching an endoscopy to a trainee of mine, the moment my patient starts to gag or starts to desat a bit, I take over immediately. And therefore that compromises the training of my participant. All of these things can be circumvented if you adopt simulation as a modality, because it's a safe environment, it's mistake forgiving. Like I said, you take a mistake, no problem, you can reverse it. It's trainee focused versus patient focused. The moment you are training your trainee, and the moment that patient starts to become unstable, you will immediately take over. And that will compromise not only the training of the participant, but also will dent them psychologically as well. It's a controlled, structured, proactive clinical exposure, so your trainee chooses when they want to do a particular procedure. It's reproducible, it's standardized, it's objective. These are wonderful words for an educator to hear. It increases the public trust in the profession and provides opportunities for deliberate and practice. But does it even work? It absolutely does, and these are just 3 studies that I've quoted here. There are tons more. As an example, ACLS written evaluation is not a predictor of participant skills. In gastroenterology, endoscopic skill improves significantly using simulation, even if you follow it by 12 months, and skills do not decay. And simulation-based educational programs significantly improve the quality of care during actual events. It's not a question of whether we should use simulation or not. I think we have enough data now to say that we do. What we as educators need to do to think where is the best niche for simulation, rather than debating in 2023 whether we should be using it or not. Just a few definitions for you to understand. A simulator is any object or representation of the task, while a simulation is the application of the simulator in a training program. Immersive simulation is recreation of the actual environment, such as making an OR or the ICU. A part task simulation is where technologies are used to only do a proportion of the portion, I beg your pardon. And fidelity means realism. How near to real life can you make it? And most of all theories in simulation will talk about, it talks about mastery learning. The acquisition of expertise requires sustained, deliberate practice with the intention to improve and change behavior. This is what simulation affords you. It will never, like I said, take the place of a real patient. And I don't want you to think of simulation as that way. I would want you to think of simulation as a modality that will allow you and your participant to pause, restart, and replay a clinical encounter and develop the skills to become masters at it. Many technologies used in medical education, from computer-based simulation to virtual environments, part task trainers, low fidelity and standardized patients. These are just a few of commercial GI endoscopic training systems. Like I said, I'm a gastroenterologist and I'm sitting among gastroenterologists, so you would want to use this. So you'll notice that there are 3 different types of simulators. There are mechanical simulators, there are ex vivo simulators, and there are those that use virtual reality. Now the mechanical ones are your most simplest ones. A large plastic box with a silicon-based model of the elementary tract inside and meant to simulate a particular task. So you can get EGD simulators, EMS simulators, and they'll take care of endoscopies, colonoscopies, upper GI trainers. All of these are either 3D printing-based models or silicon-based models made of plastic. Then you would get the ex vivo ones, which are actually animal models. So a part of the alimentary tract of the animal has been taken out and fitted into a plastic mold for you to do it on. A lot of us have probably trained on those while we were trainees as well. And those are ex vivo models. And a number of those, including the one that I have at the place I work, the Aachen University, which would be in virtual reality, which would mean that you have actual endoscopes and colonoscopes inserted into a computer-based system, which gives you a reality of the procedure. I'll pause here, but I'm not going to go into the details of it, because I think as educators and gastroenterologists, we get too hung up in the simulator. कि वो क्या क्या कर सकता है, उसमें क्या क्या हो सकता है. It's not about the simulator. It's about using simulation as a teaching methodology that's more important. And that's what I want to talk about, because what makes simulation beautiful are these three methods. A pre-brief, where you make sure that everything is in place for learning. So you give them the reading that they need to do prior to that, make sure that they're in a psychologically safe place to learn, remove all threats to learning. That's what a pre-brief is about, where you meet the group and you tell them what you're going to be teaching. The simulation is the scenario itself that you run, and there are standard methods of making a scenario. And the debrief, which is the reflective action leading to learning. And this is the soul of a simulation session. The main learning takes place in the debriefing, where you sit down with your trainees and you speak about what just happened and how could you make it better and how can they learn more. This is the process when I talk about mastery learning. What you need to do is determine the learning outcome of a simulation. So let's say I'm teaching somebody to do an endoscopy. Now there are steps to doing an endoscopy. It starts from taking a consent, to making sure sedation is in place, to making sure there is communication, from the insertion of the tube to mucosal, looking at the mucosa and taking the scope out. There are steps. You need to develop a learning objective and develop a checklist, make sure they go down this checklist, perform a skills evaluation, and participants who do not meet the minimum passing standards need to go back. And this is what you do in a mastery learning intervention. You go, keep repeating it until your candidate meets this. And then we have debriefing. The debriefing is the conversation to review a real or simulated event in which participants analyze the actions. And this is very important to do, because like I said, this is where the teaching happens. Now, as facilitators, we've been told that feedback is very important, and you've got to use the sandwich technique. So this is also a sandwich. I like your hat, your face is ugly, but your top is nice. But this is a terrible way to give feedback. This is just bad. And that is where there's the difference between feedback and debriefing. Whereas feedback is a single-minded, this is a single-driven directional conversation that you're having with your training, telling them what they did wrong or did right. Debriefing is a breakdown. This is an unpacking of what happened, where you talk about why they did what and how can they improve. This is the difference. Also, please remember, there is a difference between a debriefer and a content expert. All of us will tend to think that we are great debriefers. Why? Because we're good gastroenterologists. No, we are content experts. Content expert is a healthcare provider with advanced qualification and expertise in a specific area, and is only able to answer questions which are regarding the area of expertise. Whereas a debriefer requires specific training, and they need to be told how to uncover the frames of the participants. So it's a very different sort of person who can be debrief. Next content expert can be a debriefer, but it's not important that the content expert always is a debriefer, and there is a difference between the two. We need to move away from the two-part journey from being judgmental to debriefing with good judgment. And this is another very important foundation of simulation. When we speak of simulation-based education, it's about debriefing with good judgment. All of us are old enough to have learned from a teaching method called teaching with humiliation. I certainly have, and I'm sure I see my colleagues here are smiling, who know that the judgmental approach to teaching is the trainer feeling, get you to do the right thing and avoid the right thing because I'm the professor. I know it all. I think I know what went wrong because I have all the answers, and this is very important, and I get a lot of people which this resonates with. If I have to shame you or blame you into it, it's worth it. Because hey, you're doing medicine, you're becoming a doctor, and it's a tough life. You have to be tough. तो अगर मुझे बेइज्जती भी करनी पड़े तो ठीक है, कोई बात नहीं, बच्चा सीखेगा कैसे? This is something we need to get out of. This is a mindset that we as medical educators need to move away from. And this is what simulation will allow to do it, because a debriefing with a judgmental approach is contrary to what simulation is all about. So I think this is extremely important, because this is self-righteous and counterproductive. What we need to do is debriefing with good judgment. So nobody's telling you to be the good guy and not pick up anything that's wrong. Of course not. That's not what you need to do. You're a trainer. You need to pick out what is wrong and correct. But it's got to be done through the trainee's mind eye. Find out why they're doing it wrong and strengthen your ability to talk through the topics with your trainee and provide information, motivation, and application. One of the basic things we learn when we're learning about simulation is hold the basic assumption. The basic assumption is that you assume for all your trainers and trainees that you are here to do your best, you want to learn, and you are willing to give it your best shot. So hold that assumption about your trainee rather than thinking that this guy's just come here to waste my time. And it's only important that you will actually be able to implement simulation if you do a pre-brief, a good scenario development, and you stick to the principles of a good debrief. Please understand, using a simulator just for a task does not make you become a simulationist. So to conclude, simulation offers a wide array of learning and assessment opportunities. There's sound medical education data behind it, and like I said, please think about using it in the right areas. Don't think whether you should or should not be using simulation. We're way past that point now. Promotes patient and learner safety, promotes mastery learning, decreases the learning curve. That is the purpose of simulation. It's not meant to take over real patients. The greatest effect on sustained learning is through a blended curriculum. So you can't have people just doing simulation. You've got to blend it into the curriculum so they have a bit of cognition, and then they can learn their procedural or effective skills using simulation. And please remember, it's a learning environment, not a teaching environment. And what this means is that the focus is on your trainee, and your focus should be on to how to teach them and train them, rather than a teaching environment where you just go on a monotone of what they did wrong and how they should be doing it. This is the most important part about the simulation. Thank you very much for your attention, and I'll be open to any questions later on.
Thank you, Dr. Faisal Wasim, for such a good talk. Our next speaker is Dr. Ray McRudden. He is a gastroenterologist at Royal Bournemouth Hospital, University Hospital, Dorset. He is specializing in the hepatopancreatic biliary medicine, EUS and ERCP. He also works with the UK JAG in terms of validating teaching and training nationally for the endoscopy. And his topic of discussion is the advanced imaging in endoscopy. Please come.
Thank you. Thank you very much. I loved that talk. That was a tour de force of medical education rather than simulators, I think. Right, I'm just going to set, I don't know if I have a visual cue of the timer. I don't think I have. Okay. Thank you very much, everyone, for inviting me over here. I'm deeply humbled watching you guys scope and listening to you speak. It is a humbling experience. The amazing expertise of the home faculty is just blows me away every time I come over here. I've got two disclosures to make. The first is that I'm not an expert on this subject, but my main heartfelt one is to my friends and close colleagues, John Anderson and Pradeep, who kind of mentored me over the years about certain aspects of endoscopy, but also advanced imaging. So what are we going to talk about? We're going to talk about the new push-button technologies, but I'm not really going to go into them very much, and perhaps how we can use them to characterize the lesions. We've already had an amazing tour de force lecture this morning on characterization of polyps, and I will touch a little bit on this. So Professor Gias, when he did the inaugural lecture at the beginning of the endoscopy symposium, talked about certain dinosaurs who are old enough to remember what it was like learning endoscopy through an eyepiece. Thankfully, we moved on to fiber optics, and the new CCD processes, and then certain aspects of the service provision of carrying out the procedure, like chroma endoscopy from Japan. These were time-consuming, the learning curve was great, and that was in the context of low-resolution imaging. So vital stains took longer, they were a pain to use, and magnifying scopes weren't always available. Interestingly, fast forward to now, we actually use a lot of this in our department. So in the 2000s, entered the era of push-button technologies, and I'm going to focus on one. But we also have in parallel confocal laser endomicroscopy. And in case we don't think that everything is going to finish here once we nail this, there is a new kid on the block which is probably going to change the way that our lives are run socially, professionally, and in service provision of endoscopy and teaching. So in development, a number of people have characterized and published on the various areas, modalities. I'm not going to cover that. So NBI, FICE, iScan. So each of the different main manufacturers have their own companies. So for Olympus, which I think a lot of people here have, is NBI, or narrow band imaging. So what is that? So basically you take the 3 color filters and you take out red. And in so doing, you take your spectrum, your light spectrum, and you take it to here, to a very broad, very narrow range. So red is completely taken out. It skews the picture that you get, and all of the processes have to give you a little bit of color back, so that's artificially produced. So hemoglobin, for example, will absorb blue light, but because the red has been taken out, it will look much darker. It'll look very dark. Bile, for example, which has still got a yellow color pigment, will actually look like red. So the imaging enhancement essentially is about contrast. It's about blue light giving an opportunity to be able to, after filtering, to be able to look at things in a better way. The prerequisite of this, unfortunately, is you have to have good bowel prep. You have to have high definition imaging. So in English, picture, if you will, the 5-layer structure of the wall. You have the mucosa of the 2 layers, submucosa, muscularis propria, and the serosa apart from the esophagus. So really, if you're able to take out the mucosa mucosae and look into the mucosa muscularis, or even deeper, you start to get a feel for what how exciting this can be. iScan and FICE from Pentax and Fujinon are also alternatives. So why the interest? So the optical diagnosis is an important, and I'm going to take the paradigm for colonoscopy. Traditionally, we would send biopsies to the pathologist, but do we really need to keep doing this? If we are able to see clearly and really accurately describe lesions, perhaps we don't need to do this at all. But here's the challenge for someone like me who does colonoscopy but is not an expert. How do I differentiate between neoplastic lesions like adenoma, non-neoplastic, like hyperplastic, or serrated lesions? And how can I tell an adenoma from a serrated lesion? If I'm assessing and taking out a very big, scary polyp, am I able to assess the whole polyp and see an element of focus of cancer within? And this is perhaps where one area artificial intelligence is going to take over, whether we like it or not. I may think I'm a good teacher coming back to medical education, but actually, if the trainee can't get enough out of this from me, he may rely himself to be able to teach himself from artificial intelligence. So again, why the interest in imaging? Because we want to be able to see lesions and we want to be able to characterize them. The bowel prep has to be amazing. And as we've talked earlier about loop resolution, we talked in the endoscopy symposium about achieving better colonoscopies, underwater insufflation, etc. Really, the remit is to get to the cecum as quickly as you can and to use that short time to invest in a longer time in the withdrawal. So once you see lesions, what are you going to do now? What system are you going to use? How, do you learn them all? What is used in your peers and in your institutions? So in the kudos, we have pit patterns. And this has been widely adopted by many institutions around the world. So for example, if I've got so we're looking at pit patterns here. So this may be indicative of normal mucosa, whereas if we look at levels 2, 3, and 4, you're really looking at lesions. If you can recognize these lesions and describe them, these are lesions that are going to extend far beyond the most superficial area and actually extend into the mucosa. And then we get to 5, where we're looking at lesions which the pit patterns are completely disordered, and that may be indicative of invasion into submucosa. In learning this, and in learning things like simulators and taking these steps forward and learning how to become a good teacher and feedback, it takes an investment in time. Learning is difficult, and it actually involves good teaching, investing time to learn it and to learn systems. And then once you get good at it, to be able to detect and classify. So in developments, for example, in the Americans or the Europeans, certain classifications have been looked at to be able to classify these lesions. So if we look at the NICE system, where we're looking at building them, breaking them down into 3 different types. So on this section, we're really looking at vessel pattern. So the vessel may be invisible. So that might be indicative of a hypoplastic or a serrated sessile lesion. Regular caliber there, which is probably going to suggest perhaps a low-grade neoplasm like a tubular adenoma. And then we move into more disordered patterns, and down here, probably an invasive cancer. Another way of looking at it is the the color. So in the color, for example, in type 1, this is a narrowband imaging. The lighter polyp is almost indicative of a hyperplastic or sessile serrated lesion, and so on. So in the darker lesion, this would be a tubular adenoma. The cancers can be more difficult, so it could be darker still, or it could be a variation of dark and light. So here, using the Kudos system, you can see the pit patterns. Now this is using dye, and the issue with this is that you really do need the dye for it. So once we've got a description of pit patterns, what about how we assess it? So size and shape, morphology. So is it soft or mobile? Or does it have all the hallmarks of something quite sinister? Is it firm? Is it fixed? Is it friable? Does it bleed easily? Is it ulcerated? So in terms of the Paris classification, we've got type 1, which is the sessile, pedunculated, subpedunculated, and really this is more about describing, making an evaluation of size. For 2, it's about how does it look in relation to the mucosa. So is it flat? Is it very flat and difficult to see? Is it depressed? Depression of the lesion is high risk. Combining these, elevated and depressed, you may get a sense of what the high risk lesions are. Remember that you can get depression in sessile lesions as well, which is also indicative of possible tumour. So bringing it all together, what are we looking for with this advanced imaging? Size, are the folds tethered? What is the pit pattern? Is there a depressed component? And if you're suspicious and you lift it, what does it look like? So here, there's a lesion that's not lifting. Other polyps that we probably don't want to lift, so the pit pattern, as we've highlighted, type 2 lesions, ulceration, induration, etc. So here there are examples of very poor disorganization of the vessels and the pit pattern. Here on the right is a non-lifting sign. So for lateral spreading tumours, again, I think the challenge here is to be able to look at all of them and make a value judgment about whether there's an area of focus. So we've got granular, we have non-granular, we have lateral spreading granular typed here, and we've got non-granular here. Here we've got granular, but we've probably got extension beyond and perhaps below. Here we have an area of a polyp with rolled edges and central depression. So that's similar here, tumour. Tumour, I don't think this comes across well, but they're very disordered, almost amorphous pit pattern. And here I get the impression of tethering, and then when you lift that, you can see that it's not plain ball. So virtual chroma endoscopy does have an ability to be able to highlight some of these. You may identify the lesion, but it may help you to see the borders. It's faster than chroma endoscopy, but it does, like everything, need an amazing bowel prep. So narrowband imaging here. These are very pretty pictures, but do they mean anything? Do they help? So I think the patterns, at least for morphology, it's really about the vascular. So if it's dark and regular, if it's small, then we may be looking at an adenoma. If they're light and pale, or you can't see the vessels, could be hyperplastic. When they're dark and they're irregular or disorganized, then there's a high concern about cancer. And really the classification systems are really about these two things, at least for polyps. I want to finish on the lesions that scare me as a humble jobbing gastroenterologist doing colonoscopy. The lesion I'm petrified about is on the right side of the colon. That's a serrated lesion. Why? Because blink and you can miss them. If I'm Speedy Gonzales, I may walk right past this. They may be difficult to discern because they're covered with a mucus, and sometimes that mucus is very difficult to remove. When you lift them and you apply advanced imaging, you may see that there's more than one image, and now you get a better area, you get a better idea of the border of these. So the Americans have come, just like the Europeans, with coming off the fence in terms of how do we evaluate this? There are so many colonoscopies being done, there are so many polyps. So can we actually make a value in vivo judgment of whether this is worth doing? Is it worth resecting? And if it's worth resecting, do we need to send it off to the path lab, or can we discard it? So, and this is really about improving the confidence of the service providers across the country. So for the Americans, we're concentrating on small lesions and using validated index. For the Europeans, it's very, very similar. So in terms of discard, and I apologize for the spelling here, but to detect and inspect and characterize and resect and discard, the study looked at a number of things. Now this is all academic institutions. It demonstrated that in vivo diagnosis was possible using narrowband imaging. It suggested that it could be cost effective, and it proposed the resect and discard protocol. So if you're worried about a polyp, you're going to take it out anyway, but you may not need to retrieve it. So there are clear advantages of this. We're really talking about these lesions, 5. These lesions are much more high risk. So surveillance intervals can then be determined perhaps with a bit more confidence, maybe less work and cost for the pathologist, and maybe you don't have to retrieve these polyps. The problem is that I don't think we are there yet. So the second part of the study looked at taking these protocols from the academic setting into ordinary hospitals. And what they found was that using the NICE classification, it wasn't as great. The accuracy was lower, the sensitivity was even lower. And the conclusion was that narrowband imaging by itself is not going to be able to cut it for routine clinical practice. The issues are multifactorial. So getting general endoscopists like me to be able to learn and to be able to process this consistently is challenging, and to make a level, acceptable level where they're making judgments on polyps every day of the week. Training is an issue, and I think all of us across, particularly in the UK, are getting better at these, but there are certain other barriers to implementation. So in conclusion, there are multiple modalities for advanced imaging. What do we need? We need an amazing bowel prep. We need good colonoscopy technique. We need all the tips and tricks that we can to be able to get to the colonoscopy cecum safely, effectively, but quickly, and then to be able to use the remaining time to invest in looking for lesions. But we need knowledge. There's no point in being able to have fancy fandangled things if we don't know what we're looking at. We need to be able to identify accurately. We need to know if we're going to resect a polyp, that we're resecting all of it so that we don't get an interval cancer. And we need to be able to walk away. So I think in summary, this is really about mucosal enhancement. It's about using visual, peer-reviewed, published studies consistently, and it's about training and reducing that learning curve. Thank you very much.
Thank you, Dr. Ray. Very informative talk by Dr. Ray. Our next speaker is Dr. Arslan Kalu. He is a Chief Division of Gastroenterology and Hepatology, Associate Professor of Medicine, Program Director of the GI Fellowship Program, University of Tennessee College of Medicine, Chattanooga, Medical Director, Gastroenterology Services, Erlanger Health System. His topic of discussion is robotics in GI flexible endoscopy. Please.
Thank you for your kind introduction, and I'd like to also thank all the organizing committee to give me this opportunity. Thank you, Ray. So, just a quick snap by the show of hands. Two. So this is three. So this is definitely a new field in endoscopy. It's probably going to be getting a lot more traction over the years as artificial intelligence platforms become more and more common. And I think it actually helps to land into simulation also, as Dr. Faisal was saying earlier. This is an area where actually simulation would help big time in the future. I'm just waiting for my presentation to load. But it's an interesting area which is really going to bridge the gap between the surgery and the gastroenterology side of things, because really we're now at the level where we need to probably start collaborating between the two service lines. It's we've taken endoscopy too far and deep. Okay, is this any over? It is probably going to push the frontiers of gastroenterology and endoscopy to the point of inching close to where the surgery is. So I'm going to be talking about some of these platforms that are available commercially or in the making, or where the field is going actually in the future. So if you look at the brief history of endoscopy, we've come very far. The first endoscope was actually invented in early 1800s, and then the first endoscopy was actually performed in the mid 1800s, and then since then, we've made tremendous improvement in terms of how far we've come. The electric light source was introduced, then there was flexibility to the endoscope that was introduced, and then over the years, if you look, we have added deflection to the tip of the endoscope. We've started doing therapeutic procedures, so we moved from a purely diagnostic to an actual therapeutic procedure. Then came the advent of advanced procedures with ERCP. Then we started delving into artificial intelligence as early as in the 1980s with video capsule endoscopy. And then, multiple therapeutic modalities that have come on. So endoscopic robotics really started to kick off in the early 2000s, and that was the time that we were playing with NOTES procedures for people who are actually familiar with natural orifice transluminal surgeries. So robotics really, let me just go back. So robotics really, came to attention around the time when we were exploring NOTES in early 2000s. And really it was born at the intersection of surgery and gastroenterology, and that was the impetus to actually build more of this field. And if you look, and if you also realize how we perform mostly endoscopy, it's only one-handed. We're primarily using one arm to perform most of our endoscopy, and that takes a lot of physical toll, a lot of posture movement, and a lot of ergonomics that actually have come at the cost of just operating with one hand. Our surgical colleagues have been very smart. They have developed platforms which have been able to manipulate with two hands. So the one dimension that we really have been lacking is a triangular area of work. So we have not been able to achieve a triangulation in our work over these years that has led to so many difficulties in development in endoscopy. So if we talk about our contemporary endoscopes, we have realized with the advent of notes that there's several limitations to that. It lacks triangulation. We're only working in 2 planes. It lacks traction, and it lacks also counter traction. So all the third space endoscopy that has come to fruition now, it has a big problem with traction and counter traction. And obviously, with one very limited inflation source, we are not able to insufflate our field that we're working on. Compared to our surgical colleagues that, with laparoscopic advancements and some of the robotic platforms, they're able to insufflate, they're able to create a better field for them to actually work in 3 dimension. So these deficiencies that actually moved our growth away from nodes, mostly towards third space endoscopy, towards POEM and endoscopic submucosal dissection, where we're working actually in much smaller fields and in a smaller area, and we changed our instrumentation because of this limitation. But I think it's starting to make a comeback now, and I'll show you why. So if you think of ESD, it was created to create en bloc resection of higher risk lesions. That would help with more negative margins, lower recurrence rates compared to the endoscopic mucosal resection that we have been doing over the years. But if you really look at ESD or some of these more advanced third space procedures, the few things that really has limited the takeoff of this is because we have a very steep learning curve. It takes a long time to actually learn. It takes longer to actually do the procedure compared to some of the basic techniques that we do. It has very increased risks involved, including perforation, bleeding. It has very limited freedom of movement, where you're actually only working in 2 or 3 different planes because you just don't have enough space to actually work with in more dimensions. If you look at some of this, if this lesion, the way it is being resected, you lack a lot of counter traction. So you continue to do tunneling, which is submucosal, and that makes it a very tight space to operate. Also, earlier what I alluded to is lack of triangulation. You're working with one arm only, and you're not able to actually use both arms to actually create more planes. And that actually leads to frequent reorientation. That is one of the big issues in third space endoscopies, that you really have to keep figuring out where you are, what planes you're looking at, so that you can safely continue to dissect in a plane. So really, endoscopic robotic platforms came into attention to address some of these mechanical issues in third space endoscopy, in endoscopic suturing, also in POEMs and third space areas. So, talking briefly about different endoscopic platforms, so we have multiple that is actually available or in the making. So the very first one is this flexible robotic colorectal system. It is developed in the USA. It's a 2-piece platform. One is a platform which is a flexible robotic system where an operational console with a joystick, and that's where an endoscopist sits, works on a joystick looking at a 3-dimensional image, which is magnified, high definition, sitting on a cart and not even actually scrubbed in to the point that you can actually do it remotely. And then there's a second piece, which is the colorectal drive, which is this part, which is actually inserted at the bed, and it is a flexible robotic endoscope with a 3D camera, which is not something that we've seen in endoscopy previously, which is usually a 2D imaging that we get. And then it actually adds an extra working channel to get instruments in. So this is how it actually looks like. You have a system that actually you install. This system was actually developed to do transanal excisions up to like 25 centimeters. So this is a robotic system that actually gets installed into the rectum or at the anus, and then you move an endoscope, which is a bigger diameter endoscope than most of the flexible endoscopes, and then it actually have multiple different instrument channels that you can actually bring on the instruments out. And what it does, it actually it has the ease of move because it has the joystick maneuvering. You can move it sitting like playing a video game really at it, but it actually gives you a lot more dexterity, more precision, more planes to work with. And that is why it has actually helped us with lower perforation rates, procedural times, mental and physical workload compared to the standard ESD, which is very taxing. This has been successfully demonstrated in multiple procedures like Zenkers, ESD, endoscopic full thickness resection, and even suturing. However, it's not commercially available. It is soon to be hitting the market, but it's actually not available. It is FDA approved in the US and in the Europe, but not commercially available at this time. One of the other systems is what we call EndoMaster or E-system. I mean, if you look at it, it's actually a two-person robotic system. There's an endoscopist that inserts a scope into the patient, and then there's a second colleague who could be a surgeon who's working with two hands. And if you look, it's like a crab-shaped movement that you can actually do. And it actually helps with traction, which is a big issue in submucosal endoscopy. And actually at the same time you can have very easy dissection of the planes, as the endoscopist or whoever is performing sitting remotely. This does not even have to be in the same room. You can actually be doing it even remotely. So this is a system that goes over a double channel endoscope, very easy to insert, and actually can be more time efficient compared to a standard endoscopic mucosal procedure. So again, it helps with improved triangulation, dexterity, and haptic feedback, because the system also provides you with tactile simulation as well. The benefits of this, it actually gives you tactile sensation. It's a real 3D dimensional view. You have multiple different planes compared to, so you actually have 9 degrees of freedom compared to 2 or 3 degrees of freedom with regular endoscopy. But then it actually has some limitations as well. Inability to exchange multiple instruments because the system gets fixed into a spot. The large assembly size of the robotic system, inability to sterilize robotic arms so it cannot be used repeatedly, and sometimes it would require 2 operators to coordinate movements between them. However, successfully has been used in multiple third space procedures. Another system, which is actually an adoption from our surgical colleagues, an Endoscopy, which is regularly used by our surgeons for performing Da Vinci procedures as well. It is a scope that actually has a central part, which is a scope, and then the 2 parts that actually open up as extra aided tools that give you 2 extra working channels that you can work with, especially in tight spaces and things like that. Its production currently has been halted just because, there's been problems with this system with keeping air insufflation into the lumen. Now, this is one of the other very intriguing systems, which is the ELS system, again developed in the United States. It's a 2-part system. There's a cart with a joystick that an endoscopist can perform procedures sittingly, and there's a colibriscope, which actually is a much bigger channel scope compared to the regular endoscopes. So there's a channel that actually can get the regular endoscope out, and there's 2 other instrument channels that can actually get these 2 crab-like arms as extra hands to work with. 2 separate insufflation ports as well, and 1 suction port. So this gets you a lot more options to instrument in terms of the stuff that you need. This is how, like a practical demonstration, how this would work. You just sit at a robotic, console platform. You have a high definition view. You have multiple different angles of freedom that you can actually use these arms on top of a regular endoscope that is actually coming in this channel. So you have much ease of dexterity, much ease of use compared to multiple different positions that we have to get in when we're using endoscopes in some mucosal spaces. Now, one of the other, again, this is another demonstration of the same system that is being used, and just look at the ease of the use of, how you can track with 1 arm. You can continue to do submucosal dissection with the other Caesars on the other side. And just imagine how easy actually it gets. If we go further into this video, it actually has a video of how you can suture with 2 arms. It's like almost having to look at a surgeon suturing with and tying knots with actually 2 arms. And that has been a field that has been lacking in traditional endoscopy. And I think the advance of some of these platforms, and as more innovation gets more and more into this would really make its way in terms of improving the ergonomics and dexterity of all the more invasive procedures we do. So, this has definitely added tools to our equipment that we can utilize. You can add pinching forceps, monopolar cautery and knife, needle drivers, curved scissors, rat tube forceps, Kittery forceps, and operator has bimanual articulation of these robotic instrument with the foot pedal that can actually move the system in and out and can steer this colibriscope in and out of the patient. In the interest of time, actually, I'm going to move on. This is one of the very practical systems that was developed in China. It's sort of an overtube system that actually adds a traction device as part of the cap-assisted traction system that actually been put into place. It has 90 degrees rotation that can actually be used to track mucosa in difficult circumstances and in difficult situations. Again, it definitely adds more degrees of freedom, more angles that you can work with, but unfortunately it does require 2 operators, one actually handling the scope and one technician who actually on command base can use these devices open, close, and in different angles as well. Again, it is a very practical device that can be utilized for suturing, which is now becoming more and more common, including endobariatrics, submucosal tunneling, and even, taking care of the fistulas and leaks, that are complications of our endoscopy. So trying to wrap up, what are the pros and cons of therapeutic endoscopy platforms that are currently in practice? So if you really look at the pros, so it definitely gives us 2 arms to work, so it definitely helps endoscopists perform better triangulation, better traction, and better counter traction, which increases the efficiency, speed, and dexterity of the procedure. It has a bimanual control, which helps with the ergonomics. You're not just working with 1 arm, you have 2 arms to work in tight spaces. It increases your dexterity and precision of what you're doing. It decreases mental and physical workload, decreases procedure time, and decreases adverse events because it makes it less risky. It definitely increases proficiency for novice endoscopists who have a very long trajectory to learn ESD, and it may actually transform some of the submucosal field, if these platforms make into the mainstream. However, the cons are it is a larger device, the learning curve obviously is there, and the setup and turnover and the cost effectiveness all have to be taken into account. So, if we look forward, where are we going? I think artificial intelligence, as Ray was pointing out, is going to make a big impact in whatever we do. So just imagine if we can merge machine learning, which is artificial intelligence, along with robotics, and how far we can get with all of this. Just to show, this is a platform that was actually developed with our partnership at one of our sister institutes in Tennessee. You can actually now have autonomous systems performing colonoscopy, and this is going to be coming into the market very soon. This is a magnetic arm, completely self-learned, based on artificial intelligence, who can guide a scope which is much smaller than a regular endoscope. All it requires is a proceduralist to actually hold it, and the artificial intelligence system actually guides you through a robotic system that has been pre-learned to complete a full endoscopy. These systems have actually already shown in vivo models that you can perform pulopectomy, you can perform EMRs, targeted biopsy using artificial intelligence-based systems. So this is very near. It's probably coming within the next 3 to 5 years. Now, one other important field is teleendoscopy. We've talked about telemedicine, we've talked about telesurgery. Just think, how teleendoscopy and artificial intelligence can all be mixed together. We're actually, as gastroenterologists, behind the curve. First, robotic telesurgery was done in 2001, where a surgeon sitting in New York actually performed a laparoscopic cholecystectomy in France on a patient within 45 minutes through satellite, through all these platforms that are available, and successfully has been shown to be done by multiple advanced militaries in the battlefield injuries with trauma and stuff like that. NASA is already planning to send robot stations into the space, so if there's any surgical needs into the space, these can be operated from the ground, performing surgeries into the space using some of these platforms. So what does future look like for us as advanced endoscopists? This is where we are. We're having to be in awkward positions. Our, backs and necks are twisted all the time. Wrists is bent, twisted. We go home tired with injuries and things like that, leading to, after repetitive movements, and maybe, the robotics could be an answer to this, and maybe our future will look like, this, where you're sitting in your bed and using a joystick to actually perform a procedure. More realistically, maybe this is how it would look like, where, you have robotic stations, just like all the Da Vinci robots that the surgeons use, and, a patient that has a robotic system attached, and you're performing out of here. And also, maybe this is the times to come. The robots are going to make a big dent into the field of medicine, and maybe, we should be starting to look like all of this. Well, thank you so much, and I'll take any questions at the very end.
Thank you, Dr. Arslan Kalu, for such an interesting talk. I would like to invite my next speaker. He is Dr. Pareet Makroon Kamol. He is Assistant Professor of Medicine, Division of Gastroenterology at Advanced Endoscopic Excellence Center, King Chulalong University, Bangkok, Thailand. His topic of discussion is the artificial intelligence in the GI endoscopy.
Thank you very much for the kind introduction, and thank you for having me back. It's very futuristic of Dr. Kaloon's talk just now, and with Dr. Raymond's talk earlier, everyone was like, oh, how can we gonna navigate through all of these, the concept of image-enhanced endoscopy, all of these guidelines, on how to classifications of each polyps and so on. So don't worry no more, even though you don't have the luxury of having a robot to help you yet, but let's talk about something that's available now, which is artificial intelligence. So AI can help you with a lot of things, and now it's coming to endoscopy field. Even though we probably don't have to be as scared as pathologists and radiologists at this point, but AI is gonna take over some of the endoscopist's task in performing endoscopy. So let's talk a bit more about what is AI. So the concept of artificial intelligence has been around for quite some time now, since 1964, where first chatbot Eliza happened, and until now, where we have like ChatGPT, we have a self-driving car. This is something that gonna revolutionize the field of medicine as we know it today. So this is the outlines of what we're going to talk about today on what is AI and what's the current technology and what the future looks like on AI and endoscopy. So the definition of AI is the ability of algorithms and mathematical models to recreate a natural intelligence and decision making. And that something sounds simple, but it's not so much, because how do we gonna encode the program in order for us to learn by themselves and improve the outcomes of it by themselves. And that requires multiple layers of what we call a machine learning and deep learning issues. So when we talk about machine learning, it's the ability of an algorithm to infer and learn the pattern of data set. So basically we give them the data set of what we wanted to learn and to make predictions about other unseen data. While the deep learning system is a complex neural network where you have multiple layers of each machine learning to categorize and create a new background of a new body of knowledge by itself. Let me kind of just simplify that, of what I meant by that. So for example, if you have a dog, like my 2-year-old son is, really crazy about dog right now. So every 4 little things that he sees, a tiger, a cat, and he keeps saying that that's a dog, right? So basically, what he's trying to learn is each areas of what contributes into making something a dog. That's basically the same concept. So the neural networks are complex model created by having multiple layers involved. So that each layer might be something simple as, oh, this is a nose. So you have your 2 holes. This is what an eye look like. Something kind of crystally, like glassy looking on the face. If it has like 4 legs, and all of these combined makes it becomes a dog. Same thing. That deeper layers of what creates into one object, and each object becomes a face, and a face and a legs becomes a dog, has been integrated in what we put on a learning method for our AI. The learning away of AI, besides the machine learning and deep learning, is also supervised learning and unsupervised learning. The basic concept of supervised learning is that something we feed the data into. We say, yes, this is A, this is B, and this is C. And have the unsupervised portion of the learning system saying that, oh, well, maybe even though this is not an ABC, this can be a numeric number, this can be 1, this can be 2. Oh, this is not a Latin number, this is not ABC, this is not 1, 2, 3, but this is actually a shape. So having multiple data set inside that system can create a new body of knowledge that it can learn by itself, and that's the whole concept of what we're talking about on AI to these days. So the current technology that we have here has been a sharp shooting of a burst of new technology involving AI. When you go to PubMed and you see the publications in AI, like 4 or 5 years ago, this would be something groundbreaking. But not today. Nowadays we have a lot of publications emerging from everywhere in every field of medicine involving AI. So it is important for us to be able to navigate through that publication and say which one is a concept that is worth believing and which one is a concept of promising that can evolve into something else. The concept of overfitting refers to an algorithm of neural network works when a training data set is applied but not on the external data set. So in a way it means that we have a product but we need a means to evaluate that efficacy of such product. Right. So certain data set, especially when it's so small, when it's super concentrated, meaning it's very homogeneous, when it's unreal data, it's not something that reflects the real world practice, those can create an overfitting issue. So it all comes down to what type of data set you're feeding into the artificial intelligence. So normally what we talk about is, when we're developing AI, we talk about the training set, validation set, and testing set, and then the external validation. The training set is the biggest set of all. Whether AI is effective or not, or whether it's reliable or not, depending on the training set that you give them. Also, the validation set that you have an input outside of that training set plays an important role. So this data sets comprises of makes of initial development, then fine-tuning your AI system, and then evaluate the performance of each AI system. For example, the image augmentations, when you give an AI to learn what a lion looks like, you want to give them multiple angles of the image of the lion, so that the AI can detect that this is a lion even though it's looking it from the left or right, or the front or the back. Same thing with polyp detection. You need multiple areas, multiple angles, multiple types of polyps so that the machine can learn what polyp this is and it can help detect the polyp that we are talking about. So multiple AI system has been commercially available. The computer-aided detection and computer-aided diagnosis system has been recently developed by Fuji company. But besides CAT-E and CAT-X that we used to, there are multiple artificial intelligence system on colonoscopy, and this has been evaluated and well versed in multiple publications recently. Because the colonoscopy that we know it today is not a perfect tool. It has a lot of misread. It has incomplete resection, therapeutic options, detection, and classification. And the majority of these interval cancer, interval misread, can be preventable and can be improved. So this is the concept of adenoma detection rate, where to evaluate whether you are a good enough endoscopist to detect such polyps or not. Normally, I'm not sure if everyone in this room know how much your ADR is, but I encourage you to try to. And this is kind of a fun exercise to do, to kind of figure out how much your ADR is. If you're lucky enough that your unit is kind of monitoring you, you can know how much, where you are at in terms of detection capacity. The threshold of acceptable ADR is usually roughly about 25 to 35%. But that's clearly not enough. We have a master level of experts level who has ADR as close of 50 to 60%. So we know that each colonoscopist is not the same. So how we can generalize and standardize such maneuver? The skill sets need for polyp detection requires exposure, meaning looking, and perception that this is actually a polyp. So that's the seeing. So the exposure portion, we have multiple devices available, including the cap, the endocuff, the GI, the wide angles, that has been explored in the past. So this is kind of a little fun exercise that I like to invite you all to play. So how many polyps are there in this video? Okay, you ready? 1, 2, 3. Okay, it's a very short video. Anyone see anything? We'll get back to that. So now we're using the endocuff on the same patient, on the same segment of the colon. Okay, now so we can flip all of the folds, see everything. Okay, you ready? 1, 2, 3. Okay. Who says no polyp? Who says 1 polyp? Who says 2? 2? 2. Okay, this is 3. Who says more than 3? Okay, your ADR is probably in a good range. Well, we'll get back to that video. So the visual enhancement of the seeings has been detected used in augmented by AI. So image enhanced endoscopies, I'm not going to go deep into details on this because Dr. Ray has a remarkable talk, a lecture on this already. So basically we're giving a contrast to what we see, multiple commercially available, including NBI, BLI, iScan, and FICE, and so on. It can help you detect polyp and give contrast to the polyp detection. Some study, there we have like kind of mixing verdict on this. Some studies say that IEE can really help enhance your ADR detection rate. Some studies says no, it only helps you with your novice trainees. But if you're already experts already, having non-white light IEE might not be that helpful. So how about a CADI, the AI augmented detection? So usually what AI can help you is that it creates a bounding box to say which area is abnormal. So we're teaching them what is normal, and when something abnormal pops up, it helps you detect that area. So it is something like this. You don't really need an AI to tell you that this is a polyp, right? It's popping out into your face. You know what it is. But it shows you the way it works. Multiple AI systems are now commercially available. The CADI, the EndoBrain, the GI Genius, CADI. All of these systems are sometimes built into the scope. You have to buy the scope, you have to buy a system, or it can be an external system that can be used with any scope. So now coming back to that video, so now we have EndoCuff plus AI. We're going to turn the AI on. Okay, so how many did you see? That's right, so that's 2. So there's 2 polyps in that video. So now you can see that even though there's EndoCuff and that's AI, that's really help you see these little polyps that might be blending in and that naked eyes or untrained eyes might not be able to see. So AI does work, and it does increase the ADR, and it's been proven in multiple studies before, especially for those with novice trainings. Already low ADR. If your ADR is already 60, it's going to be hard to improve that. But if your ADR is at 20 or 25, it might not take much to improve that range. Fatigability is also one of the downside and disadvantage of us endoscopists. There's this is an interesting studies comparing between a morning colonoscopy and afternoon colonoscopy. If you're doing a tedious procedure like in your large polyp ESD at 7 p.m. while you don't have lunch or dinner, your blood sugar is 60, your wife keeps calling you, you might not be able to perform that procedure with your full potential. Same thing with, when you have you need concentration to find little polyps, AI can help reduce that fatigability. Modalities to improve colonic polyp detections, like what we mentioned before. This is a nice study published last year in Lancet. Comparing between mucosal exposure device, chromoendoscopy, and AI's augmented system. When compared to mucosal exposure, AI has better performance significantly. Same thing with chromoendoscopy, and both chromoendoscopy and device exposure device has no significant difference. So this kind of shows you that AI can be really helpful. The comparison between AI and in endoscopists who already have high ADR, roughly more than 30 to 35%, we also found that you can still have a higher increased ADR rate when you have combined AI and mucosal exposure device, meaning that even if your ADR is already high, it can still go up depending on what tools you have available to help you with that. Okay. So moving on to other diagnosis part on the detection part, not just colonoscopy, on upper endoscopy front, the gastric intestinal metaplasia is something that we can also help detect with AI. This is something that we used, we call segmentation, because the gastric intestinal metaplasia can be very subtle and doesn't have a good border as opposed to polyp. So AI can help you detect which areas is abnormal, but as you can see, there's a lot of false positive. There's a lot of bounding box that can make your eyes more fatigued and be more than a nuisance to your endoscopic procedure. The dissect and discard maneuver, like Dr. Ray mentioned earlier, even though it has been proven in literature, but not a lot of people have adopted that, and mainly because there's a fear of incorrect surveillance interval assignment. So if you resect and you don't send that polyps to pathologists, you might be afraid of medical legal issues that comes after. And that's because you're not sure of what you see is actually hyperplastic polyp. So that's an area where AI can help you with that. A recent ABC study published last month showed that when you have expert and non-expert endoscopists, you have an AI to improve to help with your colonoscopy, especially for non-expert endoscopists, that can really increase the sensitivity and negative predictive value of how you characterize the polyps, whether that polyp is adenoma or hyperplastic polyps. So this means that if you have doubt on characterizing the polyps, or if you have some reserve of doing a resect and discard technique, the AI can help you with that and say, and when AI has some confirmation that yes, this is hyperplastic, it doesn't have neoplastic ability, the potential, you can safely resect and discard that, or you just don't have to do anything with that at all. Going outside the other areas of colon and GI, for example, with cholangioscopy, there's multiple studies evaluating the potential role for AI to help you decide whether this is malignant or benign strictures when you do a cholangioscopy. Because cholangioscopy images is not something that you see every day by everyone, so having this can be very helpful for us endoscopists. Beyond this area, AI can help you with management issues. For example, if it can help decide what depth the lesions is, it can tell you whether this lesion needs to be resected by EMR or ESD or surgery, for example. Another area is something called a CAT-Q, which is quality index for AI. Many of us have done this before, saying that the prep was fair, the prep was inadequate, we don't give a full 10 years for the patient. Well, AI can help you with that. It can see how much stool is left inside the colon and whether this is adequate or inadequate colonoscopy. So the future of AI requires three things, whether it's transparency, explainability, and provability, that AI has to, we have to be able to justify why we're using this algorithm and why we're using this system. Because remember that even though it says AI, it's just a concept. And many systems have been developed, and we don't have a gold standard to prove which system is the best for us to use. So many of us might have the means to buy or have the AI augmented colonoscopy. The in-house developed AI is something possible too. Our unit has explored into this idea and have our engineering team help us develop AI. And Lord behold, this requires our engineering team less than a year to develop our in-house AI system, mimicking what's commercially already available. We call this Deep GI. And we have a training set and evaluation form comparing between Deep GI and other commercially available AI system, and we found that they are quite comparable. So now we have the tools, we have the means to even develop our own AI system. So it's whether the question of do you believe it or not. We all have seen the self-driving car, but are you brave enough to be in the car blindfold and have the car drive you to work? So that's the same concept of what current of the status of AI at this point. It is good, it's going to change our practice, but it is something that you're going to believe it wholeheartedly or not, or it still needs something that needs assistance from us physicians. The emerging fields in AI comes with GIM detection, biliary lesions, depth of invasion, other quality of endoscopy. As my good friend once said yesterday, it is such an exciting time to be a gastroenterologist these days. So with that, I would like to close my talk and welcome any questions. Thank you very much.
Thank you, Dr. Preet. A very good, very informative presentation. Now, any questions from the hall are welcome. There is a mic in the center of the hall. Anyone wants to ask a question, come to the mic.
Assalamu alaikum. My name is Dr. Sadiq. My question is with Dr. Faisal Saab. Can this simulation I have been to the mechanical simulation during my training, and it was initially a good experience before going to the patient. Can it be used as a exam tool as well, or only teaching tool?
That's a great question, Sadiq. And so when you say exam tool, you mean summative assessment as opposed to formative assessment, which is for practice and training. Yes, it can be used for summative training, for exam situations and high stakes examinations as well, but there's a process to follow. The process to follow would mean that you would have given an opportunity to the trainee to first practice on the simulator, have gone through the checklist with them that you will be using as a trainer, where you've trained them on the simulator, so they would have seen the checklist, they would have gone through it, you would have given them an opportunity to go through it. If you've done that before, you can use a checklist and you can use it for high stakes examination as well. Thank you.
Any question? Okay, any remarks from the panel of experts?
It was an excellent session, and we had some beautiful talks. Dr. Faisal Wasim, he touched upon simulation, and I think this is the area which we have to focus in Pakistan, and we have to develop more simulation labs in training centers, and as trainers we should try to develop these labs for training. Dr. Raymond, he talked about advanced imaging, again a beautiful talk. Dr. Arslan Kahnu, it was an awesome talk regarding endorobotics, and in future probably the role of surgeons and gastroenterologists may be modified by the development of this technique, and endorobotics may be much more in practice. And last, Dr. Parith, he again talked about AI in endoscopy, which is upcoming, and we should have more insight in this area as well for the detection of polyps and for our procedures. Overall, I think it was an excellent session, and we all are grateful to the speakers, and we are grateful to the audience and all the people who are present here. That shows their keen interest and being so avid learner. Thank you very much.
Thank you, Dr. Farooq Saeed, Dr. Altaf Bakar, and Dr. Fazal Khwaja, and all the speakers. Please come to the photo booth for the group photo, and we'll be back after a tea break at 5:15 for the inaugural session. Please come back at 5:15 sharp. Thank you.
Recording stopped.
أعوذ بالله من الشيطان الرجيم بسم الله
Assalamu alaikum, sir. पोजीशन ले लो आ जाओ पीसी हो गए दसाना